estrogen has a role in the pathophysiology. None of these are proven to be cause and effect relationship. But what is well known is that it's a T cell mediated disease. So the pathogenesis is thought to be brought by an unknown antigen that trigger a cascade of an immunological event that will result in the giant or multinucleated giant cell picture of the arteries. So what are the clinical manifestations? We have musculoskeletal and we have constitutional or non-specific. Regarding the musculoskeletal, you will have back pain, shoulder, hip pain, and jaw pain, also arthritis or arthralgia. Regarding the non-specific symptoms, it may include low-grade fever, fatigue, weight loss, anemia, lymphadenopathy, and even depression. The vascular event will be in the form of claudication, as we talked about the definition of claudication. It could be in any limb affected, and the reduced or absent pulse of the artery affected. So the orofacial symptoms, as we said, it's a new headache in the temporal region. There is tenderness when we palpate the temporal artery. The temporal artery appears tortuous, thickened, irregular, and with tenderness. Also, we can have jaw pain or jaw claudication, and actually, jaw pain or jaw claudication and temporal headache are the primary symptoms where the patient will seek oral health care providers. So it's important for oral health care providers to know these signs and symptoms in order to prevent serious complications. So if the lingual artery is affected by the pathological process, we will have a blockage of the lingual artery, then we'll have ischemia and even necrosis of the tongue. Also tongue pain and difficulty moving the tongue, difficulty swallowing, and even toothache-like symptoms may appear in these patients, depending, of course, of the site of the artery affected. For example, if the patient have involvement of the ascending pharyngeal artery, he will have difficulty swallowing. Regarding the ophthalmological manifestation, this is a serious complication. About two-thirds of the patients will have manifestations in their vision, and it will be in the form of blurred vision. If it's severe enough, it will result in blindness, and unfortunately, it's irreversible, and this is due to ischemia to the optic nerve. The histopathology, we talked, this is the temporal artery biopsy, and this is the lumen, this is the RBCs here, and the black arrow here reflects the inflammatory process and the granulation, the multi-nucleated giant cell. This will cause thickening of the tunica media and narrowing of the lumen. One thing that is very important to clinicians is that half of these biopsies will come out as a false negative, and this is because of something called skip lesions. So skip lesions is when you have a biopsy of one segment of the artery that has all the histopathological manifestations of giant cell arteritis adjacent to a segment that is completely devoid of any abnormal findings. So if you take a biopsy from the normal looking part of the temporal artery, you will not find any evidence of GCA. So usually they will take multiple biopsies. Management is basically corticosteroid high dose, but recently the FDA approved a medication which is a biologic called tocilizumab, which is basically interleukin-6 inhibitor. Interleukin-6 is a marker or a cytokine involved in inflammatory process. So when we block this cytokine, we will have relief of the inflammation and the symptoms. Unfortunately, we don't have any protocol of the drug use. The main thing we want to do is to prevent any irreversible complications like vision loss or even stroke. As we said, complications will include stroke, blindness, any end organ damage, depending on the site of blockage. If the brain is affected, we will have cognitive impairment, seizures, and even depression. And if the lingual artery affected will result in necrosis of the lips and the tongue. So actually this patient now Mr. X is under the care of oral medicine and rheumatology because he also found to have a polymyalgia rheumatica. Now we will move to our next patient, Mr. Y. He's 32 years old male, presented with right jaw pain, also with earache and difficulty swallowing. He had several consultations with ENT specialists and endodontist, and he said that his ear ached for about 6 months, and he feels pain, jaw pain, and difficulty swallowing. He said that the pain is electric-like, but sometimes it feels like poking sensation when he swallows, and other times the pain is constant and dull. The pain increases while moving the head or the neck to the right side or when swallowing, but painkillers didn't improve the pain. His past medical history was non-contributory. He had surgery, tonsillectomy, as a child. No known allergies. He's married with 2 children. Regarding the social history, he smokes 1 pack a day of tobacco for 15 years. No alcohol, no recreational drug use, and he's a military guy. Regarding the physical exam, everything extraorally and intraorally were within normal limits. The TMJ focus exam, the opening 30 millimeters and normal excursive movement, except that the patient feels pain when he moves his lower jaw to the right side. No joint sounds, and regarding the muscle palpation, everything was within normal limits except with pain when moving the head to the right side and moderate tenderness of the sternocleidomastoid muscle. So this is the OPG for this patient. Do you notice anything abnormal, especially on the right side? Here. So we did a CBCT to be sure, and this is the axial view. This is a stylohyoid. This is the area of stylohyoid projection and ligament and the styloid process. So the patient has an enlarged or calcified stylohyoid ligament. So our assessment, of course, the patient have right earache, right neck pain, tenderness mildly on the right side, difficulty swallowing. So together with the imaging, our first or top differential will be Eagle syndrome or stylohyoid syndrome. We put a glossopharyngeal neuralgia in our differential diagnosis, although the type of pain the patient is experiencing is kind of different than glossopharyngeal neuralgia, but that's why it's at the bottom of our differential. So we refer the patient to OMFS for further management of Eagle syndrome. So Eagle is an ENT specialist. He noticed that there is complex symptoms in patients with elongated styloid process or calcified stylohyoid ligament. So this is the styloid process, which is a cylinder bony projection from the lower surface of the petrous portion of temporal bone, and it projects inferiorly and anteriorly to the parapharyngeal spaces. Usually it's of the length of 20 to 30 millimeters, but it can be as long as 2 centimeters in patients who exhibit symptoms of Eagle. And this is the stylohyoid ligament. It could be also calcified and produce these symptoms. So an important thing to grasp here is that a presence of an elongated styloid process or a calcified stylohyoid ligament alone does not mean the patient have Eagle syndrome. The patient should have symptoms in order to call it an Eagle syndrome. So this is what you saw. This is a calcified stylohyoid ligament. The elongated styloid process by itself accounts for 40% of the population. And 4% of the 4% only will be symptomatic, will have jaw pain and other symptoms. So the true incidence is about 0.16%. And it is most common in females. So clinical manifestation will include pain and limitation of function. Pain could be in the throat and foreign body sensation when swallowing, neck pain, jaw pain, and also ear pain. The limitation of function could be the limitation of jaw movement, the limitation of neck movement, and difficulty swallowing. So the CBCT is the best option to determine the length, the angulation, and to prepare the patient for surgical removal. So risk factor could be trauma, like car accident, let's say, tonsillar surgery. You remember our patient has tonsillectomy. Also, a repeated tonsillar infection can result in the Eagle syndrome, or it could be just a variation of normal. Management, surgical, to remove the styloid process or the calcified ligament with intraoral or extraoral approach, or to numb the area in the tonsillar fossa and can provide temporary relief for the patient. So now we will move to our third patient. She's a lady. She's 18 years old. She has right jaw pain and trismus with occasional right earache. So she also complains of difficulty opening her mouth for 10 days with headaches. And she said that non-steroidal anti-inflammatories improved the pain, but didn't improve the opening of the mouth. The pain is more when she eats, so she limited food intake. But otherwise, she's healthy and she's not on any other medications. Regarding the physical examination, extraorally, she has lymphadenopathy in the right cervical area. And regarding the intraoral exam, she has, in the right posterior lower alveolar ridge, she has a swelling, erythema, around a partially erupted molar. So we did a TMJ focus exam. She's opening only 20 millimeters, so this is a trismus. Everything else was within normal limits, even the muscles of mastication, just mild tenderness of the temporalis insertion and the masseter on the right side. This is the clinical picture and the OPG for this patient. I think by now you know what she's having. This is pericoronitis, so we prescribe metronidazole and diclofenac and also antiseptic mouthwash like chlorhexidine for 2 weeks, and we referred her to extract the lower right 8. So what is pericoronitis? It's basically an inflammation of the soft tissue around the crown of an erupting tooth or partially erupted tooth. It's not just the bacterial load that can cause pericoronitis, but it's the confined space of the bacterial load, the type of environment, anaerobic environment, together with the debris and poor oral hygiene and constant trauma, then we will have pericoronitis. The incidence is about 4.9%, and about 95% of the cases in the lower third molars. It's more common in females, young adults, and the diagnosis is based on clinical examination. Management will be antibiotics to target anaerobic bacteria, non-steroidal anti-inflammatories for the pain and inflammation, antiseptics like chlorhexidine, and if this is repeated, the patient may have to remove that offending tooth. So the signs and symptoms will include pain, redness, swelling, even halitosis, loss of function, trismus. It will begin around the area of non or partially erupted tooth. It will be maybe in a form of pulsating type of pain that can radiate to the ear, to the jaw, or even to the TMJ. It will disturb the sleep, and it will be difficult for this patient to consume food because of difficulty of mastication. Because it's an inflammatory process, you will have a regional lymphadenopathy. So these are all differentials for pericoronitis, and you can notice also that TMDs and myofascial pain could be from the differential. So now you have known our 3 patients today. These are true patients we have managed in the oral medicine clinic. They all have the same complaints, but they have different diagnoses, and none of them is a TMD patient. So TMD does not equal jaw pain. The orofacial region, the pain in the orofacial region could be odontogenic, like 95% of the cases, originating from teeth or supporting structures, and about 5% non-odontogenic, originating from the heart.
Excuse me, Doctor.
Yes. Originating from the heart, from the sinuses, ears, and eyes, or could be neuropathic, like trigeminal neuralgia. So you can note here that most of the orofacial pain conditions reported in females, and the top cause is pulpitis, followed by periodontal pain, whereas TMDs and uralgias occupy only 5% of the cases. In 2017, a survey was done in the University of Chicago, and they talked about the patient experience in medical errors. And the survey found that about 32% of the cases a patient experienced is because of diagnostic errors. So diagnostic errors account for 60% of misdiagnosis, accounts for 60% of the patient's errors, and it accounts for about 40,000 to 80,000 deaths or injuries annually. So misdiagnosis rate is about 15%. This is high, and it is a problem that is challenging regardless of any medical specialty. These are the most common misdiagnosed conditions. All the conditions in red we diagnose initially at the oral medicine clinic. So here comes the important role of oral health providers to detect serious pathologies. So the take-home message, jaw pain does not equal TMD. History taking is an art, so you have to practice it, and the golden standard for any medical diagnosis, history taking and clinical examination, always rule out odontogenic cause of the patient pain because it accounts for the majority of cases. Of course, do not hesitate to consult with other providers. An important thing is that you cannot see what you don't know, so you have to educate yourself about these conditions. And thank you.
Thank you very much, Dr. Fatma. If we have any questions? Thank you, Dr. for your time. And this is a small token of appreciation. Now, 10 minutes, if you'd like to take some coffee until the next presenter is ready to present. Thank you.
تيست ها؟ اوكي تمام.
Good morning. Our next lecture, Tongue and Cheeks, will be presented by Dr. Abdelhamid Al-Sarraf. Dr. Abdelhamid Al-Sarraf is a registered specialist in oral medicine and oral pathology. He graduated from the UK with a Bachelor of Dental Surgery, followed by specialty training in oral medicine and oral pathology from the University of Western Australia. He achieved the Australian Board of Oral Medicine and became a Fellow of Oral Medicine Academy of Australasia. He authored several articles in peer-reviewed journals, presented posters and lectures at national and international conferences. He authored the Oral Medicine Clinical Guide, illustrating his cases with over 200 clinical photographs and a step-by-step approach to diagnosing oral lesions. He completed a fellowship from the Royal London Hospital and was appointed as a researcher and honorary lecturer in oral medicine until present. Dr. Abdelhamid was admitted as a Fellow of the Royal College of Surgeons of England and appointed as an external examiner in oral medicine at the Royal College of Surgeons of Edinburgh. The stage is yours.
Okay, thank you very much. Assalamu alaikum, ya'atikum al-afiyah. Tongue and cheeks. قبل لا نبدي, I have to disclose some information. Regarding the second point of the disclosures, we just have to understand that oral medicine have different opinions across several different oral medicine specialists. So what I will say in this presentation only represents my own opinion. I did this time have a thank you slide for a few reasons. So all of the clinical photographs that I have and use in my presentations are from my own patients. So I have to thank them for allowing me put those clinical photographs for you to have a look at and to contribute to the success of the presentations across the past 5 years. I would obviously have to thank the audience for being here. It's always a topic that's not interesting. It's always been a topic not interesting. Oral medicine, pathology, oh no, it's quite boring, it's quite hard. We don't want to listen to it. We actually spend a lot of hard times at university. So why would I come to conferences and watch someone or listen to someone talk about this topic? So I have to thank the audience for being here to listen to that topic. The supporters, my research team, and the colleagues for referring patients, and actually tongue-in-cheeks came from a referral. The title came from a referral mentioning tongue-in-cheeks. So I just came up with that title from one of the referrals. So thank you to the referrers of lesions to us to have a look at. We're supposed to look at this every day, everyone. We look at the tongue. البوينتر ما يشتغل, but it's okay. And we'll look at the cheeks. If you retract the tongue and cheeks, this will encompass the largest surface area in the oral cavity. يعني الستركتشر اللي انت تشوفونه كل يوم اللي هو الاورال كافيتي تبي تسميه organ, تبي تسميه structure, تبي تسميه anatomical landmark, اللي تبي تسميه. The largest surface area is the tongue and cheeks together. حتى إذا تبي تحسب بس الcheeks, it covers a larger surface area. And we'll look at numbers now. Maybe this is the first time you know that information. في كل شيء بالحياة، في كل شيء إذا كنت تبي تشتري شغلة، تبي تحلل شغلة، تبي تقيم شغلة، بتدقق عليها. في أمثلة، أنا حاط أمثلة بسيطة قبل لا ندخل على الليجنز، بس عشان كلنا نصحصح. أنا بعد فيني نوم والله، حاطيننا الصبح السنة. ليش أبو عبود؟ والله ما اخترنا الصبح أورال ميدسين، بروح أورال ميدسين الصبح. سيارة، أوكي، تشتري سيارة، شوفها من الأجناب، تشوفها من قدام، تشوفها من ورا، بتشوف داخليتها. قبل لا تشتريها بتدقق، يمكن تشوفها مرتين ثلاث عشان تدقق على السيارة. أوكي، هاي سيارة. احنا قاعد نتكلم عن بني آدم، ترى المقارنة بني آدم وهالأشياء اللي قاعد تشوفها. بدش مطعم، بتدقق على الديكور. ممكن بس تخفف لي الإضاءة اللي موجودة هني بالقاعة، ممكن تخفف الإضاءة. بتشوف الديكور، بتشوف الاركيتكتشر، بتشوف الإضاءة، بتشوف الفرنتشر، بتشوف الفلورينج. أوكي، في كل شيء، في كل شيء، في كل شيء. تشتري ملابس، بتدقق على كل شيء، حتى على زرارات تصير صديقي عادي إذا بتدقق على زرارات الجاكيت. Back to this. أوكي، back to this. هذا موضوعنا tongue and cheeks. Five by 8. 5 by 8 هذه أرقام average. يك واحد لسانه طويل، لسانه طويل حجماً، واحد ميل يعني لسانه طويل، زين. وcheeks on average هم 5 by 8. يعني أنت قاعد تتكلم عن 40 for the tongue and 40 for the cheeks. بعد شوية إذا بكون دقيق زيادة، the tongue have a ventral surface. and lateral surfaces. فهي أكثر أصلاً من 40. في study لقيتها قديمة, but they actually studied the size of the tongue for adults and neonatals. فهذه الأرقام 79 millimeters by 51 millimeters. حجم الtongue. And this is for the cheeks. 40 centimeters squared each. Shukran, thank you. Each side. So that's 80. 80 and 40. 120. بالمناسبة, just to have something different this year, I think I spoke last year and the year before. This year we have a quiz at the end of the presentation, and there are questions related to the presentation. تمام? There's a quiz, and whoever wins the quiz, inshallah راح يشرفنا of one of our future courses in oral medicine. Okay, so let's continue. I'm sure you want to see lesions اليوم. We covered this. We'll look at tongue lesions, lesions affecting the tongue and cheeks, and the quiz. This is the outline, okay? All patients came from these buildings. أيوة أحلى building. جهرة؟ والله أنت جهراوي أصلي عاد. زين. Let's start with lesions exclusively affecting the tongue. And from the name, it's geographic tongue. Keratotic borders surrounding erythematous areas within the tongue. It affects all surfaces, lateral surfaces, dorsal surfaces. I sometimes see it in the ventral surfaces, and actually sometimes in the floor of the mouth and buccal mucosa. Here are other cases. It affects kids, actually. I got this case from a pedodontist saying this is not geographic tongue. Is it geographic tongue? بعد إذا أنت محولها وتقول لي مو geographic tongue، ليش محولها؟ أقول له geographic tongue مو geographic tongue، يعني ليش محولها؟ It affects kids, so don't be amused if you see geographic tongue affecting the kids, and they represent countries in a map. That's why it's called geographic tongue. And actually, someone said at a funny conversation, يعني ما يصير تسميها لسان جغرافي يعني. أنا ما شفت أنا ولا مرة يعني خريطة دولة على التنج، فأنا حطيت له قارة. فاللي يلقى خلينا يجمع لنا a worldwide map of geographic tongue. Okay, so the next one, sublingual varices. Okay, they affect the tongue, dilatation of the veins and arteries cause pooling of blood in the area, and we almost always see this in the tongue. Some other areas in the oral cavities are affected, but it's commonly found in the tongue. Median rhomboid glossitis is characterized by central epithelial atrophy located around the midline of the dorsum tongue. It's not exclusively caused by fungal infection. Okay, so there are other factors involved in the development of this condition, and here's another case. Granular cell tumor. It's found in adults and kids with abundant granular cytoplasm found under the microscope, but the origination of that is caused by other different cells rather than the classic polyps and other lumps that you know about, such as mucoceles. Okay, So it's originated from Schwann cells, striated muscle, mesenchymal cells, histiocytes, and epithelial cells. Here we go. Here are other ones that are diagnosed as granular cell tumor histopathologically. TAGZI, traumatic ulcerative granuloma with stromal eosinophilia. The biopsy is full of eosinophils, and that's why it's called TAGZI. It's characterized by an ulcer surrounded by a white keratotic border. So if anyone wants to differentiate this from any other ulcers, then you'll always see this white border surrounding it. Sometimes it mimics malignant lesions, such as SCCs. And it's clearly illustrated here, a central ulcer surrounded by a white keratotic border. أكيد يعني hairy tongue is one of the conditions we have to discuss. It can be mild, progressing to severe hairy tongue. Okay? There are many factors detected in our population, but one factor was a little bit weird. يعني هذا patient كان معلومة جديدة، يعني قال لي أنا على طول أتمضمض في كركم، نحط قفشة كركم وماي. قلت له ليش؟ أنا اللي أعرفه يعني إنه ينشرب، يعني أساس إنه يعني ياخذ فائدة الكركم. قال أبي أضعف، فهذا يقول جربت كل شيء، جرب مونجارو، جرب فقال شيء جديد مو قادر أضعف، وياكل وايد، يعني ما يضعف لأنه ياكل وايد، مو لأن المونجارو ما اشتغل، بس قام فالحبت هذا using it for a long period of time causes dry mouth followed by hairy tongue to a yellowy surface. Okay, riga fidi. It's common. Trauma from lower teeth. Adil. Sometimes extraction of the teeth is necessary, and we review to ensure that the ulcer is resolved. I think what we're doing here in oral medicine, whether it's me or anyone else, I think previously in the conferences we used to have one presentation. And as soon as I came, that was 2018, no one was presenting. And this has kept the case until last year. And me being as part of the scientific committee with no conflicts, I've been pushing for others to present. Until I'm happy this year that we had at least 3 or 4 presentations talking about oral medicine. So why I said this, because we need others and other specialists to continue this awareness from their specialties, not talk about oral medicine, but talk about, for example, periodontics, because this previous patient here has seen a general pediatrics doctor. He's quite known, and the advice was, this is a fungal infection. The diagnosis was, this is a fungal infection. The advice was to rub the tongue. Rub the tongue. Rub the ulcer. Just imagine, you know, the pain that the kid is having, and the advice to rub the tongue 3 times a day. Anyway, so awareness is always important. This is another case, but I think this is a happy child with a riga fidi, trauma from lower teeth. This is quite common. Human papilloma virus related lesions. I see them a lot in the tongue. They do affect other areas such as the palate. But it's quite common in our population. I see them in males and females. I excise a lot of them. And have to to go through all the risk factors with the patient. Sometimes it gets weird. Anyway, tongue and cheeks. Let's look at lesions affecting the buccal mucosa. Very common one, fibroepithelial polyps. We always see them. Trauma to the cheeks, an accidental bite, for example, someone who have a habitual cheek biting habit causes these to develop. And there's lots of them. The feature, the common feature, or the shade common feature between them is that it's a sessile lump, similar color to the surrounding tissues. And this is a fibroepithelial polyp. تبتصور؟ آسف. صور. عادي؟ Yeah. They can be big, such as the one on the right here. And surgical excision is the treatment of choice. We always send to histopathology for diagnosis. If you come across anyone that bin them يعني قطهم بالكرمون الزبالة, just let me know. Because actually some clinicians bin them as if it's a polyp. We came across lesions that we think it's a fibroepithelial polyp, but then it's like a schwannoma or something else that sometimes can be malignant too, or have a risk of malignancy. This is a stressful patient that always bites her cheeks. She's got two, so 2 in 1. All right. They also affect the tongue. So I've put some photos for these lesions affecting the tongue, fibroepithelial polyps. When continued trauma happens, you get an ulcerated surface too within the polyp. So the surface gets ulcerated due to continuous trauma. When there's blood in the lesion itself, or the medical term, the correct medical term for it, angiogenesis, then we call it angiogranuloma or pyogenic granuloma, whatever you prefer. Same treatment option. Always excise for biopsy. هذه كم 2؟ أنا 2 حدي ترى 2 سنتيمتر. بس أكبر من 2 we ask our fellow surgeons to help. هذه مسويها غمازة. تويت قبل فترة قصيرة يعني. بس الغمازة سويتها بصالون. فوي got a granuloma. لا تركز على الصالون يعني. موضوعنا ايش اسمه زين. ف post dimple granuloma occurred soon after the procedure. Lichen planus affects the tongue and cheeks. It's one of the most common mucosal disease we see in oral medicine clinics, so we just have to mention this while we are through. They present in several different forms, and we will look at them now. This is the first report of oral lichen planus. Actually, lichen planus, not oral lichen planus. This was reported for skin lesions by this known dermatologist in 1866. So it's a very old disease. And there's many different forms presenting clinically, affecting the tongue and cheeks, but other lesions, other areas can be involved, such as the lips, the inner side of the lips, the lip mucosa, as well as the outer vermilion border of the lip. But since we are talking about tongue and cheeks, let's have a look at the different forms of it. Classically, they present bilateral. The reticular type is the most common. Sometimes there's redness and small ulcers within the lesion itself. This is when it gets painful. This is an ulcer. It's a yellowy ulcer, okay? It's a yellowy color. That's how you know this is an ulcer within the lesion itself, okay? Bilateral, reticular type, this is another one. And here where we have to be careful about the types that present. Sometimes multiple forms present in one lesion. Here we see an ulcer, we see erythema, redness, and we see reticulations. Here where management gets a bit more difficult, okay? Because reticular type with no ulcers, no redness, patients most of the time is asymptomatic. What I do with them, I start with topical steroids. And I do get good results, usually within 2 weeks. This is the left side, ulcer is gone. Let's move on. So oral lichen planus was common. This is rare. We don't see this a lot, okay? I do have a few cases, but that's all, okay? Pemphigus, in its ulcer presentation, is a bit more deep, okay? It's an autoimmune disease characterized by the development of deep oral and skin ulcerations leading to cell-to-cell separation. You can see the difference in presentation between an ulcerative lichen planus with a surrounding white background to this deep red ulcer that actually looks painful. There's a bully down here. Bulle, not bully. A bulla, let's say a bulla, okay? I also start with topical steroids for pemphigus vulgaris, and I also get good results, but ultimately patient will end up taking one of the systemic steroids or biologics such as rituximab, which is, thankfully available in Kuwait. It's an intravenous infusion that the patient takes for the management of pemphigus. So this was using topical steroids for 2 weeks for this case. Okay, so moving on to the next lesion. This is not a lesion, this is statistics. I looked up numbers because I do get a lot of cases that actually be involved in our clinic. They are mostly involved in certain ethnic groups, okay? Here I made a square on the non-Kuwaiti individuals, almost double the number of Kuwaitis. And this subgroup of patients who practice smokeless tobacco. And here's our next lesion. ما صوروا الليجن صوروا الأرقام. ليش؟ موجود بالموقع. كل شيء موجود بالموقع. دشيت عليه موقع المعلومات المدنية حق اللي يعني قاعد يشوف statistics معينة أرقام معينة relevant to their patients, the number of patients, adults, kids, the age groups. It's a very useful website. Submucous fibrosis. And the center I work in currently, مركز الجهرة, lots of patients come from north. وأغلب patients Asians and Africans لأنهم يشتغلون في المزارع. ف I do come across lots of patients that uses smokeless tobacco. Okay, and this is where our next lesion comes in, submucous fibrosis. الصوت شغال شباب؟ صوت إذا في فيديو شغال؟ هذا الكشاف حاطينه عقاب ولا شنو؟ ما أشوف ولا شيء. شغال؟ ما أدري. إذا شغال أنا في فيديو. There are various forms of smokeless tobacco. Powders that's been wrapped into leaves. هذه نبتة القات. الأفريقيين يستخدمونها لأن يجيبونها من اليمن. And you see other characteristics other characteristics that involve the buccal mucosa when smokeless tobacco is used. Submucous fibrosis, okay. PAN is another الحين بشرح. Or tumbak. There are various forms, even gutka. There are several different names. يعني حتى لما تسأل patient do you use مثلا تمباك تقول له في تمباك يقول لك لا وانت تدري ان في lesion يعني direct association with use of smokeless tobacco. فتنتبه بعدين يقول لك اسم ثاني يعني يقول لك اسمه جوتكا او اسمه بان ف you have to ask him do you use this and this and this and this او تسأله do you put يعني تحط انت شيء داخل. Anyway, this is the video. Let's have a look. The clinical presentation other than lesions. ماكو صوت؟ الصوت مو ضروري ترى بهالفيديو بس حق بعدين احتاجه. هذا التست. ايش رايك فيني وانا اختبرك وانت ما تدري؟ هذا حق بعدين ابي الحين هذا مو ضروري الحين بس قاعد اسوي examination for the buccal mucosa just to show you how tense the mucosa is. تمام. شوف. ماكو صوت والله. ضبطوه. بعد 5 دقائق يمكن نحتاج الصوت حق المسابقة. وإذا ما صار هم عادي. Okay. Submucous fibrosis. The last tongue case. إيش كثر عندي وقت؟ 10 minutes ها؟ Okay. The last tongue case حلو. 10 دقائق حلوين. This patient, believe it or not, huh? Believe it or not. Believe it or not. Believe it or not, huh? This patient, 1 year. 1 year. 40 years old, من الجنسية البنغلاديشية, came to me 2 weeks ago. هالصورة أنا ماخذها قبل أسبوعين. صار له سنة. عنده lesion بالتنج. It wasn't painful, now it's painful. Okay? اللي يوديه مندوب الشركة اللي يشتغل فيها، يوديه ويجيبه العيادة. أي عيادة؟ عيادات برا، هني، هناك، هالصوب. يقول والله وديه بفلوس حتى مو يعني أوديه إنه يعني المستوصف ولا هذا. يقول هو قاعد يقول أنا أوديه حتى عيادات برايفت عشان أشوف شنو مشكلته. عنده مشكلة بالتنج. وهذه المشكلة أو هذه الليجن إذا مو شايفينها بوضوح. Starts from here. إيه لازم أمشي وايد. Ends here. زين. Tongue and cheeks عنوان المحاضرة. lesion on the tongue. سنة. شو يسوون له؟ سنة ايش قاعد يسوون له؟ وين قاعد توديه؟ قاعد اكتب history 1 year blah blah blah. They smoothen the edges of the molar. لما المولر هذا صار flat. شوف الليجن. تروما. سنة. زين تروما سنة. زين لما كبرت صارت كذي، ما غيرت بالمفهوم شوية؟ هذا الضرس. هذا الحين فلات خلاص. زين believe it or not. الحين خلاص احنا خلصنا، احنا نعرف هذا شنو، نعرف شنو صار، ونعرف منو اللي شافه، ونعرف ليش قاعد يصير كذي، نوعا ما نعرف. بس المصيبة مو هني، المصيبة انه all of these cases عندهم similar history. ايش؟ الحين نصهم مو موجودين هذول. Because of 2 reasons اللي I will mention today. There are other reasons أقدر اللي بيعرفهم أقول له بعدين ليش، بس 2 reasons main ones. Because we prescribe anything for anything and we think it's trauma. This is given for 1 patient. هذه الأدوية. هني المصيبة. مرة ثانية نشوفهم. هذا كان قاعد يعطونا anti fungal medication topical و systemic. topical ما فاد، اللي هو مايكانازول، اللي هو دكتارن، اللي هو دكتارين. و systemic حبوب. ما أدري والله. How people think sometimes. غير كذي هو البيشنت يعني ما ينام ويقوم يلقى لمب، لازم في شيء قبله، صح؟ يعني مو معقول ان البيشنت ينام وباكر يصير عنده لمب يروح عنده لمب. That's not the history. The history يكون كذي، يكون there's a patch, there's a white patch, there's a red patch, there's something there, there's something shouting at you, there's something shining at you as dentists that you have to see. You have to see tongue and cheeks. بعدين teeth شوف teeth. You are dentist, you treat teeth. مفروض يعني. بس part of your management and examination is to examine the mucosa, which takes 1 minute to do. دقيقة. أنت ممكن تسوي composite filling بنص ساعة ولا وايد نص ساعة. أنا بيلي ساعتين الحين أسوي composite filling. الكومبوزيت تسويها بنص ساعة، ما أدري 20 دقيقة، إذا أنت سريع 5 دقائق، إذا مالك خلق دقيقتين، صح؟ كل هذا الميوكوزال اكزامينيشن فور ذا تانج اند تشيكس يطول دقيقة. ايش رايك؟ ويو مايت ديتكت
5 minutes.
ها؟ شلون 5 minutes؟ تو قال لي 10. We will do the quiz and I will go across the last case which is a cheeks case. وما راح يمديني 5 minutes بس I already took permission from the next speaker. وينه؟ دكتور محمد موجود؟ مو جاي لأنه قال لي أخذ الساعة كلها. ايش رايك فيني؟ لا مو موجود بالقاعة، موجود بالقاعة. So I'm good. قال لي زيد البرن اوت، ما حضرته بيرن اوت، قال لي زيد علي البرن اوت. Okay, last cheeks case. صعب أدري صعب زين. Last cheeks case, this patient presented with a cheeks ulcer. زين أو buccal mucosa ulcer. دائما نهاية المحاضرة متعود عليها تكون حزينة يعني، بس المرة تكون إن شاء الله يعني مضحك مبكي، يعني حزين بس مضحك بنفس الوقت. زين هذا البيشنت I instructed him to use a topical steroid ointment for this mucosal ulcer in the buccal mucosa that I think it's lichen planus. Okay? لأن في similar lesions on the other side. So I think this is lichen planus. فأنا يعني I recommended إنه he uses a topical steroid نفس الكيس اللي شفناها مساء. We usually have good results after 2 weeks. ويرجع بعد 2 weeks. حلو؟ And I always instruct the patients on how to apply the gel أو الأوينتمنت، لأن ما في steroid gel، ما عندنا steroid gel. زين عندنا steroid ointment اللي حتى الحين مو متوفر بسهولة. Anyway قلت له تاخذ الأوينتمنت و apply it، يعني تاخذ تحط تسوي كذي، طالع المنظرة تسوي كذي، حتى المضمضة I instruct how to use. لأن sometimes patients use the mouthwash then swallow it. Sometimes patients use the mouthwash for a few seconds then spit out. Okay? So رجع بعد 2 أسبوع زعلان، قال لي هذا ماكو فايدة، أنت تقول هذا زين هذا يجي زين، أنا يجي من عبدلي يجي كذي، زعلان. أول شيء أسأله وين الأوينتمنت اللي أنا صرفته، ورني إياه. غالبا يا يكون مصوره يا يكون جايبه وياه، ويجيبه وياه يكون شنو مستخدمه عشان يبين انه هو مستخدمه، يوريني شوف انا استخدمته. I'm a compliant patient. بس this painful ulcer is still there. I need a solution. وتلقى الهيستوري قبل شايف 20 واحد، ما بين private clinics، ما بين كذي، ما بين government clinics، ما بين medical specialties. بعدين اساله، اول شيء اساله وين الاوينتمنت، بعدين اساله شلون استخدمته. شلون استخدمه ابو عبود؟ كذي برا. قلت له ليش؟ انا قايل لك حتى هني صار احمر. قلت له ليش بابا؟ انا قايل لك الطريقه الصح اللي تستخدم فيها الاوينتمنت. قال هذا صيدلي يقول هذا اوينتمنت مال جلد. Most of our medications we use off-label. It's made for something, we use it for something else. Most of مو بس oral medicine medications in general. This is the last case, okay? Tongue and cheeks. Thank you very much for listening to this. أعتقد خلص وقتي, but I will need 5 minutes for the quiz, and the winner will attend one of our upcoming workshops. I've been trying hard for the past 5 years. Thank you to the Kuwait Dental Association that have been supporting in allowing these courses to happen. I planned for a future course in January. Some of you here, I know they attended those workshops, and some of you recent graduates, some of you are well experienced in dentistry مثل دكتورة أنيسة. شلونك؟ من زمان ما شفتك. So we will start with the quiz. I have 5 questions. أبي كل واحد فيكم ما عليكم أمر يدش على kahoot.it. kahoot.it. I have 5 questions. تمام؟ Let's do this. الصوت اشتغل؟ راح يفيدنا الصوت في المسابقة، بس إذا ما اشتغل هم ما في مشكلة. دكتور محمد الشتيل مشكور وايد. أنا راح أخذ 5 دقائق من وقتك. بس انا الحين عندي 5 دقائق، ما اخذت من وقته صح؟ خلص وقتي؟ خلص ها؟ الحين اقول لك. لا هذا السبيكر. خلنا نبلش. هوست لايف، خلنا ندخل. اي فصلت الحين بها شغله. راح اعطيكم البن اللي دش kahoot.it. The pin to enter the competition or the quiz. وينه؟ ليش ما يشتغل؟ اقدر اسوي له؟ اي واحده طقته. وين؟ 460 3651. This is the pin. 460 3651. duplicate. خلاص بس خلى الصوت. صار لنا 10 دقائق ما ضبطنا الصوت. بوي ما شاء الله وايد. بوي لا حطوا اساميكم. شنو دي اس اس اس؟ ما يصير، ما نعرف منو بعدين دي اس اس اس. يمكن يكون قتيبة. حطوا اساميكم عشان أعرف. زين 4603651. اوكي. يلا بسم الله نبلش. اقدر ابلش؟ اقدر ابلش؟ الكل دش؟ اوكي يلا. first question. tongue and cheeks. What is the surface area of the tongue and cheeks together? في 20 ثانية للجواب. اللي يجاوب أسرع ياخذ نقاط أكثر. خمسة وعشرين جاوبوا، 30 جاوبوا، 32. ايش دعوة سهل السؤال كذي. خلص الوقت تقريبا. اوف. منتبهين صح؟ شنو انت مو دانا؟ الثاني. اي اوكي. زين السؤال الثاني. Which of these only occurs on the tongue? ulcer, oral lichen planus, fibroepithelial polyp, sublingual varices. السؤال الثالث. دانا، روح مسكو دانا، روح مسكوها. لا انت لا تجاوب. شنو؟ لا تجاوب، لا تجاوب انت. شنو هذا؟ انت لا تجاوب، ما يصير تجاوب. انت تشير بيرسون، ما يصير تجاوب. والله يابا زين. When is our next oral medicine workshop? شو السالفة؟ عايشة. اوكي جاوبت غلط. زين. True or false? This is geographic tongue. قششك؟ لا. آخر سؤال. Write the clinical term for a mixed red and white patch. بسرعة اكتب. Write the clinical term for a mixed red and white patch. كل الإجابات راح تطلع. سبيلينج صح لازم يكون كلمة واحدة. يلا. أريثروليوكوبليكيا. خلينا نشوف الإجابات. حسافة راح. منو كاتب لي ولدن؟ كبير يا أبو حمد، على راسي والله. 3 يا أبوها صح. أوكي. منو فاز؟ المركز الثالث فاطمة الصفار 4 out of 5. واحدة غلط. نورة 4 out of 5. منو؟ زكية. دكتورة زكية ما شاء الله. 5 صح؟ مبروك. خلصت أنا. دكتور محمد الحين يطلع الصوت. دكتور محمد السيل مشكور وايد. ثانك يو فيري ماتش. اللي عنده سؤال ولا شيء أنا راح أكون موجود. And thank you to the chairpersons. مشكور مهند. Thank you very much. I'll see you later.
Thank you, Dr. Abdul Hamid, for the informative lecture. Our next lecture will be titled Burnout in Dentistry, Prevalence, Effects and Coping Mechanism, presenting by Dr. Mohammed Lishtail. Dr. Mohammed Lishtail was born and raised in Kuwait, acquired the Bachelor of Science of Chemistry, as well as the Doctorate of Dental Surgery from Dalhousie University. He has been practicing in Al Usaimi Clinic for the government sector since 2021. Yeah, the stage is yours.
Thank you, Doctor. Awesome. Assalamu alaikum, ya'atikum al-afiyah, sabahkum al-khair. Thank you, Dr. Abdul Hamid, for this wonderful lecture. I always hated oral pathology, to be honest. That didn't change things. Fee clicker. Thank you. And just go like, yeah. Okay. اليوم, I'm going to talk to you actually in English because I feel like for this specific topic, it's easier to explain things, easier to explain terminology. Not all of us speak Arabic in here, so I'll speak mostly in this. I'd like to thank the KDA for having me present this lecture for you today, especially the scientific committee, all of their members headed by Dr. Fahad al-Basri, of course. It is a heavy topic. Inshallah, يكون a light lecture for you guys, and hopefully you learn a thing or two. First of all, who here heard the word burnout? منو سامع بكلمة burnout? Like a few. Okay. Who of you knows what it means? Do you guys? 1, 2, 3, 4. ماشي. So burnout, the agenda for us today, we're going to talk about a couple of things. We're going to define what is burnout. We're going to say what is the definition for it, what's the history, how it started. We're going to talk about burnout in dentistry specifically. We're going to look at worldwide studies, what are the factors affecting burnout, what are the effects of burnout itself on us, coping mechanisms, healthy and unhealthy, and then finally we're going to talk about resources available in Kuwait for everybody. Summary and conclusion. A little bit about me, it's literally what the autobiography said. So I was a Bachelor's of Sciences in 2017 in Canada. I graduated from Dalhousie Dentistry in 2021, and I currently work in Nahil Asaimi in Khaytan since 2021. So I'm a GP, I'm not a specialist, so it's great. First of all, what is burnout? Burnout can be defined as a syndrome. It is not a medical diagnosis. That's the thing. It's a syndrome that is conceptualized as resulting from chronic workplace stress that has been affected multiple times and not successfully managed. It is added to the International Classification of Disease. That's as the latest definition by it from 2019. For the sake of this presentation, we'll be focusing on occupational burnout specifically. So burnout caused in your own work and how that affects everything. A little bit of history. So burnout has been around since the start of time. We've all been stressed most of the time and everything. In 1869, this lovely gentleman, the American George Beard, used the term neurasthenia, describing a broad condition caused by exhaustion of the nervous system. It's just an umbrella term. This included anything that affects the nervous system in a different way. This got popular in the States. They nicknamed it Americanitis. So this was the sort of kind of thing for it. Keep in mind that 1869 was around the same period that scientists have discovered hysteria, so things were just completely new for them at the time. Skip to 1888, British neurologist William Gowers coined the term occupation neurosis, and it was added officially to the International Code of Disease in 1948. They've said, hey, there's something wrong going on with occupations. People are being different. So they started looking into the matter. Followed by that, in 1961, American author Graham Greene published a story, a novel called A Burnt Out Case. This was the first time that the term burnt out was used in a published sort of setting. This novel talks about an architect who has stopped caring about his work, who lost energy and motive to continue being an architect. So that's why they coined the term burned out to describe this specific situation. 1976, Christina Maslach, who is the American, she noticed that the term started being used as a colloquial term. People feel, oh, I'm burnt out today, or things like that. And in 1981, she teamed up with Susan Jackson, and they both started the Maslach Burnout Inventory, which was an assessment to fully actually assess burnout and see the degree of the effects that it has on people. After this, so you might ask yourself, why did I choose the topic burnout? We don't talk about burnout, we don't talk about mental health enough, especially in Kuwait. We're all affected by it. Burnout is one of the things that you may suffer or know someone who suffers from it, and you think that you're going through it alone, but you're not. Back in 2019, when I was in university, I did research, some original research. We did a survey. I was in Nova Scotia, which is a province. This research was around for 500 dentists who practiced in Nova Scotia, and around 93 of them responded. I looked at burnout in and out. I've gone through around 60 papers talking about burnout. I've talked about different things. We've looked at different factors like specialty, marital status, things. How does burnout affect or differ from one person to the other? We'll talk about more, but this is basically what my life has. It's all about burnout. So it was just a big thing in the back of my mind. To understand burnout, Christina Maslach and Susan Jackson put it down into 3 components to understand how burnout is affected, or how is it increased or not. The first one is emotional exhaustion. I'm going to define all of these in a bit. The second one is depersonalization, and then the third one is reduced sense of accomplishments. These 3, no one factor is more important than the other. They all affect each other interchangeably. It's almost like a 3-way scale, and how your variation of your degrees to measure each will determine how burnt out you are. To start off, for emotional exhaustion, it can be described as a feeling of being emotionally overextended and exhausted by one's work. It is manifested by both physical fatigue and a sense of feeling psychologically and emotionally drained. Who here feels tired after a long day of work and you feel like you have a low battery? Yeah, Kelena is the same. So this is emotional exhaustion. It is good to know that just because you have one of these things doesn't mean that you are burnt out. I'm not saying you are not, but we all have some sort of emotional exhaustion by nature. It doesn't differ. The second part of it is depersonalization, which means having distant or indifferent attitude towards work. You be negative, cynical, and you become objective of your cases. This includes inhumane attitude and negative feelings towards others. This varies from low to moderate to heavy. In extreme cases, some people stop looking at patients as human beings. They look at them as cases, that this person in front of me is just a tooth. No, it's not a human person with emotions, and you lose empathy, basically. That's the problem for depersonalization. Lastly, reduced sense of accomplishment is the tendency to negatively evaluate the worth of one's work and feeling insufficient in regards of the ability to perform one's job, and a generalization of poor self-esteem. I definitely sometimes look at a filling that I've done and I'm just like, this is a bad filling. I don't think that I did a good job. Someone is a prosthodontist, say they look at a shade, they don't think that they're good enough, or they don't believe that in their own abilities to produce good work, and that affects their self-esteem. Okay, so focusing on burnout in dentistry. Dentistry is stressful. Anybody agrees? We're like, yeah. Dentistry attracts people who are naturally stressed. If you think about it, all the way back from the university days, from the competition to get into the university, from the competition to stay in the university and doing well, and then after graduating, you go over stress and stress and stress, and that is a constant exposure to stress in different ways. So burnout in itself, there are high prevalence rates of burnout in dentistry. There's papers that prove this. You can look at occupations. I've seen a couple papers that compare different occupations with different degrees of burned out. And dentistry does, unfortunately, score higher than other occupations. Lastly, dentists have, sadly, one of the highest suicide rates in terms of occupation worldwide. Unfortunately, this includes a lot of health professions. So we have physicians, we have ICU workers, we have different people working in different healthcares. The job that has the highest suicide rate is construction work, which is surprising because it feels like a repetitive kind of thing, but I see it. What are the effects of burnout? Well, it affects everything. And all of these affect burnout itself. So first of all, personal relationships. your relationship with your coworkers, your family members, your friends. These are all could be affected negatively. You go back to the whole depersonalization, emotional exhaustion. You don't feel that you have the energy to socialize with friends and things like that. And it does. This can lead to clinical errors. Clinical errors, things like you drill the wrong tooth, you don't pay attention. You drill mesio-occlusal instead of disto-occlusal. You get distracted. These can all lead to clinical decision making. What if something happens as an emergency in the clinic? You don't feel that you're well equipped, or you feel distracted to make correct decisions regarding your clinic. Okay. This overall decreases the quality of the patient care. So we are a very patient-centered profession. We always put the patient at first. This is beyond our needs. Doesn't matter what we have going on in our personal life. Once you go into the clinic, you are in the clinic. And we have sometimes difficulty separating the work-life balance. And we're going to talk about this in a bit. What are the factors increasing burnout? The number one factor in all of the burnout cases is stress. So stress is the number one reason why people get burnt out, because it's the constant exposure to stress, and that's the one that leads to burnout. We all have high patient demands, especially like if you work in a polyclinic. Sometimes you have 15, 20 patients waiting outside, all waiting at the same time, and you have the stress and the high expectations that you want to finish all of these people equally, because you want to give the same patient care quality to all people. Towards the end of the day, you get less and less and less. So by the time the 15th patient comes in, you should give them the same quality of care that you give the first patient. They've looked at the other things: time and productivity pressures, physical strain. We all get taught about ergonomics. Do we follow them? We try. Do we do them all the time? I have back pain. It affects us. We don't realize how physical our job is until the end of the day, where you kind of just bent over doing extractions all the time, or you kind of have strains on your shoulders and back and things like that. As I said or mentioned earlier, the lack of work-life balance. When does our life stop, our personal life stop, and then our work life extends? Sometimes we have difficulty differentiating between the two. Other factors: does specialty affect? Do specialists have more stress than GPs? Do married folks have more stress? Do separated or divorced people have more stress compared to single people? These are all factors that we're not very sure of. It differentiates from one place to the other. It could be, but correlation does not mean causation. It's just that, again, work-life balance is a little bit different to differentiate between them. All right, so let's take a look around the world. Have people studied in any of the pinned places? Australia, UK, people? Yeah. First of all, we can take a look at a study from Australia. So this was actually released in 2023, which was recent. They've looked at around 1,400 dentists. You can look at them. And they looked at the numbers. They've used the Sydney burnout inventory, which is similar to the Christina Masselbach burnout inventory. But these ones, instead of looking at emotional exhaustion, depersonalization, and reduced sense of accomplishment, they look at emotional exhaustion only and depersonalization. So those are the only two. The Masselbach burnout inventory is considered to be the one that is most often used. That's why there's a lot of papers that use it, the MBI system. But you definitely do see other papers like this. So Australian dentists are burnt out. Looking at Korean dentists, they've used the MBI system. They've looked at around 1,000 dentists. They found more than half is burnt out. Typically, or most people who were burnt out were people of the younger age. So younger dentists were more burnt out than the older dentists in Korea. After that, we can look at Singapore. Singapore here, also another different Asian country. They've also looked at people burnt out. We look at the UK. UK burnt out. We look at the States. The States look at the pediatric dentist, and specifically for this paper. Specialty does affect a little bit more stress here. So pediatric dentists, I'm sorry if there's anybody here. The most recent ADA communication report, the American Dental Association has sent a survey for all their American members, and the one thing in common between all of these studies is stress. So stress, this is the survey that they did for about 500 dentists, and they all looked at different stress-related factors. What makes you stressed? Is it the patients? Is it things? And how often do you want to quit dentistry or think about quitting dentistry? That's one of the things. Like there comes some days where you're just in the clinic and you're like, what am I doing to myself? Why did I choose dentistry? Well, because I couldn't get into med school, but still, dentistry is still a little bit more stressful. You may ask yourself, what about Kuwait? Does Kuwait talk about mental health? Let's focus on Kuwait. I've only found 4 papers that look into burnout in Kuwait. Not specifically in dentistry. Actually, none of them are dentists. But the first paper I found was burnout syndrome in physicians working in primary healthcare centers in Kuwait, or Musawsaf. They found that people are burnt out. This looked at nationality, difference in nationalities. They found that non-Kuwaiti doctors are more burnt out than Kuwaiti doctors in primary healthcare centers. Looking at burnout and surgical specialists. So they've looked into all 5 main hospitals in all of the provinces in Kuwait. They found that the surgeons, I think there was about 400 surgeons that they've surveyed, and almost 70% of them were burnt out. Another study here that looks at the predictors of depression and burnout among surgical residents. So the residents. This is not about burnout specifically, but they looked at the tendencies for anxiety and depression, and they found that there's a lot of the surgical residents have burnout. Lastly, some factors like COVID. We've all lived through COVID. COVID has been a stressful time for a lot of us. They looked at mental health of healthcare professionals or healthcare workers and students at the health sciences program in the Kuwait University. They also found that people are burnt out. So we're going to look at coping mechanisms. So we all have our different styles, different coping skills, things like that. It can be differentiated. This is to societal norms, let's say. So unhealthy coping mechanisms. Number 1 is substance abuse. Worldwide, there's alcohol intake in a lot of countries. There's drug abuse. People can tend to abuse pain medication, perhaps, or things like that, if they're having back pain or things. This can lead to drug abuse. Poor diet choices. I think I'm the last person to talk about poor diet choices, so we're going to skip this one. Withdrawal and isolation. People tend to think that if they are burnt out, that they're alone. So they tend to socially isolate themselves. They don't have a support system around them. They don't think that other people are going through what they're going through. But little do they know that we all are going through the same thing. Some people tend to overwork. People think, oh, I'm stressed because I don't have enough money. I don't have enough patients. Let me book my schedule fully, or let me oversee patients, or they don't take breaks. You tend to work yourself. That's an unhealthy coping mechanism. Neglecting self-care. When you can't take care of yourself, you can't take care of anyone else. So it has to start with you. You have to absolutely be and partake in self-care. Looking at healthy coping mechanisms, number one is seeking support. Having a network of close peers, close employees, close family members that you can talk to freely, not being scared of judgment. That can be a little bit difficult in Kuwait, but still. Quality sleep. I'm talking to you after running on 4 hours of sleep to finish this presentation, so I don't think, again, I'm the best one for this one, as well as physical activity. I'll explain how things are more than that. Setting boundaries is an important one. Learn to say no. A lot of us are people pleasers. We tend to give away ourselves for the sake of giving a quality patient care, or if the patient is always right. No, they're not. You don't have to sacrifice yourself to please someone else. Learn to take a limited number of patients if you need that. These all need to change. It's a lifestyle change. Lastly, we have practicing self-resilience, and I'll get back to this one later, with a toolkit. Resources available in Kuwait. So who here knows that there are mental health clinics in polyclinics? Does anybody know that? Anyone? No hands. Oh, well, I told you yesterday, so that's why. Oh, I see someone in the back. Yeah. So I go around polyclinics in Kuwait to do some policy work and things like that. And I ran into this pop-up. It says World Mental Health Day, choose your best life. And here it says لحجز موعد للعيادة النفسية في المراكز الرجاء مسح رمز ال QR. Or if for you to take an appointment, you can scan this QR. And I got into the QR, and you can feel free to scan it if you want, because what it leads to you to is the official Ministry of Health website. So just like patients can take appointments online to go see the doctor or go see the dentist or something, anybody can take an appointment to go see the mental health clinic. Who can be seen in these clinics, certain cases? Say, for example, if I go to the clinic and I go to them, hey, I want to go see the mental health clinic or the mental health doctor. What will happen is that they look at certain cases. They deal with major depression, generalized anxiety disorder, panic disorder, and primary insomnia. Polyclinic doctors have the ability and capability to prescribe SSRIs and SNRIs, and they do cognitive behavior therapy and all of the other things. They are well equipped, or I hope that they're well equipped to do this. What I'm going to do is I'm going to report what has been told to me. I hope that everything in this presentation is true and that the polyclinics follow what they told me. But these are the things. I pulled this out of a protocol. I asked them to show me what their health clinic protocol shows. So this is written exactly from them in the polyclinic. You might ask yourself, how do they assess it? Or how do they accept patients? Some patients will ask for help. It's not bad, and it's not like it shouldn't be stigmatized to ask for help when you need it. You need to know that you're not alone. You need to check with professional help. If you have a toothache, you go to the dentist. If you break a bone, you go to orthopedic. If you have mental health issues, you go to a mental health doctor. It's the same. What do? They give you a screening. They do an assessment tool. They have the GAD anxiety ones and things like that. They know what they're doing. And then they will assess your level of mental health, whether you're stressed, depression, things like that. And then they decide if you can be seen in the polyclinic or you have to get a referral. Referrals have multiple different places. So if you have any presence of psychotic symptoms, so hallucinations, delusions, things like that, you get referred to the mental health hospital in Sabah. Admission, they do not admit everybody. There, they do further assessment. You don't necessarily have to be admitted. I know that there's a lot of people who are scared of like, oh, if I go, I'm gonna get locked up. Not necessarily. They have to assess to see if you are fit to treat patients. Just like when we all applied for our jobs anywhere, you get a medical exam, a physical, you do a full physical, you check your eyes, you check your things. Here they check your mental health. They have their own kind of things. If you're experiencing any suicidal or homicidal, there are emergency clinics for mental health. There are people who are well equipped to deal with these sort of things. If there's substance abuse or alcohol abuse, the addiction center, Kuwait Addiction Center, which is in Sabah as well, again, not necessarily get admitted. They check, they do assessments, and they are the ones who decide if you do need admission or you don't need admission. Bipolar disorders in the hospital, the mental health hospital, pediatric psychiatry, if less than 18, they also have their own specialty center to be seen by them. Earlier, I talked about resilience. So we talked about resilient, and it's a way to kind of counteract burnout. How can we be resilient? I have a toolkit here. I took this picture yesterday in the exhibition. There's a booth in one of the exhibitions that they have this picture. I got excited as a dentist. I got scared as a human because this is what the patients look at and they think that we're psycho, which I don't blame them. Like if you come in and you see all this laid out at the table and you're like, yeah, sure. So just like we use these instruments to, as a toolkit to do extractions and things like that, we can be well equipped with a mental health sort of resources. I've summarized them, or I've used 4 E's, and these are given to me by a therapist and doctors that work in mental health, and I've done all the research with them with that. The first E that we do is engage. Build connections. Have a supportive system, safe spaces where you feel comfortable expressing yourself or simply being present without needing to talk. Positive social interactions help reduce stress and provide emotional support. Just like I said earlier, have your own network of similar people, maybe in your situation. Places like the KDA and having the Kuwait Dental Conference is a great opportunity to meet other people, to see other people from different perspectives, different specialties, different things. There are some people that I only see them in the conference. And I'm like, oh yeah, I've seen you last year, and that's how we do. Try to not necessarily have dentist friends. We get bored of speaking dentistry the entire time. Have people outside, elsewhere, things like that. So that's engage. The second one is enlighten. So enlighten your mind. How do you enlighten your mind? Is you practice mindfulness, being fully present in the moment without judgment, by observing thoughts, feelings, and sensations without reacting to them. And mindfulness can help create mental space, reduce stress, and encourages a calm, centered mindset. So what does it mean? Sometimes thoughts can be provoking, especially for people with anxiety who tend to overthink things. I'm personally one of those. If you run into a situation where you feel stressed or something, try to observe yourself in the situation from a third-person view. Look at the situation. Try not to analyze it. Try not to define what is going on. Try not to think of things to do. Just know what's going on at this moment. Like, I'm thinking to myself right now, okay, at this moment, I'm on stage giving a lecture to people. It's nerve-wracking. But I'm just acknowledging it. It's happening. Time is passing as we're doing. The lecture is going. 5 minutes. We're almost there. It's all right. All right, get to do this. Embody, align mind and body by engaging in activities that keep them focused on the same task, such as going for a walk, other rhythmic movements, techniques like bilateral stimulation, alternating physical. Basically what it means, if you move both sides of your body at the same time, this helps distract your brain from your kind of thoughts and things like that. Things like dancing, moving. If you're having a difficult case at the clinic and you're doing a filling or something like that, get up, get out, change your scenery, do things. Tell the patients, hey, like maybe 5-minute break. Close your mouth for a bit. We'll give you a break, but you take secretly a break, you know? Lastly is explore. Curiosity engages the thinking brain, the neocortex, rather than the reactive brain, limbic system, or brainstem. When we're curious, we shift away from survival mode. What this means is when we're anxious and stressed, our brain reverts back to the limbic system or the brainstem. You go into fight or flight. You don't have the ability to think of things from a third point of view. Engaging yourself in hobbies, things that you do with bilateral stimulation and things like that, that helps out. Okay, so at the end of my presentation, the future hope for all of this is that we do more research, especially in Kuwait. Kuwait is one of the places that are lacking in the mental health department. We need more people to talk about it freely. We need less judgment. We need less stigma. So if you don't want to be burnt out and end up looking like the wonderful ممثلة حياة فهد القديرة, of course, I'm not making fun. Try to have self-care. And self-care differs from one person to the other. What works for me doesn't necessarily have to work for you. What works for you may not work for the other person. So just find your way of self-care and keep practicing it. And hopefully we'll all have a better mental health at some point. Thank you all so much. This was my time for you. These are my references. Awesome.
Thank you, Dr. Mohammed.
Shukran.
Do we have any questions? Anyone?
Anyone burnt out? Yeah. Yeah. Front row. Like,
You all good?
Thank you all so much.
Thank you very much.
Test.
Bismillahirrahmanirrahim. Good afternoon, everyone. Welcome to the first lecture of the second perio session of the KDC. Our speaker is a highly dedicated and talented clinician. Dr. Ala completed her postgrad studies in periodontics and implant surgery at Houston. She is currently a member of the AAP, and actually she just won in the research forum competition of the AAP. Please, Dr. Ala, you can make a start. We are very excited to hear from you today.
وين ليش غيرت؟ ما ادري ليش غيرت. Sorry for the technical difficulties, but ليش غيرتها؟ خلاص, I think should be fine. Let's start. Okay. 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 Bismillah ar-Rahman ar-Rahim. My name is Ala Al-Safar, and today I'll be talking to you about a series of projects that won multiple awards, but the more important thing is that it solves a lot of questions that can help periodontists and dentists in general. So I initially started my dental school in Kuwait University, some fantastic years, and I'm very thankful for all the education they gave us. I went ahead and did a couple of residencies at UT, University of Texas at Houston. A fun fact, UT is the largest medical center in the world. It has over 59 institutions, and they focus mainly on innovation and technology. I am currently in Jabir Al-Ahmed Hospital with some amazing colleagues right here with me, and I'm very happy to be amongst them. Just a brief outline and kind of a mind map of what I'm going to be talking about today. We're going to talk about the history of periodontal disease classification and how it evolved throughout time. A brief overview of the current 2017 World Workshop classification. Some evidence of the discrepancies between periodontal disease diagnosis. We're going to talk a little bit about the types of artificial intelligence. I'm going to explain what a rule-based algorithm is and how we can use it as a periodontal calculator, what a deep learning platform is and how it can assess radiographs in diagnosing periodontal disease. and then how it can generate a detailed report through an online platform. I'm going to briefly discuss the accuracy and agreement of these tools, as well as the limitations of using AI tools in diagnosing periodontal disease, and some future directions and the impact of AI in the field of periodontics. I might be a little bit fast just to, catch up on some time that we have lost. So how did periodontal disease evolve? So, evidence of periodontal disease can be seen over 5,000 years ago in Chinese and Egyptian writings. In modern writings, in about the 10th century, you can see it in some writings by Abacus, which is Abu Qasim in Cordoba, Spain. And then in the last century, you can see a group of very well-known physicians that tried to, reduce and tell us more about periodontal disease, such as bacterial biofilm, bacterial etiology, local factors and systemic factors, such as Orban, Carranza, and others. And then in 1989, we have the World Workshop classification, and this classification was basically more based on the infection host paradigm, and it was heavily dependent on the age and rate of progression. There was some drawbacks of this classification, and the first one is that the gingival diseases category was completely absent, and there was extensive crossover in the progression of different categories of periodontal disease. The age-dependent criteria was actually not validated and did not have very strong evidence, and there was extensive overlap in the clinical characteristics of the categories of periodontal disease. Then we have the European workshop in the 1993 workshop in periodontology classification. They simplified periodontal disease diagnosis into 3 categories: adult, early, and necrotizing periodontitis. Clinicians really loved this classification system. They highly agreed on it, and but it had a broad spectrum of periodontal diseases that were absent. So in 1999, the AAP, which is the American Academy of Periodontology, they updated this classification system by adding gingival diseases, periodontal abscesses, endoperial lesions, developmental or acquired periodontitis. They replaced adult periodontitis with chronic periodontitis, and they replaced early with aggressive periodontitis. Although they did have CAL, or clinical attachment loss, this classification was heavily dependent on pocket depth and the extent of disease, periodontal disease. So since then, a lot of studies came out explaining environmental and systemic factors and the evidence of these environmental and systemic factors in relation to periodontal disease. So the American Academy of Periodontology and the European Federation of Periodontology actually sat together to give us a classification system, or a multi-dimensional staging and grading system where they can always add to it instead of change it with time. So they added the environmental and systemic factors. This classification system was heavily dependent on clinical attachment loss, and they actually published many papers, additional papers that included non-plaque gingival conditions, acute perio lesions, endoperio diagnosis, peri-implant conditions, occlusal trauma, as well as mucogingival conditions. So just briefly, what is the 2017 World Workshop classification? A lot of periodontists may already know it, but it's a multi-dimensional staging and grading system like I previously mentioned, and the staging explains the severity and the complexity of the disease, and the grading looks at the rate of progression and the response of treatment. So when you look at the staging, first we describe it, the severity, which we look at the interdental CAL initially. So if the interdental CAL is between 1 to 2, it's a stage 1. If it's 3 to 4, it's stage 3. And if it's 5 or more, it can be either stage 3 or 4. For the radiographic bone loss, if it's confined to the initial 15%, then it's stage 1. If it's 15 to 33, it's a stage 2. And then if it's extending to the middle third of the root or beyond, it's a stage 3 or 4. And then tooth loss, in stages 1 and 2, we do not have tooth loss due to periodontitis. Stages 3 and 4, stage 3, you can have 4 or less teeth lost due to periodontitis, and stages 5, more than 5 or equal teeth lost due to periodontitis. After determining the severity, we look at complexity factors. So stages 1 and 2 are mostly horizontal bone loss. In stage 1, you can have up to 4 millimeters, and in stage 2, up to 5 millimeters. Stage 3, the probing depths can be equal to or more than 6, the vertical bone loss more or equal to 3, furcation involvements of 2 or 3, and moderate ridge defects. And if the case, if the case can be assigned to all these criteria of stage 3, and you have additional complexity factors such as the need for complex rehabilitation, then you can jump the patient up to a stage 4 category if they have any masticated dysfunction, secondary occlusal trauma, or severe ridge defects and bite collapse, and if the opposing pairs is less than 10. So for the extent, we have, similar to previously, localized less than 30 and generalized more than 30, and the aggressive part of periodontitis was actually replaced by molar incisor pattern. Now for grading, grading can be determined by 2 ways, either direct evidence or indirect evidence of progression. Direct evidence of progression is not very frequent because you have to have x-rays that span over a period of 5 years. And if you have no bone loss or clinical attachment loss over these 5 years, then it's a grade A. If it's less than 2 millimeters, it's a grade B. And if it's more than 2, then it's a grade C category. Most patients will fall under the indirect evidence of progression. So you will determine the ratio of bone loss to age. And if it's less than 0.25, it's a grade A. If it's 0.25 to 1, then it's a grade B. And if it's more than 1, it's a grade C. And you can also look at the case phenotype and the amount of biofilm and how much destruction that occurs. So if you have heavy biofilm and very little destruction, then that's grade A. If the destruction is equal to the amount of bone loss, then it's grade B. And if the destruction exceeds the biofilm, then it's a grade C category. And then they included the environmental and systemic factors that I was talking about. So they included smoking. So if the patient is a non-smoker, it's a grade A. If the patient falls under the grade A category but smokes less than 10 cigarettes, then you can jump the patient to a grade B. And if they smoke more than 10 cigarettes, then you jump it to a grade C category. The same happens to diabetes. So if the patient does not have diabetes or is normal glycemic, then he's under a grade A category. And if the HbA1c is less than 7, it's a grade B. And if it's more than 7, then it's a grade C. So what does the literature tell us about the discrepancies in periodontal disease classification? So you have a study here done in the University of Maryland that looked at 2 groups of clinicians. They looked at practitioners with a periodontal background and practitioners with a non-periodontal background. They gave them both 3 cases. They gave them the classification guidelines, and they gave them a questionnaire. And this is what they found. So they found that about 74% with those that with a periodontal background exclusively just use the current classification system. About 79% of those with a non-periodontal background are not aware or are not using the current classification system. Now, this is in 2001, so the results might be a little bit different now. But what they saw was that there was moderate agreement between the clinicians and the accuracy was not satisfactory. It had a very wide range from 30 to 83%. And although the periodontal group showed better agreement and partially better accuracy, both had problems in identifying risk factors. So another study done in the University of Indiana by Qakar et al. Actually compared 4 groups, and they compared it in terms of diagnosis and treatment plans, where they compared periodontal faculty and residents, general practice faculty, private practice periodontists, and general practitioners. And they saw the agreement between the groups, and they saw that the agreement was actually fair at moderate to at most from 0.3 to 0.5, 1 being the most, by the way. So the overall agreement was very low, and there was no statistical difference between the groups. Now, this study was done by our group, and it is a one-of-a-kind study that actually looked at a different thing. It looked at misclassification of periodontal disease. So for those who are unfamiliar, the EHR is an electronic health record. It's where you store your data and your periodontal charts. So we made a trigger tool that identified the cases that had potential misdiagnosis, and then we manually reviewed these cases, and we also reviewed the cases that were correctly diagnosed. And we saw that about 32% of those cases had misclassification of periodontal disease, and in stage, grade, as well as extent. And that's even when we combine stages 1 and 2 and stages 3 and 4. So that's actually a problem. And there was no statistic significance between either the clinic that provided the diagnosis or the provider characteristics. So what is the significance by knowing, the agreement between clinicians and the misclassification of periodontal disease. If you have diagnostic excellence, then it's very easy to provide the appropriate care for the patient. And then you can see the potential role that technology can play in actually making a very good decision. Okay, so now we're going to talk a little bit about the types of artificial intelligence. In around early 1800s, there was a woman named Ada Lovelace, and she wrote the basics of the computer code. And from the basics of the computer code, we formed algorithms, which is a series of instructions or rules or equations that can help us in giving an outcome. So from algorithms, we developed artificial intelligence, which is, having the ability to mimic the human behavior. And a subset of artificial intelligence is actually machine learning, where the computer has the ability to learn without being explicitly programmed. And a subset of that is actually deep learning, where the computer has, multiple vast amount of data, and there's interconnections between these data to give us a output. A subset of deep learning is computer vision, and computer vision works by giving an image to the computer. The computer will analyze this image, and it will apply insights to that image. There's many types of computer vision that is available, such as image segmentation, object detection, facial recognition. It detects edges. It can look at patterns, classify images, and also match images across each other. Okay. So for us to compare humans to AI, it's very important to look at this graph here. So this graph, the x-axis, you can see how much data or the amount of cases the clinician or the AI needs. And then at the y-axis, you can see the relative human to machine making effort. The lowest being the human making the decision all by himself, and at the top being the computer making the decision all by itself. So for any clinician to gain clinical wisdom, they need to see around 100 to 300 cases to develop clinical wisdom. Now for the AI, it's different. You need to give it more data. So as we go to risk calculators, you have to give it around 500 to 600 to 700 images to make a decision. And then this is the very low type of AI. So it will actually contribute very little to the amount of decision that the physician will make. Now, when you go to machine learning and deep learning, the amount of data that you need to feed the AI is much more, thousands of images or thousands of charts. And then in the decision-making process will actually play a more important part in aiding the clinician into arriving to a diagnosis. So what is computer-aided periodontal diagnosis? It is using computer-generated tools in assisting the clinician to make a diagnosis, and today I'll be talking about two. One is the rule-based algorithm, or what we can call a periodontal calculator, and the other is a deep learning platform, or what I may refer to as artificial intelligence. So first, the rule-based algorithm. Just so that we can understand what a rule-based algorithm, imagine with me going through a zoo with a kid, and we're gonna play, guess the animal. So we're gonna go with the kid, and we're gonna tell him, is the animal big? And the kid has to answer a series if-then questions. So if the animal is big, if the answer is yes, we ask a follow-up question until we reach a conclusion. So the follow-up question might be, does the animal have a long neck? Yes or no? If it's no, then we ask a follow-up question. Does it have a trunk? If it's yes, then we guess it's an elephant. So the rule-based algorithm will go through a series of questions until it reaches a conclusion or a diagnosis. So we applied the same idea onto the 2017 World Workshop Decision Tree. So this is the same as the 2017 World Workshop that I explained in the beginning. It is in a form of a decision tree. It was initially created by Sands et al. So this uses the information that we record from the patient in the form of a periodontal chart, as well as the medical history of the patient to give a periodontal diagnosis. So of course, we have to make refinements to make this rule-based algorithm work in a more optimum condition, especially in the hands of the inexperienced clinician. So the refinements that we made, we told the rule-based algorithm, if you see any third molar, you're gonna exclude it. If you see any implant, you're gonna exclude it. If you do not see bone loss, but if you see furcation in the charting, then you are gonna include it as bone loss, especially class 2 or 3 furcation. Sorry, am I going too fast? Okay. So, and then if there is no radiographic bone loss, if you have at least 2 adjacent teeth with a cal of more than 2, then you would say this is bone loss, even if you do not see it on the radiograph. Now, the cal threshold, instead of starting at 1, we started at 2 because, most people do not record cal in the proper way. So this was to avoid overdiagnosing periodontal disease in this tool. And then if the clinician did not record the gingival margin to the CEJ in his periodontal charting, we told it to completely exclude this chart. Now, if the in an edentulous site, we told the computer the cal next to the edentulous site, you're going to reduce it by 2 millimeters. And then if you have a second molar, the cal on the distal of the second molar should be reduced by 2 millimeters unless the third molar is fully erupted. Because if the third molar is not fully erupted, it can cause bone loss on the distal of the second molar. And then to include some very specific cases that had very localized periodontal disease, those that had cal more than 5 and pocket depth more than 6, we told the computer, okay, you're going to remove the adjacency requirement. And then for the occluding pairs, if there was any implant or pontic and the patient did not need any complex rehabilitation, we told it to include it as an occluding pair. For secondary occlusal trauma, we were more specific in our criteria. We told it to see if there's actually more than 5 teeth that had a mobility of more than 3 to include it in a stage 4 category. And then to consider a case as periodontitis, you need at least 2 teeth with a pocket depth of 4 or more with BOP. This is to include any cases that only had a single pocket of 4. Now, after creating the rule-based algorithm, it gives you a calculator that was actually in the software that the students or the residents can use. So within 30 seconds, it reads all your periodontal charting, and it gives you a suggested diagnosis, and it gives you specific details to why this diagnosis was chosen. And this can be helpful in terms of students to familiarize them with the new classification system. Now, switching gears a little bit and talking about the deep learning platform. So the type of deep learning that we used is called the convolutional neural network. So a convolutional neural network is a network of interconnected nodes and called neurons that processes data in a way that mimics a human brain. So convolution means cross-correlation. So it looks for edges or features, for example, in this bird, and it tries to match it to a very wide amount of data or pictures that it has in the computer, and it tries to match each feature with an object, with another image that has similar features. After it matches all the features, it goes ahead and does pooling, and pooling is spatial dimension reduction, so it reduces the amount of data that it has, and then it goes into the fully connected layer where every input is actually connected to an output to give you a specific classification. So how did we make this deep learning platform? So first, we, with the help of the School of Biomedical Informatics, of course, we developed an annotation platform where the calibrated clinicians can tell the computer, okay, if you have an X-ray, this is how you're going to read it. I'm going to show you an image of how we actually tell the computer how it's looking at things. So we first had calibrated clinicians, and we told these clinicians, okay, now you're going to teach the computer at how to look at these images. After teaching the computer that, we incorporated all of this data into the deep learning network, and then we validated this network. We saw, is it working accurately? Is it working the way that we want it to? After we verified that, we did a user-friendly interface where any clinician can use this interface, put their FMS on it, and then it gives you a detailed report. But before actually letting everyone try it, we actually tested 100 FMSs on this interface, and we validated how accurate it is. And then we did our data analysis. So this is what an annotation looks like. We annotated around 1,900 periapical images. We told the computer, okay, this is our bone area. This is this tooth. This is a filling. This is a crown. This is the CEJ line. This is a vertical bone defect. So we went over 1,900 images. And then this is our user-friendly interface. So if any one of you would use it, you would just put your email, and then you would input all of your FMS on this platform, and you would click submit, and then you can go ahead and do your clinical examination on the patient. And within 2 minutes, it can give you a detailed report of what it's seeing in each of the images. So after you put the images in this platform, how does the computer actually determine the stage or the periodontal disease diagnosis? So first, the computer will identify the teeth. After identifying the tooth, it will look at the bone area. It then will look at the intersection between the bone area and the tooth, and it will mark it. Then it will look at this, it will mark the CEJ line, and then it will look at the intersection between the tooth and the CEJ line, and it will mark that as well. It then will look at the tooth axis, and it will determine the root apices, and then it will measure from the CEJ line to the bone level, and it will measure from the CEJ line all the way to the root apex to determine the radiographic bone distance, the radiographic bone loss percentage, as well as the staging of periodontal disease. It will also identify the furcation involvement. So this is how our report will look like, and it will measure for each individual root if it's a multi-rooted tooth, and it will measure the distance and percentage for mesial and distal to each tooth. So we also had refinements very similar to the rule-based platform. So if there's any third molar or implant site, we told it to remove it. If there is an edentulous area, if there is radiographic bone loss, we told them to remove it from the diagnosis. And then to assign a stage, you had to have at least 2 or more teeth with the highest stage. So if there was a tooth that had 2 different stages on mesial and distal of the tooth, what would we do? We would actually choose the higher stage for the tooth. And because the deep learning platform takes its data from radiographs only, you can very hardly differentiate between stages 3 and 4 because there's complexity factors, and complexity factors cannot be determined through a radiograph. So stages 3 and 4 were actually combined together. We also told the the deep learning platform, if the radiographic bone loss is less than 1.6, this is considered normal and it's considered no bone loss, it's stage 0. And then to determine a stage 1 case to avoid overdiagnosing periodontal disease, we changed the percentage to at least 25% of the teeth had to have a stage 1. Okay, so if there were any images with poor quality, we told the computer to exclude it. And if the same tooth appeared in multiple images, we took the radiograph that had the best quality. And the percentages of radiographic bone loss, instead of starting at 15, we actually started at 18. And this was to avoid overdiagnosing periodontal disease and to include more gingivitis cases. So this was actually from my research that I just presented at the AAP. It's only one slide because it's still unpublished, but it looks at the accuracy and agreement between the expert, and it compared it to the rule-based algorithm and the deep learning platform, and as well as clinicians with less knowledge or experience in the clinical field. So we saw that the rule-based algorithm actually had a higher accuracy and agreement in staging and extent, almost 80 to 85, and because it reads from the periodontal charting and it reads from the medical history, while the deep learning platform has a higher accuracy in the grading category and agreement, because the deep learning platform actually only reads from radiographs. And you can see that the clinician group included students, residents, as well as general dentists. So you can see that the clinicians actually performed the worst than the AI tools in diagnosing periodontal disease. Now, just looking at the diagnostic features, the expert and the clinician always had access to all the patient information. They had access to the periodontal chart, they had access to the radiographic data, as well as the patient information and medical history. The rule-based algorithm, it only looks at the periodontal charting and the patient's medical history. It cannot read radiographic data, while the deep learning platform only looks at the radiographic data and gives us a report. So what are some of the limitations of these tools? So we cannot generalize our samples. Most of the study was done in university settings, 2 schools, University of Houston and University of San Francisco. So we cannot generalize these results to private practice. And then the features of each tool. Each tool looks at different things. So you cannot compare, they're not comparable. So you have to keep that in mind. So the rule-based algorithm looks at periodontal charting and the patient's medical history, again, and the deep learning platform looks at x-rays. And then also the quality and the quantity of the data. If we have a poor quality radiograph, and if the quality of the charting is not optimum, then we cannot expect a good result coming out of the AI tools. Also the quantity, so if the periodontal charting is not complete, or if the PAs are missing, so this will affect the accuracy of the tools. And I want to stress something. The AI is not to replace you. You have to always exercise clinical wisdom. For example, this case, if you put it into the AI, it will very easily give you a stage 3 periodontitis case. But anyone with clinical wisdom will see that this is actually due to a shortened route from orthodontic treatment. So in this case, you actually have to exercise your clinical wisdom and say that this is actually not a periodontitis case. And this was actually the first study that looks at 2 AI tools in diagnosing periodontal disease, and we hope that by combining them, we can assist the clinician to arrive at a more accurate diagnosis. Now, what is the future directions of this? We hope that it can help in education, familiarize clinicians with the 2017 World Workshop classification. It can improve the accuracy of inexperienced clinicians and improve clinical practice. So the way you diagnose and identify periodontal disease in your practice. Its use in dental research is very, very, very wide, and we hope that it can also improve clinical quality control. There is always a chance, there's always room to improve the accuracy and agreement of AI, and we hope that we can combine them into a single interface, again, to help diagnose periodontal disease. And just like a kind of concluding remark, we should always keep the fundamental rule of biomedical informatics. The AI or the computer-aided tools are not to replace the clinicians. They are not to replace you. They are to help you get to a more accurate diagnosis, to help the patient reach or get treatment in the proper timing, the more accurate treatment, and prevent the patient from going in circles. This is me and my co-residents, my support system, and in the recent AAP meeting. And thank you so much for listening. This is actually supposed to be an animated video. It's asking you if you have any questions, but the audio is not working. So I'm open to any questions if you have it.
Thank you very much for the very informative lecture. I think we have time for a question or two. Anyone has a question?
Thank you, Dr. O'Shea. Mashallah, very, very promising research, very, very interesting. My question is, when you're, I guess there's 2 types, right? The first one, you input the data, the CAL, the probing depth to OHD, and then the other one, it reads the radiographs for you, right?
Correct.
For the first one, was it all the same clinician that inputted the data? Well, how did you correct for minor discrepancies in terms of angulation?
Exactly. So actually, the first tool was actually checked by 5 experts that have, diplomat in ABP. And then it was tested on over 3,000 cases and validated on over 3,000 cases. So it was checked, and these refinements were made to actually improve the accuracy after checking them on these 3,000 cases. So yes, like you said, we first make the tool, we test it, and then we actually validate it, and we see how the clinicians like it. We also see the acceptance of the clinician of the tool as well. So we look at all of these stuff, and we do put in mind the angulation. That's why it's calibrated through a series of clinicians, not only one.
Right, because I think there is a previous study, I don't remember it, where there's a discrepancy of 1 to
1 millimeter, yes. And that's why we changed the CAL threshold by 1.
I noticed that, and I think that was great, even excluding the distal to extracted sides, because it could mislead, and I saw you change the percentages to 18% just to adjust for these things.
That is correct.
My second question is, what about when I'm uploading the full mouth series? Are we doing PAs or vertical bite wings?
So this was actually trained on periapical radiographs. So the gold standard to diagnose periodontal disease is a full mouth series, but for vertical defects, it's very hard to look at the bite wing except if it's a vertical bite wing. But with the vertical bite wing, you don't have the apex of the root, so it's very hard to determine the ratio. So that's why our focus was mainly on the periapical radiographs.
But then with the PA, then there's discrepancies with the angulation.
Exactly.
I mean, even on a clinical day-to-day, it's hard to get it 100%
Yes.
right. So
That's why it's one of the limitations. And then that's also, if it's very severely angulated, the AI will not read it. So it will give you, for this PA, it will not read it. It will give you a blank, its image cannot be read. So that's why we try our best to have the best radiographs. Even when training the AI, we train it with the very best radiographs. A little bit of discrepancy, because sometimes it should read if it's very little bit angulated.
Right.
But if it's very angulated, it's one of the limitations, it will not read it.
Okay, and then I have a lot of questions. I'll talk to you
Yeah,
after.
go ahead.
But just out of interest, do you think in the future, with even better radiographs, that where we could see the soft tissue, that the AI could calculate at least interproximal cal, or is that highly unlikely?
Well,
On the
with
buccal
soft
level, I
tissue,
think it's
there are.
difficult, but on the
Yes.
interproximal, sometimes you can see the soft tissue, you can see the CEJ, you can see the base of the pocket. But it's not
Right.
the same as tactile, but
Correct.
maybe.
So we know a study by Hosman et al. In 1999 that the cal actually precedes the radiographic appearance of bone loss or any periodontal disease by 6 to 8 months. So that is one of the answers I can give you. But there are some studies. There was one currently by the University of Michigan that presented with me. He was looking at the soft tissue thickness using an AI tool, but he trained it using an ultrasound. But these are very, very hard to train because it differs. You're looking at angiogenesis and you're looking at different stuff. So AI is still, I won't say it's in the initial phases, it's a little bit advanced more than that, but there's many applications to it. If the radiographs are very good at detecting soft tissue, then that might be a good thing to look at. But people are looking into using AI and CBCTs and a lot of other stuff. So it's definitely an open subject to explore.
Very, very promising. Thank you very much.
You're welcome.
So if you have any question, you can ask Dr. Ala directly. We need to stop. You are running late of time. Thank you.
Thank you.
عندك HDMI واحد ايوه عندي واحدة بس خليني اتاكد مم. هذا مو الكليك دقيقة عندي فلاشي انا ثواني انا ابالي هذه مال يعلق هذا مال ابل هم؟ إيه لا. اوكي
Okay, welcome back everyone. We're moving on to the next topic of talk. We have our respected presenter, Dr. Abdul Wahab Al-Kandiri. He received his training in periodontics, a master's degree from Oklahoma University. He's interested in the educational field, being a full-time faculty at the Kuwaiti Board of Advanced Dentistry and the director of the International Team for Implantology Study Club in Kuwait. He is interested in giving topics in the surgical and non-surgical periodontal therapy, as well as implant surgery, especially in the topic of guided implant surgery. So with that, please, let's welcome all Dr. Abdul Wahab for his talk.
hello Allah. Welcome everyone. So basically there was a presentation before mine. It was detailed. Oh, amazing job ما شاء الله. I'm surprised إن يعني الحين صار عندنا محاضرين almost to the international level ما شاء الله. Basically I'm gonna follow up. I'm gonna talk about the diagnosis, classification, but my focus is mostly not for specialists. And for me, I've encountered in my short period of time working in يعني صار لي 8 years back in Kuwait, 7 years back in Kuwait. Most of the problems we have is when to refer to a specialist or when to take the case by yourself. يعني you take care of the case. فباسically أنا مركز على الجي بيز. مركز على الناس اللي قاعد تشتغل بالمستوصفات. الفرونت لاين مالنا. متى أنا راح أشوف الحالة؟ متى أنا راح أحول الحالة؟ فباسically I will make the classification يعني the simplest way. لما ترد البيت إن شاء الله من هني راح تعرف stage 1 2 3 و 4 1 و 2 حقي 3 و 4 حق السبيشالست. اوكي فراح نبدي ان شاء الله عاد هذا يشتغل. اوكي التوبيك اوتلاين راح يكون بداية راح اتكلم عن definitions بس I will go very briefly ترى very fast. اوكي الشغلة الثانية راح تكون عن البروجنوسيس which is part of the classification now. It used to be separate. Okay. اللي بعده راح يكون periodontal treatment planning, overview of the new classification, وبعدها الكلاسيفيكيشن ستيب باي ستيب. الحين انتم اكيد شفتوا you saw the table والدكتوره ما شاء الله عليها فصصت لكم التيبل يعني حتى اللي كان موجود. I will not go through it يعني as detailed as her. I'll go very fast. بس بعدها راح يكون في عندنا flow chart. انا هني حق decision making. For you guys to decide, for you guys to know and be confident when to take care of the case and when to refer. Okay. وراح اعيد وايد حكي اكثر من مره عشان شنو نفهم احنا شنو هو الستيجنج والجريدنج. اوكي. اول شيء ببدي بالهيستوري. اول بيريو متى كان؟ ترى احنا تخصصنا قديم 1806. هني درينا ان في gum disease. اوكي. بعده 1942. وباي ذا واي ترى الدكتور علي وشهري took a huge part in this presentation. He helped me a lot. So thank you very much, doctor. Okay. فهير in the history كان حق الحرب العالمية الثانية. يبي يعرفون هل هذا ال coming soldier is fit or not fit to become one. Okay. فكان هذا حق الارمي second world war باليو اس. اوكي. بعدها 66 درينا ان في شيء يكون متاخر كرونيك يطول. اوكي. بعدها شنو صار؟ بعدها شافوا بعد ما قال يطول ما يطول شافوا ان في شيء حق الصغار شيء حق الكبار. فهني بداوا يشوفون الايج ما قاعد يشوفون الديزيز اتسلف. يشوفون ان في certain age في ديزيز اليونج. بعدها ركزوا عليه فزاد صار بيبرتل وقعدنا ايرلي اونست فاست فورورد. الحين هني شنو قاعد نطالع الايج. We're classifying according to the age difference. هذا المين يعني هو في وايد شغلات تفاصيل بس انا ما بتكلم عنها. اوكي. هني صار early onset adult. بعدين دش necrotizing ulcerative periodontitis بالulcerations. اوكي. هني انا كنت resident ارميتاج 1999 واول ما تخرجت شنو يالنا النيو كلاسيفيكيشن. اوكي. شنو اللي يميز النيو كلاسيفيكيشن؟ هالكلاسيفيكيشن شافوا الشغلات اللي هم احنا كنا نستخدمها بالبروجنوسيس، شغلات نستخدمها حق الكلينيكال فايندينجز، قبل كنا بروبينج كلينيكال اتاتشمنت، هذول قاموا يركزون على اشياء ثانيه. اوكي. ولاحظوا في اغلاط، في اشياء مو اغلاط يعني في اشياء كانت تحتاج امبروفمنت from the old classification. اوكي. شنو هم الاشياء اللي لازم تتغير؟ لاحظوا ان السي جي وايد صعب ان نلقاه واحنا نقراه. وايد صعب ان نلقى السي جي. وراح اوريكم بعد شوي بطريقه سريعه شلون راح تحسبون الكلينيكال اتاتشمنت لوس. اوكي. ولا ليفل. اوكي. وشافوا ان ان جنرال في اشياء ثانيه غير مثل البليدنج اون بروبينج، مثل الاكس راي، البون لوس اللي تشوفه احنا بالاكس راي. هذه شغلات ثانيه احنا لازم نشوفها and we keep in mind while doing our diagnosis. Okay. So what are the principles of the new classification? اول شيء صار في شيء جديد عندنا اللي هو intact on a healthy periodontium. الحين احنا لما نسوي الكلاسيفيكيشن لازم نعرف شنو هو الهيلثي. في عندنا هيلثي بعد ما صار في بيريود ديزيز بدون تريتمنت، وفي صار هيلثي بعد التريتمنت، وفي هيلثي فبعد التريتمنت يصير ريديوست بيريودونتيوم. الحين ريديوست في جنجفايتس ما في جنجفايتس، رد مره ثانيه صار بيريودونتايتس. هذه الاشياء كلها تتكلم عنها النيو كلاسيفيكيشن. اوكي. اول شيء لازم نفهم، انا كنت متوقع انه وايد من الجي بيز راح يكونوا موجودين، ف ام فيري بيسك. انا احب البيسكس عشان نفهم شنو الفرق بين الجنجفايتس والبيريودونتايتس. الجنجفايتس اللي هو it will include only the soft tissue, only the soft tissue, the soft tissue part. الجنجفة، الاتاج جنجفة، just the soft tissue. Periodontitis it will include شنو؟ الهارد تيشو هو البون. Once we start to have periodontitis it's not reversible. حتى بالستيجنج مرات الستيج يظل نفس ما هو ترى بس controlled. اوكي. فلازم تعرفون هالاشياء. gingivitis soft tissue, periodontitis, soft and hard tissue. Okay. فمثل ما قلت لكم بالكلاسيفيكيشن احنا عندنا patient with periodontal health يمكن يصير فيه gingivitis بس once we treat the gingivitis the patient can go back to periodontal health. So it's reversible. Gingivitis is reversible. فاحنا اذا لحقنا على الكيس gingivitis نقدر نعالجها وبرافو علينا ونحطه maintenance وخلاص والسلام عليكم. اوكي. البريدونتايتس كيس غير. فالحين لما عندنا patient periodontal health يكون healthy gingivitis يضر gingivitis او اذا عالجناه يصير periodontal health و peridontally healthy for diagnosis. بس once we have periodontitis patient where it will include the hard and soft tissue راح يصير عندنا 3 different scenarios. periodontitis patient stable. الحين في الماركرز اللي قاعد بنشوفهم احنا هذول الاشياء المهمه بس اذا انتم سويتوا مره مرتين ثلاثه راح تكون by default. You will know them by default. Okay. bleeding and probing شيء مهم لازم نعرفه. البوكيت depth is another important thing. وبعدين اذا احنا بنشوف مثلا عالج البيشنت بنشوف اذا هل هو للحين بيريو نحط له بروب نشيك اذا 4 ملم اوكي بس ال 4 ملم بليدنج هني نقول احنا still an active periodontitis case. اوكي اتس فيري سمبل. يعني شوفوا في شغلات معينه راح اركز عليها. ريميشن يكون عنده بليدنج. اوكي يكون عنده بليدنج اكثر من 10%. unstable اللي هو يكون more than 4 ملم or 4 ملم and bleeding still. اوكي الحين شنو الهيلث شنو الجنجيفايتس بالانتاكت بريودونتيوم. اوكي الاتاتشمنت لوس ما عنده. البروبينج بوكيت ديبث يكون 3 or more or equal or 3 like 3 or less. اوكي bleeding on probing يقول دائما less than 10%. لما يكون جنجيفايتس يصير more than 10%. اوكي راديوكالفيك بون لوس ما يكون عندنا. هذا الانتاكت بريودونتيوم. اوكي اللي بعده reduced periodontium in non-periodontitis patient. يعني هذا ما شاف periodontitis didn't have a treatment. اوكي فشنو يصير عنده؟ نفس الشيء probing attachment loss يكون عنده فوق ما عنده. اوكي probing pocket depth ليش؟ لان هذا صار في بيريو وبعدين راح. فهمتوا قصدي؟ اوكي انا ما ابيكم تملون. فاللي بعده successfully treated نفس الشيء. يكون عندنا شنو؟ يكون مثلا عندنا recession نشوف الروتس بس شنو؟ ما يكون عندنا bleeding. البوكيت ديبث كلهم 3 ملم or 4 ملم already treated. okay ما عندنا signs of inflammation. So this is reduced periodontium. This is a new thing we have here. Okay for one more time I will explain it to you guys in a different way. Periodontal health intact periodontium no clinical attachment loss or bone loss. نفس ما قلنا الروت مو مبين الفوركيشن involvement مو موجوده القم مو نازله وايد الضرس مو مبين يعني مو بس beyond the CEJ مبين. فهالحالات احنا we know ان the patient is stable from the periodontal part. اوكي الحين reduced periodontium هذا الشيء الجديد اللي لازم تعرفونه. periodontitis patient يكون stable او يكون non periodontitis patient ومرات يكون من شنو؟ ما يكون حتى من البيريو مرات يكون مثلا من crown lengthening or aggressive brushing لما يكون عندنا recession. صح؟ اوكي فهذا هو البريدونتال هيلث. Case definition less than 10% of bleeding and probing with pocket less than 3 mm equal or less than 3 mm. Stable periodontitis control of local and systemic risk factors resulting in minimal of less than 10% bleeding sites probing depth less or equal to 4 mm with no bleeding. بس 4 bleeding خلصنا. اوكي الحين حندش على ستيب باي ستيب. اول شيء لازم نفهم الكي elements in the new classification. شنو هم الكي elements in the new classification؟ اول شيء ال new classification is looking at the severity degree of the periodontal breakdown يعني ال percentage of the bone loss ال clinical attachment loss هالامور هذه. اوكي الشغله الثانيه ال extent localized generalized. اوكي يعني كم tooth is involved in it. اوكي والcomplexity probing depth type of bone loss furcation lesion tooth mobility missing teeth. هذا complexity. The more it is the more complex it is the more you have to refer. ترى this is the main reason why I'm here. بنعرف متى we refer, متى we take care of the case. Okay? Rate of progression and then risk factors such as smoking and diabetes. Okay? Clinical definition of periodontitis. شنو هم ال 3 factors? Loss of periodontal tissue support manifested through clinical attachment loss and radiographically assessed alveolar bone loss. The presence of periodontal pocket and gingival bleeding. هذه الأشياء كلهم مع بعض هم شنو؟ periodontitis. خلصنا؟ 3 points. Okay? الحين حق شنو؟ They should include identification of patient with periodontitis case, identification of specific type of periodontitis, okay? Description of the clinical presentation and other elements that affect clinical management, prognosis and potentially broader influence on both oral and systemic health. يعني احنا الحين بالنيو classification ما في جدول احنا نمشي عليه. It's patient to patient based and clinician to clinician based. يعني عادي انا periodontist مع periodontist ثاني and we have different يعني diagnosis. بس there are landmarks we don't jump from 1 2 and 3 4. يعني انا ما اقدر اقول 1 والبريدنتست الثاني يقول لي 4. اقول له تعال شنو السالفه؟ في شيء غلط. بس 1 2 3 4 they are normal. Okay? الحين البيشنت is a periodontitis case when the clinical attachment is detectable for 2 or more non-adjacent teeth. يعني ما يصير 2 adjacent teeth next to each other تحط لي بروب بالنص وتحسبهم اثنين. They have to be in different sites. Okay? يعني 2 different teeth. ويكون عندنا هالشيء. أو إذا ما عندنا هالشيء نروح نشوف الريسيشن على البكل. نحط له بروب. لازم يكون عندنا 3 ملم من الريسيشن بليس. يعني from the gingival margin where the recession is نحط له بروب بكل. صار 3 ملم اوكي نطق بريك هنا نقول هذا بعد periodontitis. اوكي the observed clinical يعني وفي اشياء احنا ما نعتبرها perio cases. يعني root fracture عندنا wisdom tooth شلناه distal to the 7 الدش البروب راح 6 7. هالاشياء هذه احنا ما نشوفها as a perio case. It's caused by a local factor, a different local factor. اوكي وفي endodontic الvertical root fracture مثل ما قلت لكم. ففي اشياء احنا we have to think of once we have 1 site or 2 sites بس والباقي everything is healthy. We have to see maybe it's a local whatever يمكن endoperio region يمكن abscess. فاحنا لازم we have to know when we do these things. الحين خلينا نبدي بسرعه كذي. ادري انا توكم سامعين بس راح اعطيكم اياها بطريقه سريعه ثانيه. عندنا staging وعندنا grading. اوكي فالستaging عندنا 4 stages والجريدنج عندنا 3 A B C. حلو. فاحنا الحين نبدي بشنو؟ راح نبدي راح تنط والله المفروض تنط. ايوه انزين. اول شيء نبدي بالستaging. الستaging نشوف شنو نشوف بالستaging؟ الستaging نشوف severity of the disease at the presentation يعني الاكستنت والcomplexity of the disease management يعني furcation involvement. هذه واحدة من الكومبلكسيتيز سهلة عشان الكل يفهمها. اوكي this is one of the complexities. فعندنا بالستaging في scoring قلنا 1 2 3 4. شنو هم؟ stage 1 initial periodontitis اللي هي the most mild kind of periodontitis. اوكي بعدها stage 2 اللي هو المودريت. انا I believe everyone can treat stage 1 and stage 2. اي واحد خرج من الجامعه يشتغل كدنتست should be able to manage stage 1 and stage 2. وين احنا راح نفتك من الحاله؟ لان احنا عندنا ضغط مثلا بالمستوصف. متى نقدر نحول؟ انا I believe according to what I have seen 3 and 4 مبين. شوف الحالات. These things will يعني especially stage 4 زين it will need more than one يعني multidisciplinary treatment. pros surgeons ortho يمكن فاكثر من شخص. فانتم لازم في حالات تحولونها على طول من البدايه once you recognize. the worst is stage 4 يعني stage 4 for sure. يعني اذا انت بطل الابطال راح تدق على صاحبك البريدونتست راح تدق على احد راح تقول ايش اسوي بهالحاله. اوكي. فاحسن شيء يعني stage 4 and 3 I would think that you should refer them to the specialized center or a specialist. Okay. عندي مشكلة بهذا. الحين خلصنا من الستيجنج، نيجي حق الجريدنج. الجريدنج شنو يشوف؟ information of the biological features of the disease. يعني شنو؟ يعني مثلا شنو هي الدكتور عبد الوهاب؟ يعني انا ما اشوف كالكولس، ما في كالكولس، في بريدونتال ديستركشن. انت منظف؟ لا انا مو منظف قبل، مسوي سكيلينج مو مسوي سكيلينج قبل. هذا this is the worst type. بس لما انا اشوف كالكولس وما اشوف وايد بون لوس، this is the good type. there is no rapid loss of periodontal attachment due to what I see. البايوفيلم اللي موجود. فهمتوني؟ It's very easy to see. يعني ما اشوف كالكولس، ما اشوف شيء، بس كله يعني فركيشن انفولفمنت وموبيل تيث ولويا وانفلاميشن، بس ماكو كالكولس، ماكو شيء. اوكي. والريت اوف بروجريشن. وبعدين في شغلات ثانيه اللي احنا ما نتحكم فيها، سموكينج اند دايابيتس. هذول الشغلتين لعبتنا احنا البيريدونتست. اوكي. سموكينج، ما سموك يسموك، ماكو امبلانت تريتمنت غير، نعطيك انتي بايوتيك. ف these things you have to consider. يعني ستيج 3 and 4 يكون البيشنت سموكر والدايابيتس ماله 1000، لا انا احوله. why should I take care of that؟ اوكي. والريسك اسسمنت هم هذول اللي انا تكلمت عنهم توني. الحين الجريدنج سيستم هذا السلو ريت مثل ما انتم شايفين، ما عنده وايد بون لوس، everything is good. جريد بي moderate rate of progression، تشوفون وين واصل البون لوس. هذا كان على بالي راح يطلع حلو بس بعدين المهم هني. اوكي. وبعدين جريد سي اللي هو الورست. اوكي. how many minutes do I have؟ انا قاعد امشي طياره. I have time؟ اوكي. الحين الستيجنج، سوري، الجريدنج اول شيء. اوكي. الدكتوره شرحت لكم كل شيء، انت كنت يعني اعتقد الاغلبيه كانت حاضره. فنشوف الفينوتايب ونشوف البون لوس according to the age. في تيبل راح يطلع بعد شوي، اذا تبون اصوروه شلون تحسبون البروجريشن ريت اوف بون لوس according to the age. This is one of the basics، هو من اهم الاشياء اللي احنا نشوفها. بعدها الفينوتايب، بعدها السموكينج، نون سموكر less than 10 more than 10. واغلب الناس عندنا بالكويت they're more than 10. يعني اغلب البيشنتس عندنا بالكويت ما في عندنا واحد يدخن سباكيت. العموم يدخن اكثر. زين. بعدين دايابيتس، احنا نشوف الاتش بي اي 1 سي مو according to the American Diabetes Association، لا احنا نشوف على 7. فديروا بالكم يعني هذا هني still is a questionable diabetic patient. بس احنا عندنا حق الجريدنج less than 7 شنو يكون؟ grade B. اوكي. more than 7 grade C. اوكي. الستيجنج هي شويه معقده اكثر، بس في خط احمر بين الجي بي وبين السبيشالست، بيننا احنا مع الجي بيز. شنو هو؟ ستيج 3 and 4 خلاص لا تفكر، حول. ستيج 1 and 2 لا، انت جاب الحاله، حاول كثر ما تقدر، اذا ما انحلت المشكله بعدين حولها. بس هذيل انتم لازم تحاولون تحلونها. الكلينيكال اتاتشمنت لوس 1 to 2 3 to 4، راديوغرافيك بون لوس. اهم شيء ترى، اهم شيء انتم يعني انا لما تجيني الحاله بالعياده سواء بالخاص ولا بالحكومه، ما يعني يكلمني الريزيدنت وهذا، اول شيء اشوفه الاكس راي، بطلي او بي جي، ابي اشوف الحاله ان جنرال and it's very clear you can see. يعني مع الوقت قاعد اقول لكم مع الوقت راح تشوفون، يعني حتى من الكلاسيفيكيشن بس من البون لوس وبس تطلب حج المريض راح تعرف ان هذا ستيج 3 ولا 4 because you have to count the number of teeth lost due to periodontal disease. في رقم معين موجود هني. زين. vertical bone هني عندك 4 teeth or less. اوكي. 5 or more راح يصير معانا 5 كذي بس على السريع عشان تعرفون تفهمون الوضع. بيريو كيس قاعد تروح الاسنان، في اسنان وعندنا بون لوس كامل وعندنا لوس اوف تيث، خلاص هذا يا 3 يا 4 احوله. اوكي. الحين احنا دش البيشنت العياده نبدي معاكم ستيب باي ستيب. انا مشيت على السريع عشان تعرفون بريدونتال هيلث، متى يصير عندنا بريدونتايتس بعد ما نسوي تريتمنت and that's it. الحين you just need this. اوكي الحين patient suspect of periodontitis شنو راح نسوي؟ اول شيء نشوف الاكس راي if it's available. ما عندنا اكس راي نسوي له اكس راي. diagnostic quality of the full mouth نشوف مثل ما وريتكم ساعه ان اذا في big destruction less destruction calculus فيه ما في calculus عشان الجريدنج all of that should be يعني براسنا. اوكي detectable marginal bone loss اذا هذول كلهم موجودين اوكي راح يصير عندنا suspect of periodontitis. we move to the next step. اذا ما عندنا هالاشياء نروح نشوف اشياء ثانيه. assess الانتردنتال clinical attachment level buccal or oral recession نفس ما قلت لكم نشوف نحط البروب باماكن recession. اذا ما طلع عندنا انتردنتال في probing ولا clinical attachment نروح على البكل اوكي ونشوف we measure البليدنج and probing ما في it's periodontal health less than 10% periodontal health. يعني اوضح من كذي we are all good تمام. الحين متى يصير gingivitis؟ لما يكون more than 10% bleeding. localized ولا generalized هذا ترى ما في وايد حتى في بعضهم. if it's 10 to 30 it's localized gingivitis. more than 30 generalized gingivitis. احنا كلنا نقول gingivitis في localized في generalized. اوكي الحين اذا عندنا interdental clinical attachment loss نحوله suspect buccal recession more than 3 ملم بالبروب دشينا خلاص we are suspecting انه periodontitis case. نكمل نروح حق اللي بعده. هذا ما راح حق اللي بعدها طلع. اوكي انا هذا ما عجبتني. الحين يكون عندنا suspect of periodontitis. نشوف اللوكال فاكتورز. احنا مو قلت لكم من اول شيء نشوف اذا بس مكان واحد عندنا ديب بوكيت صح؟ هذا المكان نيجي نشوف هذه الاشياء. vertical root fracture, caries, restoration, impacted wisdom, overhang في وايد اشياء. بس على هالسايت we have to exclude them first. we exclude everything عشان تكون purely perio case. اوكي؟ اذا هذين موجودين يرد ترى يصير healthy او gingivitis localized ولا generalized. اوكي الحين عندنا clinical attachment loss اكثر بين 2 teeth ولا more لا ما عندنا نرد نشوف الجنجيفايتس. عندنا اكثر من 1 tooth clinical attachment loss ندش على البيريو تشارتنج وناخذ راديوجراف ونسوي الاكزامينيشن مالنا. اوكي نشوف البوكيت is 4 or more no ردينا على reduced periodontium اللي قلت لكم انه هو already كان treated. ونشوف الحين البوكيت دشت 4 بس صار في bleeding ما صار في bleeding ما في bleeding reduced but healthy periodontium patient plus gingival inflammation and periodontitis patient اذا عندنا bleeding. اوكي المهم الحين نروح حق البيج شارت اللي انا احس ان هذا وايد مهم. اول شيء لما نشوف انه هو الحين خلاص صار بيريو كيس في clinical attachment loss في عندنا الساينز اند سيمبتومز اللي انا قلت لكم اياها. ني اول شيء نشوف اذا localized ولا generalized. more than 30% generalized less than 30% localized. نشوف بعدين الليفل اوف بون اند clinical attachment loss. البون لوس كورونا عندنا بون لوس تو ذا coronal third والclinical attachment loss is less than 5 ملم هني لعبه اللي قاعد بالمستوصف. شنو يسوي؟ راح تكون باي ديفولت. ثاني شيء شنو تشوفون بالاكس راي؟ في مكان تراينجل اسود على الفركيشن ولا ما في؟ في يعني فركيشن انفولفمنت صح؟ انزين اذا ما في نكون نقضنا روحنا ودشينا نشوف البوكيت دبث بالاماكن اللي احنا شاكين فيها 3 or 5 ما في periodontal tooth loss ما عندنا due to perio disease. اوكي هذول ماكو هذول الاشياء كلهم ماكو. شنو يصير عندنا؟ stage 1 or 2 خلصنا ترى خلص الموضوع انتهى. اكس راي نفس ما شرحت لكم هذا كله ما في tooth loss pockets less than 3 or 5 ملم ما في فركيشن انفولمنت، كل هذا تقدرون تشوفونه، ترى اغلبها تقدرون تشوفونه بالاكس راي. اوكي، جنرالايزد لوكالايزد، هذه الاشياء كلها نقدر نشوفها بالاكس راي. زين هني بعدين بنفصل بين الستيج 1 و 2 ليفل اوف بون لوس اند كلينيكال اتاتشمنت لوس، هني بس على ستيج 1 و 2. اوكي، وترى both of them have the same treatment options. Non-surgical periodontal therapy most of the time works for these. Okay, البون لوس less than 15 والكلينيكال اتاتشمنت لوس 1 to 3 1 to 2 stage 1. البون ليفل 15 or 33% والكال 3 to 4 stage 2. خلص انتهى الموضوع. واضحه؟ واضحه؟ تمام. انزين الحين اذا كل واحده من هذيل مو موجوده، مثلا قلت لكم انا من ساعه الفركيشن انفولمنت في عندنا 2 or 3، لا نطلع من ستيج 1 2 خلاص على طول نطلع، وراح يبين معنا بالاكس راي. البوكيت مور ذان 5 نطلع من ستيج 1 and 2 خلاص ما راح يكون عندنا احنا بالمستوصف. periodontal tooth loss عندنا due to perio disease نطلع. most of the time يعني ان شاء الله عندكم راح يكون يعني easy to differentiate من الاكس راي حتى مو من الكلينيكال اتاتشمنت وهالسوالف والبروبينج. اوكي، الحين ستيج 3 and 4 شويه معقدين. perio tooth loss 1 to 4، اذا عندنا 10 or more occluding pairs، bite collapse drifting flaring، no severity of ridge effect، هني نروح بستيج 3. اذا كل هذيل اغلبهم يس، اذا عندنا مثلا more than 4 teeth خلاص we always go to the worst. اوكي، شنو عندنا worst؟ شيء واحد worst نروح عليه. اوكي، واخر شيء في مفاجاه يعني حقكم، يعني انا الحين قاعد اشرح لكم اياها بس شوف جزء من المحاضره اللي قبل كانت something to make your life easier. الحين اذا عندنا البيريو tooth loss more than 4 وعندنا less than 10 occluding pairs وعندنا bite collapse بالدرفتنج، عندنا bite collapse patient have difficulties in chewing, difficulties in biting and everything. okay, severe ridge defects or effects يعني عندنا due to perio disease وبعدين he lost the tooth due to perio، الرج ما راح يكون موجود اصلا يعني في يكون almost no bone، فهني ندش بستيج 4. هني حتى احنا عندنا راح يكون مشكله يعني. okay, we will need a lot of attention. الحين تخيلوا هذا يكون ستيج 4 وجريد بي، الرجال يدخن اي شيء يدخن اكثر من 10 سيجارات خلاص هذيل الموديفايرز يعني يو هاف تو سكيب. يعني مثلا الحين عشان اشرح لكم اياها تفهمون، اذا عندنا previous record نشوف and we estimate in the past 5 years. most of the time in Kuwait we don't يعني here we don't have a lot of history x-rays، واذا عنده مكان ثاني وما يقدر يجيب الاشعه وهذا، ففي another way الميجرمنت اللي هو البون لوس على الايج اللي هم 15% 33 وان يو جو and find the worst one يعني اسوء واحده تشوفونها وتحسبون عليها هي. اوكي، فاذا less than 0.25 grade A، 0.25 to 1 grade B، more than 1 grade C. الحين this is the basic، هذا البيسك مالنا، بس في معاه موديفاير نقدر ننط بين C A B. شنو هم الاشياء هذه اللي تخلينا ننط؟ شغلتين: smoking diabetes، non smoker خلينا نسمع هو مثلا كان more than 1 grade C ما راح يتغير، بس هو مثلا he smokes more than 10 cigarettes a day upgrade to C. اوكي، diabetes كان A بس controlled يظل A، لا non controlled ينط من A ل C، لأن الموديفايرز they are very important، لأن these are the things that you will not control. You will not control these things بالعيادة. You have to يعني 8 اوكي انا والله اندمجت بس يلا خلينا نطوف عيل. انزين هني المايل تو مودريت بريدونتايتس اللي انا شرحت لكم اياها اول شيء ستيج 1 and 2. جريد A most of the time اللي انا ابيكم تجابلونها بالمستوصف، لا تحولونهم، خلوهم اذا ما قدرتوا عليهم حولوهم، بس انه هني الفلتر 1 2 1 2 نخليهم. ترى حتى عندنا الشباب الاي جي دي يكونون بالمستوصفات نفس الشيء نفس الكلام 1 2 جاب لهم. 3 اذا انت شاطر مشتاط وكنت حاب البيريو بالريزيدنسي اوكي جاب لها. 4 حولها تكفى، يعني حولها على المراكز، خليهم يجابلون البيشنت. اوكي. ومثل ما قلت لكم 3 و4 جريد بي سي هذيل الكومبلكس كيسز يعتبرون. تمام. انا كنت بوريكم الكلينيكال اتاتشمنت لوس، بس I think I have to skip this. خليني اوريكم بس شغله واحده. هني لما نحسب البون لوس ناخذ A ولا B؟ صح، انا فخور فيكم. تمام. خلاص انا ما قمت احاتيكم. يلا تمام. انزين هني شلون نحسبها؟ اللي بيحسبها هذا الايكويشن. اوكي. وهذه الحالات اللي انا اتمنى انكم تشوفونها عندكم بالمستوصفات او بالعياده الخاصه اذا انت جي بي ولا انت عادي. You can do this. You can face this and have amazing results. اوكي. هذه ستيج 2. شوفوا البون لوس اوفرول ما في فركيشن انفولفمنت. يعني انا عندي لما اطالع الانتيريورز ايش كثر البون لوس فيه، بعدين اروح اطالع المولرز على طول، بعدين بطل حج المريض اشوف في كالكولس خلصت يمكن 70% من الدايجنوستس مالي. اوكي. الحين كيسز بحط لكم هذول ترى كلهم من اليوروبيان والامريكان، يعني ماخذهم انا من الاونلاين. يعني شوف هذا الحين حاله انتردنتال كلينيكال اتاتشمنت لوس مور اور هذا مليمتر وين ديتكتيف سي اي جي. شنو يطلع عندنا؟ ستيج 1. انت الحين قاعد تفهمون صح؟ ما في ريسيشن، ما في سي جي مو مبين، بس في عندنا اشياء كذي شاكين فيها. اوكي. how many minutes I have؟ ترى انا وايد دقيق بالوقت. اوكي خلاص خلينا نطوف هذيل. الحين هذيل بس حالات، هذيل you can watch them online، ترى موجودين اونلاين. اوكي. بس الحين مبين، يعني هذه الحاله لو اقول لكم كلكم راح تعرفون شنو هذه اللي قبلها صح؟ تمام. هذا الجريدنج بس عشان بغيت اوريكم مرات الجريدنج يكون الموديفايرز يكونون كبار. زين سوري بس can I fast forward this؟ I have to skip this. Peri-implantitis. Okay, peri-implantitis very easy. Peri-implantitis اذا عندنا امبلانت جاينا المستوصف حطينا البروب طلع بليدنج مع بس وشفنا الاكس راي والاكس راي كان كذي نفس هذه most of the time is pre-implant mucositis. الفرق الوحيد يعني مو انا بشرح لكم على السريع عشان تفهمون الفرق. لما يكون عندنا بليدنج وباس وما في بون لوس pre-implant mucositis. سوينا اشعه شفنا كذي pre-implantitis. نحول انتهى الموضوع. pre-implant mucositis ادق على صاحب البريدونتست شو اسوي؟ ربر تيب سكيلر سوي كذي ماوث ووش. You treat it as almost as a gingivitis case. Okay, non-surgical therapy always work for peri-implant mucositis. هذا case done by my colleague محمد فلمبان from Saudi Arabia أيام residency, and it is a very interesting case. هني نفس الشيء، يعني شوفوا هذا hopeless خلاص رايح على اليمين على يساركم. الثاني نفس الشيء. نحسب ايش كثر الطول، حتى ترى الحين في new advancement in peri-implantitis how to treat it. 15% 30% نفس الدايجنوستس ترى حق الامبلانت احنا قاعد نسوي نفس الشيء. زين. الحين انا شرحت لكم كل شيء. قاعد تفكرون اعتقد وايد منكم كذي. زين. ف I think it is still very difficult. يعني تخيلوا انا بريدونتست وصار لي ايش كثر قاعد اشتغل. Sometimes I feel it's challenging for me. اوكي. فهذا ابلكيشن جديد موجود على الابل وعلى الاندرويد. اوكي. شنو اسمه؟ اسمه بيريو برين. شنو مسوي؟ الجداول اللي انا وريتكم اياها مالت الجريدنج والستيجنج بس حطوها بابلكيشن. فانتم لو تجون تشوفون هذا هو البرنامج. زين. انا ابي حق الجي بيز المستوصفات الريزيدنس مالت البورد اذا موجودين لا اشوفك ماسك التليفون. زين. بس it's a very interesting very nice very fast وهو يعلمك. هذا اللي مؤسسين الابلكيشن. اوكي، هني هذا السريع، هذا وايد سريع، هذا مثل السكرينينج. الثاني الفل، البيريو فل، هني تروح شوف كل شيء موجود. دايابيتك، نون دايابيتك، الاتش بي اي 1 سي 7 اور مور لس، كل شيء اللي شرحناه بالجدول موجود. باي كليك تحت الاخضر كلاسيفاي، اعبي كل المعلومات اللي ابيها انا داخل. اوكي، اي صح، ما اعطيتكم اياه محاضرتكم صح. بس على السريع وانت بالمستوصف طالع الاكس راي، طالع كل شيء، تسوي بروبنج، لك خلق تسوي البروبنج، تسوي البروبنج بالمستوصف. صار حطيت طق وناسه ترى، طق شو كلاسيفيكيشن 1 اور 2 سكيلينج. تعال لي بعد شوي بعدين خليني اسوي لك تيستينج 3 اور 4 حول خلاص على الستيج. اوكي and that's it. انا كان ترى هو الهديه لكم كان الابلكيشن، لان الابلكيشن وايد راح يسهل لكم حياتكم. اوكي حتى انت هون قاعد تضحك. Thank you very much. I wished I had more time.
Okay, thank you, Dr. Abdurrahman. Thank you. There's a time only for one question. Is there any question from the audience? One question. I think you made it very simple that people don't have any more questions to ask you. So with that, I'd like to, on behalf of the KDC committee, we'd like to show our appreciation for you, Dr. Mohammed Abdul Wahab, for presenting this lecture. Thank you so much. Show your appreciation.
حبيبي تسلم ما قصرت. شكرا. شكرا حبيبي يعطيك العافية. نشكر حبيبي.
الحضور audience please. I think it's time for the lunch break. It's going to be قاعة المسيلة 2. مسيلة 2. قاعة المسيلة 2. We have 1 hour for it.
additional lecturer. Dr. Pons is a clinical assistant in the Department of Periodontology and Implants of the International University of Catalonia. He holds a master's degree in periodontics and implants from the International University of Catalonia. He's also an EFP accredited clinician. Please join me in welcoming Dr. Pons. Dr. Pons, the mic is yours. Thank you very much.
Good afternoon, everybody. First of all, I would like to thank KDI Media for your kind invitation and from letting me spend these beautiful days here in Kuwait City. And also, I would like to thank the audience that you have come quite soon after the lunch break. So, without further delay, let me share with you several strategies on the diagnosis, prevention, and treatment of peri-implant diseases. I would like to know how many of you are familiar with this kind of scenario. In other words, how many of you are you dealing with the peri-implantitis treatment on your daily practice? Sorry, but sometimes yes and sometimes no. If not, I will stay like this. So, we will try. Allow me to share with you some concerning data. At least 10 millions of implants are placed every year all around the world. And we know from the evidence that almost 50% of them will show peri-implant diseases. As an example, in my little country, that it's Spain, between 1.2 and 1.4 million implants are placed every year. And according to the data available, we know that 2 out of 5 implants will develop peri-implantitis. That means that in 10 years, around 2.5 million of the newly placed implant will present this pathology. And these numbers are really alarming. Before going into deeper detail on the pathology, let's remember some concepts about what is peri-implant health that will be clinically diagnosed by the absence of bleeding, suppuration, and increased peri-implant probing depths. Radiographically, what we will see is the absence of bone loss beyond the initial remodeling that succeeds after the implant placement. And so, what we will find is a bone stability over time. But if this homeostasis and this balance is disrupted, inflammation will appear. That it's called mucositis. On those cases, clinically, we will find bleeding, we will find increased probing pocket depths, and even suppuration. However, as it happened with the healthy condition, radiographically, we will still find an implant that presents bone stability over time. Let me show you a first case in which we have an implant diagnosed by mucositis with bone stability, but with this soft tissue inflammation surrounding the implant. We can treat it in a predictable way by disrupting the biofilm wherever the strategy chosen, or mechanically or chemically or by combination of them, and then we can return the implant to a healthy condition after 3 to 4 weeks. And this is due to the fact that when talking or speaking about mucositis, we are talking about a reversible disease. However, if we maintain a situation like this one, with this soft tissue inflammation over time, and we didn't treat it, it will develop to perimplantitis. And that means with the loss of supporting bone of the implant. Perimplantitis, sorry. Can we have another? Perimplantitis, as it succeeded with mucositis, its inflammation, and then clinically will present bleeding on probing, increased probing pocket depths, and also suppuration. But coming back to the principal difference between the other two conditions, radiographically, perimplantitis will show bone loss beyond the initial bone remodeling. And that means an irreversible consequence of the disease that is usually accompanied by huge soft and hard tissues deficiencies, as well as aesthetic concerns for our patients. Indeed, perimplantitis appears to progress in a non-linear but accelerated manner. And although treating it, you should know that the evidence suggests that around 2 out of 5 implants treated by perimplantitis should be explanted after 5 years of treatment. And this means that we should restart with our treatment again. In fact, new bone reconstruction, new implant placement, and new prosthesis. With our group, we study in how many cases after implant removal the guided bone regeneration was needed. And we found that almost 80% of the cases needed for bone reconstruction for placing a new implant. And that means an increase in morbidity for the patient with more surgeries, increase also in time, not only for the patient, but also for you. And finally, an increase in the treatment cost of the patient. And this situation should be avoided. But how can we prevent the onset of peri-implant diseases? We can act at 3 different time points. First of all, before the implant placement. That means by preventing the risk factor development. As an example, by educating our patient in a proper plaque control. Secondly, we can do it before the development of the disease. And that means by preventing the disease onset and controlling the risk factors associated. Again, by placing the implant in a proper 3D position, or by designing a prosthesis that allows us a proper interproximal hygiene. And finally, we can do it once the disease is present by, on one hand, preventing the disease recurrence, and so treating mucositis or perimplantitis, and also by preventing the disease consequences, that in terms of perimplantitis. I would like to highlight several risk factors that we should keep in mind when dealing with perimplantitis. That would be, as the evidence has suggested before, patients with history of periodontitis, poor plaque control on our patients, and lack of regular maintenance after dental implant therapy. Moreover, we should keep an eye on patients that present several systemic conditions such as diabetes, or those patients that are smokers. But why is perimplantitis so aggressive? Let me compare 1 second the soft tissue surrounding the implant and surrounding the teeth. surrounding the implant, we will find a huge amount of collagen fibers, but in decreased numbers of fibroblasts. And that means that the turnover of the collagen will be limited and decreased. In addition, the vascular supply is also reduced surrounding the implant. And finally, the orientation of the collagen fibers in a parallel way surrounding the implant differently from the perpendicular way that are surrounding the teeth. And that means that we have a weaker or a limited defense system, that the progression and the extension of the bacterial plaque can be greater than in the periodontal lesion. And that's why we can find situations like this one with huge bone defects surrounded by a dense granulation tissue. Looking for several differences between the peri-implant lesion and the periodontal lesion, you must know that we will find an increased number of macrophages and neutrophils. Also, the connective tissue infiltrate is more apical, and not only that, typically is uncovered and exposed to the peri-implant pocket. We know that the lesion is twice as large as the periodontal one. In several studies, in preclinical studies and in animal studies, it has been proven that peri-implantitis is more destructive than periodontitis. And finally, we know that it presents a faster onset and progression that can be accelerated by other factors. If we put into the cockpit the fact that we have a weaker defense system plus a very aggressive pathology, treated in an efficient way is mandatory in our practice. And our endpoint during this therapy would be to achieve success. And what we consider success? Success can be defined as to provide an ecosystem comparable with peri-implant health. And that means, in other words, after our therapy, we should have residual probing depths of less than 5 millimeters. Also, and in terms of bleeding at more than 1 point, absence again of suppuration, and finally, but not, and even more important, the absence of progressive bone loss. Clinical guidelines have suggested a two-stage approach to treat peri-implantitis. Phase 1 will include a non-surgical therapy, and phase 2 would be this surgical treatment of peri-implantitis. During the non-surgical, we will try to, first of all, control those supramarginal biofilm as seen in the case of mucositis. Also, we will try to control several risk factors associated with peri-implantitis, such as the excess of cement. We will try, again, to control the peri-implant biofilm and all the inflammation surrounding the implant. And this is due to the fact that we will try to provide a more favorable scenario for the surgical treatment that we will perform 6 weeks later. Regarding the surgical phase, we can select between 3 different approaches. We are talking about resective therapy, reconstructive therapy, or combined therapy because it presents, or we will have to use several concepts of all the other 2 approaches. But what is really important is that to select one or another is based on the morphology of the peri-implant defect. If you are not familiar with the defect classification, you should know that we can find some defects that present an intraosseous component and will be classified as class 1, and also those implants that present a defect with horizontal bone loss, that those will be classified as class 2. And what are the clinical implications of knowing this morphology of the defect? Look, when talking about intraosseous components, we expect them, or we know that they are candidate for reconstructive therapy, especially those defects, as the one of the picture and this one, that they are crater-like morphology. Some years ago, we tried to actualize the classification prior from Dr. Schwarz, and he helped us to actualize it. We add a new class that would be the third one, and we consider as combined defects. Combined defects are described by two components. We have on one side a supraosseous component, and also we have the intraosseous component. Also, we try to classify the severity of this defect. And then we can find slight, moderate, or advanced defects according to the bone loss related to the length of the implant. And this is key in helping us to choose if we can go farther with the peri-implantitis treatment, that would be in those two cases, or maybe if we are talking about an advanced defect, maybe it's a better option to restart again, explant the implant, reconstruct, and new implant placement. Let's move on to the resective surgery that has as objectives to improve the inflammation and to eliminate the pockets. We will reduce also the anaerobes and putative microorganisms, and we will try to facilitate the effective oral hygiene measures performed by our patient due to the recession that the mucosal or the peri-implant mucosa will have after the surgery. As indications, we will perform it in cases where a defect class 2 with the presence of horizontal bone loss is present, and also, very important, in those implants that are outside the bony housing, because we know that those implants, they are not candidate for reconstructive therapy. Let me show you one first case. Let me show you one first case, at an implant that present bleeding on probing, and also we can check radiographically that he presented this crater-like bone loss. And we decided to go to raise our full thickness flap, and we see once we open the flap that the implant is partially outside the bony housing, so we cannot reconstruct this defect, and we can perform the debridement of all the granulation tissue, decontaminate the implant surface, that in this case was performed by means of titanium brushes, air powder abrasives, and also with hydrogen peroxide. And finally, we suture the flap. Prior, we perform a little bit of osseous surgery, trying to flatten the bone architecture. What we can see 1 year later is the stability of a healthy condition, and that the bone loss has been arrested and it's maintained over time. But do we have more tools nowadays for treating this type of defects? And the answer is yes. From several years ago, we start working with implantoplasty, always combined with the resective procedure. That's why they share several objectives, but in this case, with implantoplasty, what we can achieve is a mechanical decontamination of the surface of the implant by reducing plaque adhesion. This is due to the fact that we try to eliminate completely all the threads of the implant and converting a rough surface in a completely smoothened surface. The only thing that I would like to highlight from the indications, as they are the same as the resective surgery, is this concept that we need to avoid implantoplasty in those implants that are narrow implants, especially in those that present an internal connection. There are several ways to perform implantoplasty, and we can use several different types of burrs from different materials and also with different type of polishing burrs. I prefer to work with a kit designed by a very good friend of mine, Alberto Monge, that we have on that kit several tungsten carbide burrs, and also we have a sequence of polishing burrs in decreasing grid size. Let me show you how can we perform and combine resective surgery and implantoplasty through this short animation. First of all, we remove the crowns and we place healing abutments trying to protect the platform of the implant when performing implantoplasty. Once we raise a full thickness flap, we start with our osseous resective surgery trying to flatten the bone and converting a flattened bone architecture, and then we will continue with the carbide tungsten burrs surrounding the implant, trying to eliminate and remove all the threads, and finally we will perform the polishing or the final polishing of the surface. Then the last step would be to apically position the flap. Going in more detail, we will see the different sequence that we use to use. We protect the implant with a healing abutment. We start with the great diameter carbide tungsten burr, and then we start removing all the implant threads. By performing this type of movement, as if we were preparing a tooth for a crown, these four motion back and forth motion movements surrounding all the implant. Later on, we will start with the polishing burrs in that sequence, in decrease and grid size, performing the same movement as we did before during the first part of the implantoplasty. Finally, with the titanium brushes, with a slow velocity, we can try to remove all the titanium particles that has been adhered to the flap and also to the periosteum very slowly and to clean it. Let's move on to reconstructive therapy. That in this case, the objectives are quite the same or quite similar to resective surgery, but our main goal is to improve radiographic bone gain. It will be indicated in those defects that presents an intraosseous component and also those implants that are inside the bony housing. The application of the principles of guided bone regeneration, with or without membranes, has proven effective in bone repair for contained defect configurations. And let me illustrate through a series of cases how can we manage several or different situations. The first case I would like to share with you is a reconstructive therapy by a submerged way. We usually start our surgery 15 days before, when we remove the crown and we replace it for a healing abutment or a healing cup, trying to facilitate the adaptation of the tissues for the day of the surgery. usually start with a crestal and continued intrasulcular incision, trying to preserve the color of the granulation tissue, adapt or adhere to the implant surface. That will facilitate the posterior debridement of these tissues. Then we perform the implant surface decontamination, that we will talk about it later, and we fill the bone defect with a mixture of autologous bone harvested from the neighboring area with some xenograft bone substitute material, and we covered with a resorbable membrane. In this case, as we were doing it in a submerged way, we tried to obtain primary wound closure, and the disadvantage of doing it in that way is that the patient will need a second stage after 5 to 6 months. But what we can see on the follow-up radiographically is bone stability, and not only that, we achieved a radiographic bone gain. But what it's difficult during this type of surgery or this type of approach is not your skills, is not if we use membrane or not, and it's not about the type of bone material that you use to fill the defect. What really matters is that when dealing with implants, we are dealing with a contaminated and a difficult to access surface. And that's the key point of our treatment. How can we decontaminate that surface? 2 years ago, sorry, but it's not me. 2 years ago, we performed a review with a group of friends trying to study the different strategies that we have nowadays for implant surface decontamination. We studied chemical methods, mechanical methods, lasers, and the combination of them. Well, we concluded that although each of them presented advantages and disadvantages, none of them presented superiority versus the others. However, last year, a systematic review from a consensus concluded that from all the other, or all among all the treatments that we have, or the surface decontamination methods that we have, the only one who showed superiority was the use of titanium brushes. But we're still working on it. And for example, in my clinical daily practice, we are starting using the electrolysis by galvanic currents, and maybe they will help us in the future for our goal, that is surface decontamination. Another key point to discuss is whether we have to use membrane or no when performing our reconstructive therapy. We performed a randomized clinical trial, and we concluded that there's no significant differences between use it or not. However, I suggest, or my recommendation would be, that if we are talking about a non-contained defect, it's better to go through the placement of a membrane, and if we can fix it, better. Indeed, what we found during this study was that those factors that really have an impact on the results of our treatment were the presence of a band of keratinized mucosa in the day of the surgery, and also the plaque control that has our patient on the following after surgery. Let me show you another case, but we will do it in a non-submerged way, as we perform always. We start our surgery 15 days before by replacing the crown, and radiographically what we can expect is a crater-like defect, and then we will go for further with the reconstructive approach. We start with our crestal incisions, continued by intracircular incision, and that image in the middle represents what we were talking about, that we try to maintain all the granulation tissue adhere to the implant surface, and then we can keep it and debride it easily with curettes or with ultrasonic devices. Once we have debride all the defect, we perform our implant surface decontamination, that in this case, we did it with titanium brushes and with electrolysis by galvanic currents. Again, we harvested some autologous bone chips from the neighboring area. We combined with a xenograft substitute material, and then we fill the defect. We covered with a membrane that we previously perforated to let the emergency of the healing abutment. This is the view at the 2 years follow-up. We can observe bone stability and also radiographic bone gain, but don't be impressed from the reconstruction, because what it really matters is that the implant presents a stable condition in a healthy condition without bleeding, without suppuration, and with probing depths that are compatible with health. Finally, let's move on to the combined approach that, as I tell you before, is due to the fact that we combine implantoplasty with reconstructive therapy in those defects that we consider as combined, and we will have a supraosseous component and also an infraosseous component. And finally, also, we can combine it with soft tissue conditioning in those cases that there is a lack of band of keratinized mucosa. Don't worry, because I will speak few things about soft tissue conditioning. Yeah? Very briefly, as we perform this combined therapy, we start always with our implantoplasty procedure that you already know how to do it. And once it's performed and everything is polished with a smoothened surface, we start by the reconstruction of the intraosseous component of the defect. To explain it in more detail, another case, radiographically what we can expect is this combined defect, because we are talking about horizontal bone loss till this area more or less, and the intraosseous component on that region. And so we start our procedure, and we decided to combine implantoplasty plus reconstructive therapy. As always, we perform our crestal incisions, and we will continue intracircularly. We let this granulation tissue, we debride all the defect, and what we expected radiographically, it's also present intrasurgically. And we will perform the implantoplasty for the 3 coronal millimeters of our implant, and then we will perform the reconstruction of the infraosseous component. As always, combination of materials, autologous plus xenograft. We filled all the defect, and we tried to adapt our collagen membrane to the implant surface, and then we suture it with monofilament 5/0 in this case. The 3-year follow-up, again, what we can achieve is stable results in terms of healthy condition of the implant, and also radiographically what we have is a partial radiographic bone field of the area, but it's stable over time. And the last case, to show you how we can combine implantoplasty plus soft tissue conditioning in those cases in which there is an absolutely lack of keratinized mucosa surrounding our implants. And then what we usually do, in this case, we perform a partial thickness flap, because we want to create this vascular bed, this vascular area in which we will place later on and adapt our free gingival graft, I usually protect it with a gauze when doing our implantoplasty, because if not, all these titanium particles will remain all over our vascular bed. And once we have finished with our implantoplasty, we go to the palate, we obtain and harvest 2 free gingival grafts, and we fix it and adapt it by this continuous suture and also with simple suture to keratinized mucosa neighboring. The 2-year follow-up, in which we can observe that we have gained a beautiful band of keratinized mucosa, and not only that, we have modified the conditions, and then the patient can keep a proper plaque control, and instead of what she had before, that was discomfort when brushing. To wrap up the presentation, I would like to highlight that among all the treatments that we have talked about during this presentation, my first option would be prevention. Okay, by preventing the appearance of the disease, we can obtain successful results over time. And not only that, the importance of peri-implant maintenance therapy, because we will try to instruct our patient in oral hygiene measures, and not only that, you need to inform your patients on the risk of developing peri-implant diseases. They should know before the implant is placed. Also, we will try and we will include our patients in a strict maintenance therapy that is usually tailored according to the risk factors that present your patient. Okay? And finally, we will try to monitor every year the status or the condition of our implants, not only clinically, if not clinically and radiographically. And that's how we can obtain long-term success with our implant therapy. But don't be frightened, because if the disease appears and you treat it, and you include the treated patient on a strict peri-implant maintenance therapy, the evidence suggests us that more than 80% of the patients will maintain and will retain their implants for more than 7 years. But if we can avoid treated, better for all of us. With this, I will finish my presentation. Thank you very much for the attendance, and it has been a great honor to share these days with you.
Thank you, Dr. Pons, for the informative lecture. I would like to invite the audience if there's any question. At the back one here, please. Mike, can we get the mic there at the back?
Thank you for the lecture. I think it was very informative. I have a question. What's your cutoff line to extract the implant rather than try to save it and do implantoplasty and resective surgery?
Can you repeat just only the first part of the question? What is mine?
What's the cutoff line? Like, when do you decide to remove the implant or to save it with implantoplasty and resective surgery?
Look, it's probably we have to talk, when we were talking about the severity of the defect, it can guide you a lot, because I usually, if we have more than 50% of bone loss, 50 to 60, it's the limit. Later on, you have to also put in the cockpit the age of your patient. I don't know if you are trying to save an implant from a young lady or you are trying to preserve that implant in an old lady that maybe can arrange it for 5 to 10 years. It's very different. But I usually, if I will say that 50%, it's like the top.
That's the last we can go with the implant.
Yeah.
Thank you.
Because it will decrease as more bone loss the implant or the defect present, less is the probability that you achieve success with your therapy.
Thank you.
Always.
Thank you very much.
You're welcome.
Any other questions? Mic here, please, to the right.
Thank you so much, Doctor, for your informative lecture.
Thank you.
I would like to ask about just something, the implantoplasty. I've noticed in the pictures there's some particles of the titanium. Is the irrigation, is it enough just to remove those particles, or?
We try as much as we can, but it's true that sometimes some particles can remain.
Yeah.
The implantoplasty has proven a lot of controversial during these last years, because there are several groups that are saying that we can find some particles that can migrate through the blood vessels in animal studies. They have shown that. Also in preclinical, they have shown that the size of the particle, it is what really matters. That the big particles, they are not toxic, but the ones that are smaller, they can produce any type of cytotoxicity. But there's no studies also saying that will represent a damage or a irreversible damage or condition for our patients. So we can continue doing, because if not, the alternative, which one it is?
Thank you so much.
The front, please.
Thank you. Okay, going through the first question, that it was the one of implantoplasty. The only thing is that you can deliver some titanium particles for the other tissues, but the structure of the implant, you won't lose the osseointegration, but it's true that in some cases with narrow diameters, that 3 millimeters or less, you can have implant fracture, and that's true. Okay? This is the first. The second one, the combination, the mixture that we perform, it's only autologous, the xenograft, and saline. That's it. We don't use any type of antibiotics. We didn't combine it. I know that several years ago it was combined. There are also several brands, like I think that LifeNet has been working on it with vancomycin, it's called, that it's bone particles with some antibiotics incorporated into the bone, but nowadays I'm still working with this strategy. The ones that we have presented, we have like 3 to 4 years at least, because I don't have enough practice nowadays. But it's true that when we were talking about the peri-implant maintenance therapy, you should know that probably I visit my patients after the reconstructive therapy. Every 3 weeks, we perform with. That's from my father. It's another thing. They are from my father. You're welcome.
Dr. Pons, I would like to ask about the reconstructive surgery that you did. You showed us a case where you did a submerged submucosal healing and another case where you did transmucosal healing. Is there any preference, any clinical difference in terms of the outcomes?
Look, we have advantages and disadvantages for both of them. Regarding guided bone regeneration principles that will include a primary wound closure to achieve better result with our therapy, that would be the submerged way, the one selected. But it's true that not all the patients accept being without the crown during 6 years, 6 months, sorry. And that's why we can also go for a non-submerged way, because the patient can bring the crown during the healing process.
So this is my second question. When do you place the crown again after the reconstructive surgery?
15 days later, when we remove the suture.
When you remove the sutures, which is after?
15 days.
15 days, okay, 2 weeks.
At least it's like 1 month without the crown, but not 6 months. And also, and talking about it, it's also about the defect configuration. Because although you have a crater, if you have your implant platform coronal to the bone levels, you cannot go farther for try to perform a submerged way healing. Okay.
Okay. I think I'll go for the final question. You showed the study showing the different types of protocols to disinfect and clean the implant surface, and you've touched on which one is the most superior or there's more evidence behind it. One of the leading implant companies, they have a machine where they claim they can clean and totally decontaminate the implant surface by electrolysis. So you showed it. Okay. So any thoughts on that? Any thoughts on that? Like, have you used it?
Nowadays we are performing a multi-center clinical trial that we expect that in the beginning of 2025 we will have the results. At this moment, it's with a slight differences, but it seems that help us with achieving better success results with the reconstructive therapy. But it's true that what we have seen on SEM analysis, okay, microscope analysis, they are like very, very good results. But we will see.
Indeed. Dr. Pons, thank you so much for the lectures, for the question sessions. And with that, if you can show your appreciation for Dr. Pons, to you with our appreciation. Thank you, Doctor.
Thank you very much. Thank you very much. I appreciate it. Thank you. It has been a pleasure.
تيست تيست. اوكي. تيست تيست تيست. All together. No no echo.
بس اعتقد الصوت واطي شوي.
الصوت راح رجع. اوكي شباب احكوا. Say
Test,
something.
test, test, test.
Test, test.
Test.
I think I will switch this. Yes, this one off.
Assalamu alaikum. Good afternoon, everybody. Please come with me today's panel for the three distinguished doctors. I'm going to introduce the first one, Dr. Khalid Saeed. Khalid Saeed is a senior consultant of periodontics since January 2020 in Hamad Medical Corporation, the most prominent tertiary care provider in Qatar. He is also a clinical associate professor in Qatar University College of Dental Medicine, and he practices, teaches, conducts research, and presents lectures on periodontics and implant surgical techniques. His career portfolio expands for more than 25 years between clinical, academic research, and administrative experience in the specialty of periodontics and implant dentistry between universities and tertiary hospitals in US, Jordan, Saudi Arabia, and Qatar. His qualifications include the completion of his specialty certificates and master's degrees, fellowship in implant dentistry in Iowa, USA, and the American Board of Periodontics and Implant Surgery. Dr. Saeed have led multiple task forces in applying standards and guidelines in curriculum development, assessment tool design, academic quality, and accreditation reviews of multiple dental programs and postgraduate residency and master programs. I'm going to move to Dr. Basma to introduce Dr. Ayad.
We also would like to welcome Dr. Ayad Al-Athamna. Dr. Al-Athamna was trained at both University of South California and University of Buffalo. He is currently a consultant prosthodontist at Hamad Dental Center in Doha, Qatar. He worked as an associate professor at University of Texas, Houston, and University of Buffalo, New York. I'm also honored and excited to present Dr. Amir Shatta. Dr. Shatta has an advanced education, includes a Master of Science in Dentistry and Comprehensive Training in Periodontics, all completed at Case Western Reserve University, USA. Dr. Shatta also completed a fellowship in implant at Boston University Henry Goldman School of Dental Medicine and is a diplomate of the American Board of Periodontology and Dental Implant Surgery. Currently, Dr. Shatta serves as a consultant in the Periodontics Division at Hamad Medical Corporation in Qatar. He is also the program director for dental residents at the same institution. Additionally, Dr. Shatta holds an academic appointment as a clinical associate professor of periodontics at Qatar University College of Dental Medicine. Welcome, Dr.
Thank you. Thank you. Thank you, Dr. Basma, Dr. Munira, for the kind introduction. We'd also like to thank the organizing and scientific committees for giving us the opportunity to come to Kuwait again for me. We would like to thank you for the great hospitality and the amazingly well-organized 3-day symposium. We would like also to thank you for the great selection of topics, lectures, and themes. So we're going to start with stating that there is no conflict of interest that we would like to declare, and any clinical or radiographic photo that you see or image have been consented for. We'll start with, among three of us, there's more than 30 years of experience in implant and periodontal surgery. And probably we have found out that there's no unique solution to fix all dental problems. There are diverse options, resources, facilities, tools, instruments that help us to reach a certain optimal kind of treatment for a certain patient, for a patient-centered approach. Having said that, these are just classic situations that we face on a daily basis. Those are not the same patient. Those images are for two different patients. Patients come sometimes with exact similar complaint, exact similar presentations. But when you look deeply into the case, when you look at the clinical radiographic evidence, when you look at other factors in the mouth or in the medical history of the patient, socioeconomic status, and most importantly, patient expectations, then you start seeing that the treatment plan will diverse and become more customized to the patient needs.
As Dr. Saeed mentioned earlier, there is no unique solution. And as a practitioner, we would like to have a bag of tricks. So in this session, we will be debating, discussing, maybe fighting a little bit, of what options are there as a people that we use with, deal with implant therapy and implant dentistry. These are the 9 modules that we're going to discuss in a debate matter, and we're going to start by discussing immediate versus non-immediate.
Okay, so we will discuss first immediate versus non-immediate. And the immediate now, to give you overview what we mean by immediate versus non-immediate, first we start immediate, it's placement of the implant at the same day of the extraction. Delayed implant placement, it will be after soft tissue healing or partial bone healing or fully bone healing. So please, Dr. Khalid, convince me that I like to go with immediate implant placement. Please convince me that I should go with non-immediate approach.
Well, other than my favorite topic, which is going with non-immediate approach, I am backed by more than 20 years of science, long-term study evaluation of that implants that were placed in a later early approach. I am backed by the ability of the surgeon like myself to design the surgery, place the implant in the exact location I want, site location important, and the predictability of the outcome. So actually it's the other way around. You have to convince me that immediate really works.
So the way I see this, if I'm going with immediate implant placement, there's 3 important factors. Number 1, I will be looking at the implant survival and success. Is it same between immediate and non-immediate? So from the literature, there is some superiority to non-immediate implant placement, but in general, most of the studies agree that immediate and non-immediate implant placement are comparable and giving the same success and survival rate. So for this reason, also I will go with immediate. The other factor also here, the treatment time and patient management, which is considered a big plus for immediate implant placement in comparison with non-immediate. The treatment time and visits is much less when we go with immediate implant placement in comparison with non-immediate. So this will be reducing the treatment time, overall patient management, and also it will be a good potential practice builder. The third one, aesthetics. Also, if we are placing the immediate implant in the anterior, which is more important than the posterior, the immediate implant will capture the aesthetics, especially when we do immediate provisionalization.
Well, I'm not sure, Dr. Ahmed, because immediate implants just gained a little bit of bad reputation for a while. I mean, I have tried immediate implants in the past, and they don't work with me as good as delayed approach. What's different?
Okay, so when I start to when I receive the case for consultation, we take CBCT to evaluate the bone, and we need some requirement, and I consider it a little bit as a challenges sometimes, because we need to have good bone quality, good intact bone, no infection, adjacent structure should be also healthy. So sometimes it's difficult and will need also high level of experience to do that.
Well, thank you for bringing this up. This is one of my favorite studies. This is an assessment of the bone thickness on the buccal side of young Arab patients. The overwhelming majority of these findings are that about 4 out of 5, 80% of our patient population have thin bone less than 1 millimeter. And as we know, that this will create, for sure, a problem when we attempt to place an immediate implant. The 1 millimeter is going to go away.
Come on, Dr. Khalid. If you have patients now coming to the clinic asking for dental implant, we cannot tell them that the bone is very limited and will not be able to do it.
especially with the tools we have in our hands today. We can place the implant with bone graft. It's very simple to maintain the amount of bone. We can increase the thickness with adding bone graft. And this is one of the solutions. And also we have another solution like the socket shield, which is just when we do extraction, we do partial extraction therapy. We keep part of the root connected to the buccal plate to maintain the bone and soft tissue.
Dr. Amr, you're just making it more complicated now. This is a time-consuming, challenging technique, and it has very, very long list of contraindications. But what bothers me most is that most of the teeth we extract in the anterior maxilla nowadays are either having trauma, fractures, periodontially involved. So it's not really a stable part of the root that we can maintain. I mean, let me share with you this case, if you don't mind. This is one of the cases that were originally treated with the socket shield. Just 5-7 months later, the patient came back with a mobile part of the root, the residual root. And then we had to open a flap again, go back with the bone graft, and deal with the whole situation one more time. So it's like we did not gain anything. This is just another delayed approach with a bone graft.
But still, with the immediate implant placement, we know it's challenging, but also when the patient selection will be very important. So the patient should also accept some risk when they ask to go with immediate implant placement. We have to understand the biology and our limitations. So if we can go with immediate, we have to push for this, because our patient will come to the clinic asking for immediate. If you cannot do it, they will just run away and search for another one. So we have to understand the biology and limitations. Maybe we can still manage it if we are in the safe zone or caution zone, and we have to avoid danger zone. But we have usually to try to push our envelope and go more to immediate implant placement.
Your point is well
So
taken.
as a periodontist, I like always to be able to do immediate loading. I mean, that's the goal that I have with all my patients. The debate is immediate or non-immediate is going to be always a surgical decision. But at the end, the practitioner has to know what is the limitation, case selection, and patient. It all plays a role in, am I going to be placing the implant and loading the implant immediately, or I'm going to go with the delay placement. Aesthetics, function, patient selection for sure, immediate would be what I pick. But again, I have also to look into my success. Do I want to implant placed immediately and I do immediate loading and then it fails a few weeks down the road? So understanding the parameter is something that all practitioner has to look into it and deciding what fits the case. It might be two cases, two different patients. You go delay with one and go immediate with the other one. And you can do immediate placement of an implant, but you decide at the end, you know what, you don't have enough initial stability, you decide I'm going to abort and I'm not going to even load the implant. So this decision has to be made with discussing all the factors that we said and we discussed earlier in the presentation. Just a little bit of meticulous study of the case would give you an idea of which way to go. So now we're going to move to the second, which is flap versus flapless. Surgeons like to always debate which way to go.
So for myself, I would like to go with a flap. Flap is, I can visualize the bone. It's easy to see the bone. I will be sure that I can place my implant in the correct position. I can cover it with bone. What do you think, Dr. Khalid?
Well, look, from my perspective, I work in a tertiary hospital. I deal with a lot of geriatric elderly patients, significant medical history, long list of medications, a lot of them on medications that could affect the success or the complications with flap surgery. So personally, I like to do flapless. It's faster, low morbidity for those patients, and faster recovery time. So it works well for my group of patients.
But the way I see it also, when we do flap, at least we can maintain the soft tissue, and we will not, we will prevent so we will keep the soft tissue, and we will be able to add bone and soft tissue if needed. And one of the biggest disadvantage of doing flapless approach is bone perforation with the implant placement.
Well, I acknowledge actually that there are incidents of perforation bone during implant placement, whether flap or flapless, but yeah, definitely more common with flapless. However, this is why we focus on performing flapless surgeries with a guided approach. So when we do a guide with the prosthodontist approval, we are positioning the implant in a place that is prosthetically viable, but at the same time, avoid the risk of perforation for those patients. So it's a win-win situation.
So guided has been always the tool, but with adding digital, it became very easy to plan, predict, and go
But
even
guys,
without.
it's still, I understand that, but still with the flap, we can do it as a guided. So it doesn't affect if it's flapless or flap.
Well, that's true. I mean, let's look at guided procedures. Let's look at guides.
So when we discuss guided versus freehand, I think nowadays we pass the freehand defense that, you know, freehand is we're going to give you the same predictability of placement. Yes, I can understand if you're an experienced implantologist or a surgeon, if you place one implant bounded by 2 teeth, yeah, I that or bite that. But if you start placing more implants or placing full cases, I mean, without a guide, there's no discussion to say that guided will be as predictable as freehand.
Dr. Iyad, I like to go with freehand. I see it's easy, fast, and works in my hands.
But again, I'm looking for predictability. I'm not going to accept less than 100%. So are you able to do that predictability in each and every case? The advent of digital technology did provide us with a new technology, both biologically and prosthetically, that I can predict and I can know that my prosthesis is where it's going to be at the end. I don't want to start by guessing where is my end crown. The digital technology is a restoratively and biologically driven treatment. You do your wax up, you pick your implant selection with size, length, diameter, because you have the 3D position, and then you also do your abutment selection. And then at the end, your surgical plan gets to be executed. So what else do you want more than that? I start my treatment, and I know exactly where I'm going to end. I have a plan, and I look at my final restoration, and I know exactly this is what I got. Prosthodontists are a little bit OCD, and then without that, I feel like, you know what, I'm failing my patient.
Dr. Iyad, from your language, I feel you are not happy with my implant.
I can't. You are the surgeon that I deal with every day, so I have to make sure that my language does not. What I'm saying is the technology itself is something that developed greatly the last 10, 15 years. When we started, we were not sure. So I have a motto that success should not be measured by the number of times you make it, but it should be reducing the number of times you don't make it. I mean, the ability of us to be able to just do it one time is our success versus doing it 2 or 3 times. So looking at the guided versus guided, there is a lot of benefit, as we said. And we have a case, we'll go through it really quickly. So a patient comes, missing 2 teeth, we scan the patient, you do a wax up, you have a CT scan that superimposed with your digital impression, fabricate your guide, and you place your implant. And even before the placement, you are already printing or milling your provisional. It's easy, quick, and then at the end, it's very predictable. Cost maybe a little bit more, but then again, it's worth it because at the end, you know exactly where is your restoration and what to expect versus going freehand. And then, you know what, you see disasters when we start doing that. And again, this is the first picture is on the day of placement, 2 months, and this is your final restoration. So what else do you want more than that? And all it takes is just a scan that gives you exactly what you need, whether it's bone grafting, tissue grafting, or whatever is needed before you place your implant.
Well, I'm glad you went flapless with that case, Doctor. Thank you very much. So let's move on to another topic that we always think about: how to select our implant, what design, what size, etc. Dr. Amir, where do you go with this?
So I would go with tissue level implant. Tissue level implant is my favorite implant. the main reason that I'm in love with this smooth collar in the implant. So this one is much better and easier for maintenance for both patients and the clinician. So definitely I will go with tissue level implant.
But when we think about the anterior maxilla, especially with our patient population with thin mucosal phenotypes, with the risk of exposure of this highly polished surface, we run the problem of aesthetic complications. For me, bone level implants, especially in the anterior maxilla, gives me and the prosthodontist a better chance to accommodate the needs of the patient. Don't you agree?
Yes. But also don't forget that the level implant comes very beautiful with built-in emergency profile. What do you think, Dr. Iyad?
You know, it does come with decided emergence profile, but on the anterior region, it just restricts my ability to be able to shape and reshape my tissue and my emergence profile. So I don't want to be restricted. So do I like tissue level on the anterior? I would rather go with bone level as a prosthodontist. Do I like the prosthetic part of tissue level? It makes it easier to deal with it. But again, you have to look into the bigger picture, whether does that serve my purpose or the patient needs at this point.
Okay, so guys, let's be in agreement that we will go with bone level in the anesthetic area and tissue level in the posterior.
You mean always?
Yes.
No, not always. Sometimes, you know what, you have to look into the case, and sometimes, you know, even placement of a tissue level on the posterior area is not possible because you need more space. What about that? Sometimes you have to even play around and use something that is not easy commonly used. But again, every case, it dictates what to use and what not. Again, this is a bag of tricks you have. Nothing is, as he said, Dr. Said in the beginning, nothing is going to be the same all the time. You just have to know what to use and what not in the specific case. So now let's go to wide and narrow. That's another good discussion.
Well, I'm on a good streak. I'm leaving this to Amir now.
So for the wide versus narrow implant, I will lean to use narrow dental implants. So narrow dental implant will preserve for me more bone in comparison with wider implants, because most of the cases we end up by having the implant placed and then bone loss facially, and as a result of this we start to lose tissue also, and most of the cases will end up by failure and removal. So we can see also in this study by Monchi, they found that if we have less than 1.5 millimeter in the buccal blade, this will cause avascular bone, which will lead to bone loss. And as a result of this, also we might later have the tissue loss. So our group also published on the pattern of bone loss around peri-implantitis, and we observed in this study that wide implant placed in grafted bone, they are at higher risk of peri-implantitis in comparison with narrow implant placed in native bone.
Well, I have a great respect for your research group, Dr. Amir. But let me share with you some of the photos that come to the clinic, not on daily basis, but this is a case that received a narrow implant. And you can see the complexity of maintaining this case. This is a successfully integrated implant, but look at the huge space for plaque retention. And more importantly, according, you remember a Kut study just came out very interestingly. Those cases are more prone to caries in adjacent teeth. So instead of having a problem only with plaque and peri-implantitis, now also we're looking at caries.
So when it comes to emergence profile in any of the restorations that we give the patient, as you see on the diagram and also in the article, it should be smooth, graduate. When anything is more than 30 degree, then you have an issue. Patient have a rough time trying to clean that, plaque accumulation, and the long term of the restoration is something has a question mark. So if we move to the second one.
So what you're saying here, if we have narrow implant, you will have difficulty, especially in the posterior area, to have good emergency profile. So simply we can overcome this when we place narrow implant to go just slightly deeper to get gradual emergency profile.
But how deep is deep to do this? I mean, there is a limitation to our abilities to manage deeply inserted implants, and we've seen this quite often nowadays, people going deep. For example, this case, deep in this situation, is not only creating a periodontal problem, maybe aesthetic problem, but also prosthetic challenges.
For sure, I don't want to be like trying to find the platform 6 or 7 millimeter below the tissue, the crest of the tissue. I mean, it just makes it harder and harder. And this is just one implant. Imagine if I have 2 or 3 or 4 implants.
And the other thing is, Ramon probably have mentioned it at the end towards question part, is how narrow we are going now. I mean, this is not stopping at a certain point. Research and studies and infinite element studies have shown us that if we have an implant narrower than 3 millimeters, the chances of implant complications, failure, prosthetic complications become much, much higher. Not only that, interestingly enough, when we look at the evidence, narrow implants, regardless of their length, we're not talking about short versus long, regardless of their length, have lower ISQ values. So the chances of early loading for them or even immediately loading for them is less than having standard implants or wide implants. What about the risk of fracture? We always talk about risk of fracture theoretically on narrow implants. How do you justify that?
But Dr. Khalid, today with the new implant surfaces, the new generation of the implants are more resistant to fracture. Even if the implant is narrow, it's resistant to fracture.
Okay, I accept this. But again, you've all seen Ramon's presentation, and you all seen the implantoplasty phase. And once the implantoplasty phase reaches the narrow implant, and we know 25% of our patients will have a form of peri-implantitis. This will structurally compromise the integrity of the implant, especially the narrow implant. So the risk of fracture of such an implant becomes even higher. So if I want to be predictable for long term, knowing that 1/4 of my implants or might end up with need for surgery, I think I would prefer to go wider.
So let's say that I want to be in agreement with you, but we should, when we decide the implant diameter, the most important thing that we don't compromise the available bone. So we have to respect the bone we have and just not going with wider implant just to get the emergence profile. And if you want, maybe you can build the area before you place the implant. But the most important thing that you respect the biology and the bone amount you have before the implant placement or going with wider implants.
I agree on that.
So I have a question for you guys, because every time I send a case to my periodontist, and it doesn't have to be Amr himself, you guys like to place short implants, though you have enough bone to place maybe a couple of extra millimeter. But I see them in the tendency of laying short ones. So can you explain to me and the audience?
So you said it's not Amr, so the option is me.
I was
so
very
you're
clear
pointing
because, you know, I'm
fingers
going to
now.
go back and I have to work something with
okay.
Amr. So, you know.
Okay, it's not Amr. All right. So let me share with you the science, the evidence. Science have showed us that the percentage or survival rate of implants, regular size implant in terms of length, 11, 12, 13, 14 millimeter implants placed in the maxillary sinus with a bone graft is comparable to a 6 millimeter implant placed without a bone graft in intact bone. So why would I expose my patient to a surgery that takes cost, morbidity, high, well, not high, but there is always a risk of complications in the maxillary sinus? Why should I expose the patient for this, knowingly that I don't have to, and the patient will be happy with what I provided, which is a 6 millimeter implant? I don't know. Do you have a say for that?
Yes, I agree with you, Dr. Khalid, but also when we think about the length of the implant, I don't want to have the message that I have to go all the time with short implant. I can be in agreement with you if we are placing the implant, we are avoiding, for example, excessive sinus lifting, or we avoiding the vital structures in the posterior mandible. But it's not the norm just to select all the time to have 6 millimeter implant everywhere. If we can place a longer implant, still we have to go with this.
Well, I agree with this somehow, but usually, let me ask you this question. When we have risk of peri-implantitis, really, when we have a risk of peri-implantitis, which is better, which is easier for us, to get rid of a short implant or to babysit an ailing long implant?
So for this one, of course, it will be much easier if we are talking about removal of diseased implant. It will be much easier to remove short implant in comparison with long implant.
But with the new concept saying that splinted implant, splinted short implant has more chances of peri-implantitis. A lot of implants, even companies with 4 millimeter will ask you to splint implants, multiple implants, if it is placed, especially on the posterior. So I am increasing the risk, thinking that longer implant has more risk, but with shorter and splinted, I have more risk for the peri-implant.
Yeah, so if we're talking, you are adding also here extra point that if we are placing short implant and will be splinted, it will add a problem, peri-implantitis, and then we'll go to this problem again for removal. So this is why I would like to go with longer implant if I can, to make it easy also for prosthodontists and not to splint.
Well,
it will be easier for the patient to
I guess the
maintain.
debate is going to be always what is short and what's long. And it's all depends on bone availability we have. But it's an interesting discussion, what is short and long. And I guess we're going to move to the graft versus no graft.
Okay, so this is a hot topic also, graft and no graft. We'll cover in this area here, bone graft and soft tissue grafting. So, Dr. Khalid, is it really important to have good buccal bone around dental implants?
Well, actually, you made my life easy when you cited that paper of Alberto Monge. Again, the consensus reports, new studies, all the studies, we all have long-term studies that says that it's very, very critical to have adequate thickness of buccal bone, not only in the anterior maxilla, like we used to think, but also in the posterior sides of the teeth, in the maxilla or the mandible. It's critical because buccal bone thickness will have other impacts, indirect or direct. This is the classic study, well, it's now classic by Alberto, but the point is if you have less than 1.5 millimeter of thickness, when the implant is placed, at the time of the implant placement, there is a risk. Furthermore, some dentists have this concept that placement of bone graft around an implant is complicated, especially if you're doing contour augmentation. It's not. If you are well trained to do it, it is doable, it is predictable, and at the same time, we will end up with a good bone thickness for long-term planning. Don't forget we're talking long-term. Let me share this case with you. This patient received a beautiful implant at the time. Regular size, everything went well. It was surrounded by bone from both sides, but the bone thickness was just about 1 millimeter. So you remember those cases where you can see just the trace of the metal from the bone. But we said, okay, let's save the patient money. And time came by, we took a new CBC. The patient came actually for another problem. So we took a CBCT because this problem was very interesting. Look what happened 3 years after. 5 millimeters of buccal bone is just gone. This patient had no signs of infection at the time. He never came back with abscess or any infection. So you cannot blame the poor bacteria on this. This patient have lost bone. And guess what when you lose bone, what happens? What follows is losing mucosa. I don't think you're happy with this yet when you see it.
I mean, this is my nightmare when I promise a patient that we're going to place an implant, a crown, and it should last for, we give them number and success and survival and all of this and that. And can I see? I see the metal, I see the implant, what's going on? And then I guess I have to send him back to my periodontist again.
So deal with it.
So let's discuss then the mucogingival graft. Or the mucosal graft around dental implant.
Well, before rushing into another surgery, we have been I'm not saying, but we have been doing so many surgeries now around implants. Research have showed us, Dr. Amir, that with optimal oral hygiene, but even with deficient keratinized mucosa around the implant, we still can maintain the bone, the level of the mucosa and the health of the implant.
Thank you, Dr. Khalid. So you mentioned optimal oral hygiene. So how easy to maintain optimal oral hygiene around dental implants with very thin and mobile tissue? So the literature showing that the brushing around dental implants with no attachment, it will be not only difficult, but also the patient will have discomfort. And if I want to explain for you simply, if you want to clean any surface, the surface should be fixed, stable, not moving. So for example, if I want to clean now my tube here, and it's moving with my hand, I will not be able to clean it. But if it's, could you please help me?
Okay.
So if I want to clean it and it's fixed, it will be much easier to be cleaned. So exactly same, thank you.
Oh, you're welcome.
So exactly same around dental implants. If the tissue is attached, fixed, not moving, thick, it will be much easier to maintain. So let's see this case, how we convert the phenotype from very thin, mobile, to very thick, wide tissue around dental implant. So which one do you think, Dr. Khalid, will be easy to be maintained by the patient and the clinician?
Well, definitely the one with the thick mucosa makes everybody's life easier. Agreed? Well, time to get back to you, Dr. Iyad. Now, let me ask you an important question. We always ask. We place the implant, now it's time to manage the implant. What value does provisionalization have, if it does? And how can we make it easier for you if you decide to do it?
So let's start by answering the question. No provisionals, restoration has no value. So by having no provisional, I'm actually doing nothing. The value of having a provisional is what I'm looking at. But I want to also you guys to help me by placement of my implant into that position that I want to have it on. So this is the story shows the pictures of how implants can be used with provisionals to get your tissue molding, and it. So again, this is just a quick slide of the importance of, especially on the anterior or aesthetic zone, how to mold the tissue, how to get your emergence profiles, and what are the basic rules of trying to get what you want aesthetically. Remember also, having a provisional will give the patient the aesthetic they want, and they can see your restoration before even it happens. Also, patient feels that you gave them a great service by having something restoring whatever was missing. The rules of which is easy, you make sure that your implant on the buccal is convergent, that the morphology allows soft tissue to be, grow around it. And you have to be meticulous when it goes to your provisional, because it makes your life easier when it comes for your final impression. Usually, you play a little bit of some adding and subtracting, but then when it comes for your final restoration, you just have to take an impression. And there is multiple technique of how to capture the tissue that created, because a lot of people sometimes will create the tissue. When it comes to impression time, it's all not transferred to the lab technician, or if you don't have a digital scanner in your clinic, would be the easiest way to do that. So, screw versus cement retain. I would always love to have a screw retain, but again, my question would be to the periodontist surgeon, can you please place it in a way that I can use a screw retained restoration?
Ouch.
No, sorry, we can't.
I'm just making sure that you get my message.
Okay, we got the message.
So with screw retain, you can, as we all know, and it's basic nowadays, you can remove your restoration, you can replace it, you can add to it. It gives you the ability to retrieve and put it back. There's not a lot of risk of having extra cement that goes into the tissue. And as you see with the next slides, I guess Khalid can. And this is also the comparison of screw versus cement. The paper discusses the bone and resorption of bone in both cases. It does not really show a lot of a difference. But again, we were trying to always make sure that nothing on the bone that might affect it long term. I'd rather to have something that I can deal with it, go and be able to modify versus something I cement and I'm not sure. Placement of an implant can be, if it is a little bit not deep, that you can do your cementation, but you're taking risk. You have to be meticulous. What I'm saying down here, you still can do cement, but you have to be meticulous versus having a screw retain.
Well, from our point as periodontists, please try to avoid cemented restorations. We face significant complications when you place the cement, especially if you go with deep placement and narrow placement. We end up always with that concern that there will be excess cement. And excess cement is one of the most well-known risk indicators of having peri-implant mucositis, peri-implantitis even. And this is an issue we try to avoid.
So this is a chart. It gives you, when you have an implant, both anterior and posterior, when you will use cement retain and when you will use screw retain. And again, you have to understand the value of both of them. And even if you want to use cement retain, I mean, you still can use cement retain. You just have to understand how to deal with it. I'm going to go, I mean, it's just a chart will give you a quick idea of when cement retain going to be used and when screw retain is used. And again, anytime I get to have a screw retain restoration, I would go for it 100%.
Glad to hear that.
It's just the placement has to be right.
Thank you.
Just saying.
Okay, we took note. So I think we still have time. So we need just 5 minutes. So we're going to share with you this case that hopefully will build on what we have discussed today. This is a case that was done, and we would like to share with you.
So for this
the
case,
outcomes.
actually, we will discuss all the factors we discussed earlier with full case. This is Miss Katrina. She presented to our clinic having missing central right central incisor, and the teeth are splinted, mobile. We can see the amount of bone loss. The shorts are very short because of the external resorption due to previous orthodontic treatment. So the treatment decided to be for extraction and replacement of those teeth with 2 implants in the lateral incisor area.
So the treatment plan was done and discussion was done that we're going to be removing the upper anterior. It's going to be replaced by 2 implants. So we start by taking a scan and then digital wax up, and then from there we go ahead and start building our surgical stent, which is going to be the next slide. Anyway, I'm just going quickly. And then we also print the provisional, and these provisionals were also hollowed so we can pick up the restoration. So we did not, we're going to pick the restoration from the patient itself. And the wings, by the way, we're going to remove them after it's done. We just for stabilization, picking our. So this is our surgical guide, and this is the provisional. We were not sure about the stability, the initial stability of the implant. So we decided we're going to have both. One is the fixed provisional, and the second one is something as a removable till things get to be ready for provisional. And then the plan as it shows, placement, and then Dr. Amr is going to take from here talking about the bone.
So from the CBCT and the treatment plan report here, we can see that it doesn't only showing us the quantity of the bone, but showing also the quality of the bone. So as we see here, the green is D3 and yellow D4. So it's showing us most of the bone contact to the implant will be low quality bone. So we were concerned that if we are be able to place fixed provisional or removable. This is why we had 2, the removable and fixed are available during the surgery. So I will share with you the case, the video, what I did exactly. So here we're removing the splint, and we're removing the teeth with minimally possible trauma to the bone. And then we start to do the osteotomy preparation. It's fully guided, meaning that we're doing the osteotomy preparation and the implant placement through the guide. So nothing freehand. So we didn't get the torque will allow us to place fixed provisional restoration. We didn't reach to 35 torque, so we decided to go with the removable provisional. And then I went back for the second stage. We did some gingivoplasty, if you notice here in this area, to adjust the aesthetics. And then we started to...
And then the restoration, the provisionals were picked from the patient mouth. Again, after that, and this is actually the picture of the photo of the provisional. Moving to the second one, after 3.5 months, 4 months, the final restoration and x-rays. The whole discussion of these modules were to say that you have options and you can pick either one as long as you understand which way you're going to go and which is best for your clinical case. Again, this is
how we started, and this is the final prosthesis.
Well done, Dr. Amir and Dr. Iyad.
Thank you. We are ready for any questions.
Yes, we are done
Thank
on
you.
time.
Thank you.
Thank you so much, doctors, for the very well organized lecture. It was like a great summary of the debate in the literature presented in a collaborative approach. Thank you so much. Any question?
Thank you.
We thought we were going to have a little bit of a fight, but it did not happen, I guess.
Yeah, that was good.
We were trying to behave. Thank you for that.
Yes. Let's go to...
Immediate. Okay, what's the second question till he finds it?
Yeah, when you said about the provisional, when to place fix or remove, you say something about the tool. I didn't understand.
Okay. Well, I'll start with the torque till you find this slide. In order to be able to place any load over an implant, the implant should be stable enough in the bone to receive that torque, to receive that implant, restoration. Usually it's a crown. But there are certain values that we use as an indicator whether the implant is ready enough to receive it. There are two ways of measuring it. Some tools use what we call the ISQ, which is a different numbering system we did not cover today. But the torque by itself is how hard the implant insertion was. So if the torque that we place the implant with exceeds 35 Newton centimeters, that is usually a good indicator that we can put some load over that implant. Not the full load, because this is an immediate implant. Actually, not the handpiece, the micromotor that we use to place the implant has that torque in it. It's measured. You calculate the torque. It gives you that. There are other ways of doing it manually, but we don't really think it's very objective. The better one is doing electrically. So, Dr.
Yes,
Amir.
could you please show the slide on the screen? So the socket shield, it's called partial extraction therapy. So instead of removing the tooth completely, we keep part of the tooth connected to the bone. So if you notice here, this is the full tooth. Then we can do cut here in this area. We keep this part of the root intact to the buccal plate, and then we do some preparation. We remove this part of the root to make it at the same level of the bone or slightly apical to the crest of the bone. So the main idea for this, if we have very thin buccal plate, to maintain this buccal plate, and at the same time, if we have the bone and part of the root is still available, this will maintain the soft tissue and bone. We'll still have the supracrystal fibers which connected to the root, so this will maintain all the architecture of this area. And then we can place the implant, and in the gap in between we can fill it with bone graft. Thank you.
I have a question for Dr. Amir. Since we both came from the same program director, Dr. Bisada, I remember he used to say, bone sets the tone, but tissue is the issue. So when do you consider soft tissue grafting around implant, and would you do it before or after placing the implant?
Thank you very much for this question. in general, all graduates from Case Western, they are in love with soft tissue grafting. And they, even if there is no excuse, we try just to do soft tissue grafting. So in general, I consider soft tissue grafting around dental implant is extremely important. If we have less than 2 millimeter keratinized tissue or thin mobile tissue, we do gingival graft. So in general, if I want to answer your question, if I have less than 2 millimeter keratinized tissue, for sure I will do gingival graft for dental implants. For the question before or after, I do my best when I start my procedure, even when I start with the flap reflection, to have enough tissue for buccal and lingual or palatal. But if I don't have chance to do this, I do the implant and I will do the soft tissue grafting with the second stage surgery. Thank you.
So there is no more questions. Please accept our small appreciation for your participation in the Kuwaiti Dental Association Conference.
Thank you very much.
Thank you, thank you.
I would like to take a
Well,
Thank you.
لازم نصور.
شكرا جزيلا.
يعطيكم العافية. شكرا.
الله يعافيك.
الله يعافيك.
خلي ما راح نحكي.
with our next topic, mucogingival surgery around implants, the PIN code, with Dr. Mohammed Bassam. Dr. Mohammed Bassam is an ITI member and a member of the American Academy of Periodontology. He graduated as a GP in 2006 and then as a specialist in perio and implant dentistry from the Lebanese University, Lebanon in 2013. He has more than 10 years of private practice experience in full mouth rehab, hard and soft tissue reconstruction, in implant and aesthetic dentistry, and surgical and prosthetic digital dentistry. He's an international speaker, presented several international lectures and hands-on workshops in advanced periodontics, implant dentistry, and hard and soft tissue reconstructions. He's also a founder of the GBR Made Easy hands-on course series. Also, we had the privilege to have Dr. Bassam last year with the first Kuwait Dental Association of Perio Symposium, and he was a great addition to our symposium. So please welcome with me Dr. Bassam.
Thank you so much, Dr. Munira and Dr. Basma, for presenting me. It was a pleasure to be with you last year in the KDA Perio Summit, and it was great. Last year we spoke about bone augmentation, and this year we're going to talk about soft tissue reconstruction. I'm privileged to be with you among these great speakers in the KDA and the Kuwait Dental Conference 2024, the 24th one. And I like to start with this quote. Coming together is a beginning, keeping together is a progress, and working together is success. It applies as well to our implants. It's important to put everything together, the implant, the soft tissue, and all of that. But when the things stay together, that's going to be the progress. But what's most important is when it all works together, which is the function, and this is the important thing. And we all want that our implants will last as long as these Roman columns in Baalbek in Lebanon. Today we're going to discuss the mucogingival surgery around implants. We're going to talk a little bit about the PIN code, which is how much soft tissue we need around our implants. As Dr. Basma just said, as Dr. Bisada said, what sets the tone? The bone sets the tone, and what is the issue? The tissue is the issue. So we have to talk a little bit about tissue when we are doing the reconstruction of the sites. Okay, so we all like to have cases like this, to end up with these cases, but unfortunately, sometimes we get these things, sometimes no. And whenever we include the implant complications as bone loss, as our severe bone loss, our excessive bone loss as an implant complication, we go to 18.7% extra of failure of our implants. And you know that the market of dental implants is getting more and more increasing and getting larger more and more. In 2013, like 11 years ago, it was expected that it's going to raise of 0.7 million implants sold only in the US. And today we are in 2024, so you can expect how much it's raising and elevating. So it's important here we're talking about soft tissue, not bone augmentation and the reduction of bone that we have. We're talking about soft tissue. Whenever we have a complication of the site, of the implant site, talking soft tissue, either we created the problem or we received the problem. Okay, so when do we create it? We create it when we do our surgeries. Whenever it's a stage surgery, we have to do 1, 2, 3, 4 surgeries sometimes. And sometimes we receive it, this is when we are relieved. Okay, we received the case like that, we have no problem, we're easy. And the most important, one of the doctors, I think Dr. Ramon said it, that whenever possible to prevent any complication in soft tissue will be great. So what are the main risk factors? So what are the main risk factors for the implant complications? First of all is the bone dimension. If we don't have enough bone dimension, soft tissue requirements, and 3D implant position. So as we said, not all cases are great. You can see these 4 cases. They are different. It's mainly a problem in execution or diagnosis or assessment. Like in the first one, placing two implants too close to each other to replace one tooth, which is the tooth number 6, was a great, what was a big mistake. Of course, we're gonna have bone loss in the middle. We will end up with an abscess as well. These implants are non-restorable, so we had to remove them. Another one, the doctors just finished discussing and debating about immediate and non-immediate. Or these implants were placed immediate, and you can see this is the lateral and this is the canine, and these are difficult to restore. And especially when you do these implants, it's not easy to tell the patient, okay, so we cannot restore it, we have to remove and start over. Here we have a failure of bone graft, which is ended with loss of soft tissue, loss of the grafted bone, and the fourth one, peri-implantitis, loss of bone, loss of soft tissue. So it's important to prevent it. It's important to stage our surgeries, and to get a success in surgical phase, we have to have enough hard tissue, proper 3D implant positioning, and proper soft tissue, morphotype. And just to add a little bit to what Dr. Khalid said a few minutes ago, whenever we're going with immediate implants, it's important to place the implant in the optimal position. So if you can place it in optimal position, go for immediate, otherwise don't. Okay, so what is the dimensions that we need, the soft tissue dimensions around implants that we need? We will start with the width. I will not put a lot of papers. We're at the end of the day, so lots of words will be a little bit complicated. So whenever it's observed that we have less than 2 millimeters, okay, it was associated with clinical parameters of inflammation. So less than 2 millimeters, there's inflammation around our implants. This is this was in 2013, that was 11 years ago, and nothing has changed. The same in all the it's the same in all. I'm sorry, there's a problem with the pointer. Okay, so where do we have lack of the width of keratinized mucosa? We have it in atrophy of the jaw and in surgical procedure. Whenever we do a surgical procedure, we're gonna lose some of this keratinized band. For example, this is the situation in the beginning of the case. This is the mucogingival line. We have loss of the band. When we do our grafting, for example, we placed 2 implants with external sinus lift. We added some bone graft, the bone on the buccal side is very thin. We closed it, and now you will see how the case was. And this is when we grafted. This is all is grafted bone, plus we displaced the mucogingival line more coronal. So we reduced the band of keratinized mucosa, plus we added bone, so we have to restore all of that. We opened, we have a great bone, okay? We're happy with that. We set the tone, now we have to move our tissue back to the buccal side and restore our placement of mucogingival line and restore more than 2 millimeters of keratinized band on the buccal side. If we go back here we had thick bone. We left some periosteum on the bone, so I can place collagen sponge, PRF, whatever I like, just to close this area. But in the next case, as you see there, the bone is very thin on the palatal part. I couldn't, and the soft tissue was very thin, so I preferred to go with a pedicle connective tissue that I moved over my implants just to cover it and sleep at night. As you see, for example, in this case, with coronally advanced flap, we did bone grafting here with a tenting screw. You see that we had a decrease in the width of our band. So as well here, when we do with coronally advanced flap, we will move the mucogingival line from here up to here. So on our second stage surgery, it's important to reverse that by doing here a peculiarly positioned flap with papilla preservation. So we didn't cut the papillas, and we moved the mucogingival line to its original position. And now what is important for us is to wait for the healing. So how to prevent coronal displacement of the mucogingival line? I couldn't but placing this slide because I like it a lot. We have this problem, especially when we have extraction socket. Either we placed an implant or we want to do a bone graft. So first we can go with a free gingival graft. Okay, so this is the free gingival graft. We just go with a trifimber or our blade. We just take a free gingival graft around the palate and we suture it. In the beginning, I said to myself, oh, that's gonna be great, I wanna try it. I said to myself, I'm gonna have a smooth, after 10 days, I will have like smooth tissue, but actually it wasn't. This is the healing after 10 days. And this is what you're gonna find. Whatever you do, this is what you're gonna find after 10 days. Another one is pedicle subepithelial connective tissue graft. For example, in this case, we had a failure of the implant on the second premolar, and there was a sinus lift there, so we had this failure. And if I want to keep this implant uncovered, I couldn't go with coronally advanced flap to close over my over the placement of my implant or where my implant was. So what we did here, split incision on the palate, a pedicle connective tissue that is still attached to the mesial, and we moved it to this over our socket. And then what we do, we go with our blade as well, split thickness under this remaining palatal band, and that's the time that you're gonna insert your buccal suture. You will go buccal under this band, take your soft tissue, go out at this point, and then pull and tie, and then you close your socket or where the implant was or whatever the thing was. So this hole that you have, you're gonna close it, and then you're gonna suture the donor side and suture over your connective tissue. The third thing that you can use is biomaterials. For example, in this case, we placed an immediate implant, bone grafting, and then we put mucograft over it, and this is the healing. That's at 10 days, at 20 days, and at 30 days. As well, we can go with biomaterials on and on and on. Here we used mucograft. You can go with tolerable, resorbable membranes that you can keep exposed. You can go with PTFE membranes, and each one has its own indication. And finally, we can stage our treatment. So how much is the thickness that we need? Bilink Vicious in 2015, nothing new. If it's less than 2 millimeter, expect that you're gonna have bone loss. So just to wrap it up quickly, why do we have bone loss? We have bone loss because there's biological width that's gonna be formed around our implants. So it makes sense that if the soft tissue is less than 2 millimeter or 2 millimeter or less, you're gonna have a resorption of 1 millimeter additive that will be for our biological width around implants. So it's important to check how thick is your soft tissue. So how thick is your soft tissue? It's easy to do it whenever you do the cut. Okay, or you can do it prior to your implant. Just go with a probe and check how thick is your soft tissue. So an answer here for Dr. Basma, who just asked a question, if you do soft tissue graft before and after. For example, whenever you have less than 2 millimeter in thickness, at this stage, you can do one of the two things. If you have enough coronal height for your crown, you can add a soft tissue graft here to thicken your soft tissue at this time of placing your implant. Or if you don't have enough soft tissue, you can just sink your implant 1 millimeter below, and let's say you have 2 millimeter, you sink your implant 1 millimeter below, now you have 3 millimeter. So at the end, you're gonna have a remodeling of the bone without losing any of the bone that is at the level of the neck of your implant. or at the platform of the implant. So this is a 1-year follow-up in thin tissue and in thick tissue. In thin tissue, we had bone loss. In thick tissue, we didn't. Despite that, let me tell you, that's a, I know, that's a BioHorizon implant, and that's a Zimmer implant, and it's well known that the connection of Zimmer implant is much better than BioHorizon implant. We had no bone loss on BioHorizon, and we had bone loss on Zimmer, and the tissue was the problem. Okay, so another thing, in the presence as well, in the presence of keratinized mucosa that is less than 2 millimeter, there was significantly discomfort. The patient reported maximum discomfort. So the soft tissue should be 2.5 and more in width and in height. So what is the pink code that we need? More than 2 in width and more than 2 in thickness. So the first thing that we face, we're going to start the sequence of the series of cases, the atrophic mandible. Whenever you have, this is the most challenging cases, you see it a lot, whenever the patient comes with a bridge, and then we remove the bridge, and what do we have under the bridge? No bone. So this is when we're going to start the problem. This is where the problem starts. Okay, so this patient, we will have a little bit touch of bone grafting. We have atrophic jaw, so we have to start with bone graft. As we have just, we spoke about it like in the 4th or the 5th slide. Whenever you have several surgeries, you're gonna lose your keratinized band. So in this surgery, we opened the first time, we did bone grafting. So at the healing, you will lose soft tissue. And then you opened again, you placed your implants. And then another baby bone graft, and we lost more soft tissue. Now we have to augment it. We are lucky if we have 2 millimeter of band here, so you can just reflect it to the palatal side or the lingual side and try to augment on the buccal. If not, you have to do your graft on both sides, which is a bit challenging, but it works. So this is my incision that we're gonna do. If we don't have, if we are a periodontist or a oral surgeon who have done soft tissue graft, he will know that we're gonna go here with a split thickness. If not, we have to go with a split thickness because the only way to vascularize your graft is the periosteum. So you have to have an intact periosteum, split thickness, and try not to tear it because you will use it for 2 things. First of all, you will use it for vascularization, and the first 3 days, your graft will be, especially the free gingival graft, will be, the nutrients will come through diffusion, and you will use it for your suturing. So we took our free gingival graft from the palate. We placed it. The first sutures that you put is to stabilize your soft tissue graft, and wherever you see there's a mobility, you have to stabilize it again. You can either go with roll, a sling suture over your graft, or you can just find the best way to stabilize it. There's different ways to stabilize your suture. Just don't exceed with your sutures, and don't squeeze your soft tissue. This is important. So find the best way you want, and if you want, just document and publish it. It will be under your name, and then we will say that this is the way you suture it. And this is the time of suturing, the surgery, and this is after 15 days, or I remember that's 10 days, and this is after 25 days. And just keep in mind, whenever you're thinking soft tissue, this is how we started, this is how we ended. Whenever you're thinking about soft tissue, keep 2 things in mind. First of all, think blood supply. The second thing, give it time. Just give it time and you will succeed. Don't worry. Just don't go right away. For example, in this case, don't go for impression right now. Wait at least 2 months. Why? Because the maturation of the collagen fibers in the soft tissue in the connective tissue, which is underneath your epithelium, starts at the second month. So better not to start prior to the second month. Okay, so wait for 2 months and then you can start with your healing. And whenever you're going with anteriors, just try to wait more and more. You will see some cases next. Okay, so what is the free gingival graft dimension? And let's talk a little bit about the donor side. And whenever you have more morbidity or less morbidity, I will go quickly on that. To wrap it up by Professor Giovanni Zucchelli, Lorenzo Tavelli, which is well known in the Europe school for soft tissue grafts. Whenever you have a soft tissue that is in height, free gingival graft in height, that is more than 4 millimeter and in width more than 14 millimeter and thickness, which is more than 2 millimeter, you're taking more than 2 millimeter, the patient will have more discomfort at the site of at the donor site, which you can try to manage it with either PRF, which either PRP, put some hyaluronic acid, try to cover it with periacryl, put your palatal plaque. For me personally, I do it all. I put PRF, I put over it periacryl, and I put over it a palatal plaque just to sleep at night. So I did it all. There's nothing missing. There's only one thing that I used to do, but I stopped it. I used to, whenever I have some excessive bleeding, I used to suture the artery. But I had, in 2 cases, a necrosis in the palate. So I stopped it. Whenever I need it, I use it, but most of the times I don't need it anymore. I'm more and more careful when I'm harvesting my connective tissue or the free gingival graft. Now, let's talk about the shrinkage, which is also important. Okay, so I will go quickly. The mean standard deviation of shrinkage of a free gingival graft without implant by this study is 24%. So whenever you're placing a free gingival graft, just you're gonna expect 24% of this area that's gonna shrink, okay? So whenever you're going with free gingival graft, try to make it a little bit big. So if you need a 2 millimeter or more, or let's say 2.5, you're gonna go with 5. Because as well, there's a greater reduction in creatinized width, which is around implants, which is greater over implants than over teeth. So if you're doing 2 gingival grafts around implant, around teeth, around implants, you will expect greater shrinkage. And by Alberto Monge, free epithelialized graft are exposed to dimension changes. He reported 40% of change, 40% of reduction, but that was a case series. But from a doctor, our professor, which is Alberto Monge, he's doing a lot of surgeries, so he's somehow predictable, and he's somehow, let's consider it as evidence-based. Okay, another session, another case, we go split, we open up, we take our graft, we place it, we suture. If you see here, we have a mix of sutures, just like the one before, and here I go round over it just to stabilize it. So no squeezing, stabilizing, and no squeezing. Least suture, more squeezing. And this is after 2 months, and you can see here how the beautiful capillaries are coming from the old soft tissue to the new soft tissue. And whenever you're going with free gingival graft, you'll always have this white patch. So in this case, for example, we're placing our implant. So we're opening our flap, extracting the tooth number 8, placing a 6 and a 7. Beautifully parallel, we're doing everything right. But at the end of the day, if the bone was good, we still need the soft tissue to be good. If not, we have to create it. We have to modify it sometimes. Okay, so I'm gonna go quick because we're gonna be short on time. So this is the situation. This is my 2 implants. Whenever you're trying, at this stage, try to innovate. Whatever, if you place your free gingival graft here, you will have a problem in the papilla side. So whenever you're harvesting, just harvest it the right way and adapt it. And then you do your suture, and this is the healing. It's beautiful at the 30 days. At day number 30, it's beautiful. But when I waited another month, you see the shrinkage that I had in this area. This is how thick was the band, and after shrinkage, this is what we expect. Especially, we expected on molar tooth number 6, tooth number 7, and the mandible, because we have the insertions of the muscle at that point. So sometimes the insertions are high, you will have more shrinkage. So let's go to the maxilla. Here, for example, you have to assess what is the need that you need. What are the things that you need? Here, we need height, we need thickness, because the mucogingival line is over here. And we need thickness, okay, and we need width. So at the implant in the back, the 7, we don't need anything, we just do a simple second stage. But on the 2 implants, on the 2 premolars, I will go split with a beautiful trapezoid incision. I will go split just to remove my epithelium with a little band of connective tissue. So I will not have necrosis later on. And then I will go to the base of my connective tissue, and I will start splitting it out, and I will extend my incision to the buccal side with papilla preservation. And then I will roll. This is the connective tissue that is attached to my buccal flap. I will roll it, suture it, and then I'll put a PRP, PRF, collagen sponge, and then suture. And whenever you're going from the palate to the buccal, always try to go a little bigger. Here I was a little bit shortened with this implant, the placement of this implant. If I didn't have this implant, I would extend more to the distal. Why? Because you're gonna be short. You're going from a smaller diameter to a bigger diameter. Or from smaller surface to a bigger surface. And this is how it is. For me, I consider that any surgeon needs a touch of prosthetics. So if you are a surgeon, if you go with a little bit of prosthetics, you will see a little bit how the things will go. We did the soft tissue graft. I conditioned with temporaries, and this is how it is after the temporaries. And now you send it to the prosthodontist, who will be so happy. We're just gonna take the impressions. I will not say a word about it. Okay, so sometimes you have this little periodontist inside of you that needs to play around a little bit. Here we don't need anything. You have enough thickness, you have enough height, everything is great. This is the perfect case. You have very, very thick bone where you can place your implant. If you close your eyes, you place your implant, it's gonna be in the right position. But still, we are periodontists. We like to play with the soft tissue. So at second stage surgery, actually we placed an implant on the mesial, and here it was socket preservation. And then now it's time to place my implant on tooth number 6 and uncover tooth number 5. So I started with papilla preservation incision, and I extended a little bit my incision a little bit to the palate to have thicker band. I exposed my implant on the tooth number 5, placed my implant on tooth number 6 with sinus lift, of course. And now I have these 2 implants. I have a thick soft tissue here, a wide band of soft tissue. So what can I do here? What is the lack that I'm gonna have? When I suture, I will have lack in this point. So what I'm gonna go with a little bit of Palachi. I'll just do my incision here and roll my soft tissue in between to the papilla area. And then I will suture it. This is the healing after 14 days. But as I told you, just give it time and you will see miracles. And this is the healing after around 2 months. As well with with temporaries. So I temporized the first one, and I waited for the second one until after 4 months, and then we placed the two crowns together. And these are the two crowns, beautiful papilla, especially on the mesial. I was fascinated when I saw this. Okay, let's spice it up a little with this case. So this patient came to my clinic with a discomfort, referred from the prosthodontist with a discomfort on one of the implants. I was so excited to start with this case. So the patient was having a mobility of this implant. So I was so excited, I gave anesthesia, and I removed the implant. And what I found around my implant is impression material. It seems this patient was treated with immediate implants, and they took for her an impression to place immediate loading crowns. And it seems some of this material, it seems that some of this material went inside the socket. So I removed this implant. Now it's time to assess the two implants in the front. They have a lot of bone loss, so I expected some of the impression material there, so I had to remove these two implants. So I removed these two implants, placed bone graft, and then an implant on the side here. I did bone graft as well, and I placed two new implants after grafting the side. Now I'm assessing the implants on the side. I have the first one, lack of width, and here lack of thickness. So on the first one, I took one graft, I split it in half. Here it's free gingival graft, here it's subepithelial connective tissue graft, and I sutured. On the other side, where we removed that implant, if you remember, I placed another implant, and it was time to uncover it. Okay, so my implant is here. Here I have a loss of the width of the soft tissue. So I tried to innovate a little bit, so I went with a new kind of incision. Okay, so this is my incision, and it's still attached to the buccal. And then over that, under this soft tissue, is my other implant. So I exposed it, placed my healing abutments, and sutured. There's a problem. Okay, so this is the healing, and then the patient, this is the healing after 2 months and a half, and now it's time to take final impression and go with my final prosthesis. As you see, we have enough thickness and we have enough height, thickness and width of soft tissue. And this is the prosthesis, and this is how the patient came to me, and this is how she left, with a big smile. Okay, so I'll finish it with these two cases. It's always nice to stage. Just in this case, I didn't go with immediate implant because when we extracted, there was no buccal bone, so I left it to heal. And then after 3 months, I opened, placed my implant, did my bone graft, and I sutured. And now I have the healing. I have lack in thickness, and I lost the papillas. So whenever you do bone graft and you cut the papillas, you're gonna lose them. So it's time to regenerate. So in this case, I did an eye incision. I staged my second stage surgery. I did my eye incision, and these two bands of soft tissue, I pushed them towards the papillas. You do just a little bit of dissection under it, and you just push them, and you suture these to this soft tissue. So you're adding more soft tissue on the sides. This is how it is. And then I placed my temporary. I know that my temporary will not be the best. I still have like bulby papillas, and I have lack of thickness on the buccal side. So I will go with my microblade. On the buccal side, I will do my dissection. Now it's time to add more for the thickness. So I harvested my connective tissue. As you remember, we have enough soft tissue on the papilla area, but we have a problem on the buccal. So now I'm adding more on the buccal side. So this is my connective tissue. I like to suture it at the base. Some other doctors, they suture on the side and then the other side. For me, I like to take it on the base, suture on the base, but whenever you tie on the base, try not to tie it a lot. Just keep it a little bit, not loose, not too tight. And then another suture on top. And here I wanted to show you when I place my temporary, you see with composite, I modified the emergence profile. This is the right time to place your temporary with a great emergence profile. This is when you do the surgery, because all the healing will go around it. It's easier for you you will have a better outcome. So this is how the case is before delivering of the final crown or before taking the final impression. And this is how it is before our connective tissue and modifying the temporary. So it's important as well to keep in mind that the temporary has to be modified to mimic the shape of the final tooth. And this is the result before placing our final crown. So I'll finish with this case. Okay, this patient came to me with a problem on this tooth. She placed that implant immediate with a final crown which is cement retained. Like this, it looks well, but when she opened her mouth, we have peri-implantitis, and I have a pocket of around 10 millimeter post drainage, and with the CBCT, I have loss of loss of bone around this implant. Still a little bit stable, but we have loss of bone. So in patients like this with high smile line, it's very frustrating to try to work on these implants. Whenever you see a lot of bone loss, try to remove and start over. You will have better results in most of the cases. So I decided to remove this implant because no Western paper has told us that peri-implantitis has the right to defend itself. So I prefer to remove this implant now. So I removed this implant and waited for the healing. Just 5 minutes. And at the time of placement of my implant, the implant was placed with a 0.5. The implant is out of the bone with a 0.5 cover screw, and I was stenting around over this implant. I placed a double layer membrane. The first membrane was placed with autotax, with tax, and the second one with sutures. The first one is both of them is BioGuide, both are collagen membranes. And then I closed. But still, I will have this depression. So in this case, I have lack as well of thickness in both papillas and the buccal side. So at the second stage surgery, I didn't cut my papillas. I left my papillas intact, but I went with a semilunar incision on the, let's say, occlusal palatal side, and I went with split thickness on the buccal. I harvested my connective tissue, and here, because I have to do two things. Okay, I inserted as well, as you see, I took my suture, I go in, hold my connective tissue again in the connective tissue, and go out and then pull my threads, and the soft tissue will go inside properly. But because I wanted to augment the papillas, I had to cut my connective tissue, and these two flanges, I just inserted them under my papillas just to elevate them. I placed my healing abutment, and this is the final suture. The incision was this simple. This was my incision. As small as possible, and whenever you're doing your dissection, try to elevate more just to have easy, the manipulation of the soft tissue is easier. And this is the healing with the temporary in place. And this is the temporary one. I removed it a little bit just to see the emergence profile. And this is how it looks at the day of impression. And this is how it is at the final. I'm so sorry I couldn't close that, that triangle. I'm still thinking about it until now. But if you look on the sides, it will not show, but I like to show it here. So this is the emergence profile on the two sides, right, lateral view. And our take-home message, by the way, two things are, one of the things that will give you more success is your ceramist. So this is a natural tooth, and this is an implant. You see how he mimicked the same tooth? So the take-home message is, first of all, respect the basics of implantology and a proper diagnosis and execution, so we will not end up like the third slide. Bone support for long term, and think blood supply and time whenever you're going with soft tissue graft. Think bone remodeling and biological width around implants whenever you're talking about the thickness and why we want more thickness of soft tissue. Measure twice and cut once. This is very important. Just always measure twice and cut only once, because it's not a composite filling that you can redo it, or an endo that you can remove it and do it again. Once you cut, you cannot go back in time. Measure twice and cut once, and very importantly, the maintenance phase. Always try to call your patients for maintenance. This is my Instagram if you want to contact me, and if you want to see my daily cases. And one eye on our profession and our conference here, and the second eye is on Palestine and Lebanon and the war there against humanity. I would like to thank you all for being here. I would like to thank you all for having the time to come. I know it's the end of the day, and I'm so happy that we still have a few that are eager to learn. Thank you.
Thank you so much, Dr. Bassam. One word, mashallah.
Taslami, on time.
Very nice, neat documentation and information and knowledge. Thank you so much for giving us this opportunity to take a look, a peek on your practice.
It's pleasure. It's my pleasure to be
so
here
much.
with you. Thank you so much.
Do you have any question? Can you repeat, please? Just to hear. خلص أنا بجي لعندك. Yes. Whenever for example, if you're placing your implant and you want to go with, let's say you're going flapless. If you're going flapless, for example, you're going to place your connective tissue, but still you have to suture it. You have to stabilize your connective tissue. How are you going to stabilize without suture? It would be less sutures. Yeah. So according to the case, how it depends. So what I'm showing you here is the most common techniques, with a little bit of thinking out of the box. But still, if you're placing your implant and you can just go with an incision that is a little bit a pinhole, and which is beyond the mucogingival line, and dissect, place your implant, try to hold it with 2 stitches, it's fine. But try to place your soft tissue graft. Since you're going with soft tissue graft, you're doing your surgery, try to do your surgery the perfect way, despite that the patient wants to see sutures or no. If he doesn't like the sutures, you can place them more to the palatal. And just to give you a little hint, whenever you're going with big cases, just give the patient all the details that you have about your surgeries, all the steps that we're gonna do this surgery and this and this. It's a package. So you cannot go with, let's say, place your implants and then you're gonna convince the patient that you're gonna do fringes of the graft. You can't. You have to start from the beginning, just to tell them the steps that you're gonna do. Thank you so much, Dr. Bassam.
Most welcome. Thank you.
This is a small appreciation from the KDA for your participation.
Thank you so much. في حدا؟ Thank you. كيفك؟
فيني.
All right. I would like to present our next speaker, Dr. Bassam Rabi'. Dr. Rabi' is a prosthodontist graduated from Pittsburgh University, USA. He's a diplomate of International Congress of Oral Implantologists. He was a visiting lecturer at Continuing Education Department at Tufts University, Boston, Milan University, Italy at 2007, Harvard University 2010, Louisiana State University, and Dental School at Dental School of Sharjah University, United Arab of Emirates 2009. He's an owner of One Dental and Facial Concept. Please welcome Dr. Bassam.
Thank you very much. First, thank you very much for the long introduction. Okay. It's a great pleasure to be in Kuwait, and I understand it's the last day of the conference, the last hour of the conference, and I appreciate who are still here. And I appreciate anybody else who has left also. I understand always the end of the day, end of the conference, it's always like this. As I said, it's a great pleasure to be here. This is not my first time. My first time was 44 years ago. I was 10 years old. So I don't remember anything about Kuwait. This is like my first time. And I really appreciate the invitation from the KDA. It's a great pleasure. And today I'll just be showing you implants in the aesthetic zone, how to navigate the challenges that we as prosthodontists, as periodontists, as oral surgeons, as restorative dentists deal with these cases, and how to navigate for a long-term stability, functionally and aesthetically. So when I look at these cases, I like to start my presentation with a case referred to me like that. Not showing what I did about this. I'm just telling you, these are the cases. These are the integrated implants that you get in your private practices. You can see the problems and complications, and now we have to solve these problems. It's very challenging. Takes a lot of time, a lot of effort, a lot of manipulation from hard and soft tissue. Placing implants like this, you get bone resorption, recession, look at the restoration. There are many factors for the success of implant dentistry. Basically, as a prosthodontist, I've been placing and restoring implants since '96. So it's over 25 plus years now. And I'm doing a lot of soft tissue, bone grafting, all the advanced surgeries. So basically a prosthodontist who does perio implants also. So when I look at these cases, there's a lot of challenges and a lot of work that needs to be done. And as I said, as a prosthodontist, these are my cases, the one before is a referred case. When I look at this, look at the above and the lower, two different cases, 24 years, 22 years old. At that time, we never thought about the soft tissue, the hard tissue. It was the era in 1996 that started immediate extractions and immediate implant placement, and that's what I used to do, immediate extractions, placing the implants in the socket. Never thought about the soft tissue, the bone, the underlying structure. And what do we get? Never analyze the soft tissue. Look at the soft tissue. We have recessions, failures, bone resorptions. We have to deal with pink porcelain to accommodate for our complications that we actually do for ourselves and our patients. So it's very challenging. Same patient, look, this is the above picture. That is like 22 years ago, and this is like 18 years ago. The difference. You leave it, we have integrated implants, but what are you gonna get? You're gonna get bone resorption, recession, cosmetic failure. Functionally, it's still functioning, but you know you are heading to a failure. We have to analyze the soft tissue, very important in the aesthetic zone. In the morning, I had a 3-hour workshop. I just gave them just few brief introduction about the soft tissue. Any one of you who has been doing implants in the aesthetic zone understands what I'm talking about, the soft tissue. The soft tissue phenotype, biotype, what quality you have. How does it react to stresses, to irritation, to trauma? And how can you keep the soft tissue and the underlying bone structure and the surrounding implant superstructure and everything intact for a long term? We have to analyze the bioform. We have scalloped, thin biotypes, and we have thick, flat biotypes. As I was saying in the morning for the hands-on, our best types of implant patients are the flat thick, because when you have flat and thick keratinized tissue around your implants, you know you don't need to interfere with more soft tissue grafting, a lot of procedures. It's going to stay there. This is the problem. Although it's more cosmetically appealing because you have this scalloping and you have the interproximal heights of bone very high, where you're going to get this very good papilla, but it's very fragile. If you don't know how to manipulate this area properly, you will get recession around it. Introducing soft tissue. We as prosthodontists, periodontists, oral surgeons, implantologists, and I believe I just came 1 minute before Dr. Bassam also, right? Bassam, Mohammed Bassam. He's a periodontist, I can see, so he does all this stuff. And he will understand, everybody will understand. You have to implement in your practice microsurgery. You have to have all the tools for microsurgery. Microsurgical instruments, microsurgical sutures, microsurgical blades, good magnification to see properly, to do all these types of surgeries. Because specifically in the aesthetic zone, we have a lot of failures because of the manipulation. We don't understand it properly. We're not using the right tools, the right sutures, the right blades. So trying to implement microsurgery, because when you do that, you reduce the amount of trauma, complications, swelling, any kind of scar tissue for the tissues. And you have to understand how to do these techniques. Why? During placement of implant, after placement of implant, or solving problems from other cases or your own cases. This is my practice back in Cairo. I have a practice in Cairo and in Lisbon, Portugal. That's my team up there, and down there is Portugal, Lisbon. So when we come to think about the aesthetic zone, everybody places implants. Implants will integrate. Whether you're doing implants, immediate extractions, placing our bone, whatever the bone you're placing, you're going to do some type of soft tissue grafting. The whole idea is to have this type of stability of the soft tissue around your implant restoration. Year 1, 10 years. When I look at this right now, and any periodontist here will understand, I don't like this. It's still thin. Although I did some soft tissue grafting from 10 years ago, yet it's stable because the quality of the soft tissue that was placed, it's good quality. It's real connective tissue quality. In immediate extraction sites, which again, in our private practices, it's everyday scenario. All fractured crowns, root canals that have problems, you need to extract this and you have to place an implant. You want to restore it. And these are the most challenging. From the studies that we know from Lindy and Nevins, if you extract a tooth, you don't place anything, what's going to happen? You're going to lose this labial plate completely. In a study, they placed bone, and in this type of study, they placed bovine bone because it's a very slow turnover biological product. Yet, they found in the study, even when you place bovine that doesn't resorb that easily and it takes time to resorb, you have 20% of resorption in this area. This area, which is the labiocrestal part. And this labiocrestal part is the area where all the problems happens. That's where your head of implant is. That's where the interface between your implant and the superstructure. That's where the recession happens. That's where all the aesthetic problem occurs. So what's the reason for recession and color changes around implants? Look at this case. Over 20 years ago, scenario, fractured tooth, upper central, extraction, and we want to place an implant. That's over 25 years ago, actually. Normal atraumatic extraction, and at that time, as a prosthodontist, and Dr. Waleed, you will understand, you've been trained in the States like me, in the prosthodontic department 20 plus years ago, we never were taught about soft tissue or bone. You extract, place the implant in the middle of the socket. We don't do this, we know that. But at this time, look at that. You can appreciate how thin the labial plate is, atraumatic, opening a small flap, placing the implant in the middle of the socket. That's how we were trained at that time. And this implant is the old system, the Brannamark system. Everybody knows Brannamark, the external hex. There's my implant in the center, beautiful, everything's fine. We have a small gap labial, a small gap palatal. Do I fill it with anything? At that time, we had no idea. We were not trained to do that. Maybe periodontists were at that time. Placing a collagen membrane. Why? Because we were taught, place a collagen membrane so you don't have these fibrous tissue going inside. Tacking it, very beautiful pictures for lecturing. And then, that's my outcome. This is an integrated implant. It's integrated. Integrated mesial, distal, palatal, but you've lost the full labial plate of bone. And we all understand when you want to remove an integrated implant, you are destroying a lot of bone in this aesthetic, challenging area. When you have labial bone loss, you get recession of the soft tissue and labial contour loss. And now after you've placed the implant and you have some soft tissue recession, some problems with the bone, you have to solve it. Now you have to go into microsurgery again, placing some soft tissue graft, doing some techniques of tunneling around the implant, around the natural adjacent teeth, suturing with 6, 7, 8, 0, whatever you want, to try to solve all these problems. As I said, there are 3 factors in implant dentistry for long-term success. One is biology of hard tissue and the soft tissue, and one is biomechanical considerations in implant prosthodontics. If you have the 3, you will succeed. Any factor of those, you have to compensate it with something. Design of the implant is very important. Prosthodontists will know this study. It's called the photoelastic stress and strain analysis, in which we know from this pattern of strain and stress, 60 to 70% of the stresses are concentrated at the head of the implant. Where is the head of the implant? It's the area where 20% by default you get bone loss, remodeling. It's the area where you have your prosthetic interface. It's the area where you have your sulcus and your gingival tissues around. Again, where all the problems happens. So the design of the implant is very, very important, and that's why all of you know, or most of you understand, that most of the companies now are trying to do some microgeometrical design at the head of the implant, where they have micro threads, micro channels, whatever you want to call, to increase the surface area contact around bone so it reduces the amount of stresses in this area. That's the Red Sea in Egypt. Okay, implant diameters. When you are going to extract a tooth in the aesthetic zone, what's your implant diameter? What do you choose the implant diameter according to what? Do you just take any diameter, any length, and you place it? Or there are some kind of rules that you have to follow? It depends on the gap size that you want to leave. And it depends on the socket size where you're extracting and placing an implant. And this gap size that you want to leave, are you going to graft or leave it? Because till this moment, I see a lot of clinicians, they don't graft the gap. When you have 1-2 millimeters of gap in front of the implant, they tell you it's enough, the blood clot. And there are studies like this. But remember, there will be resorption by default and remodeling in this area. So it's better off to fill it. Personally, I always fill this gap with a biological material. Now, what's the thickness? What's the average thickness of the labial plate? We're talking around 0.7 to 0.9 millimeters to 1 millimeter. That's anatomically, that's the average thickness. So it's very thin. And when you're extracting, you have to extract atraumatically because you don't want to disturb this area. And remember one thing, this part here, once you extract this tooth, you have the bundle bone. This is the bundle bone, this area. The bundle bone where the periodontal ligaments are attached to this area. And it takes its vascularity from this periodontal ligament. Once you remove it, this bundle bone disappears, regardless what you're going to be doing. Placing implants, we virtually plan. We know, all of us, that we have to place implants in the right directions. More palatal, you have to leave a gap, at least 1 to 2 millimeters in front of the labial plate inside, or you're going to get this outcome. This is the gap you need to leave in front of your osteotomy, not like this. This is the wrong direction of the implant. So in UCLA, there was this guy called Joseph Kahn. You know him, definitely. He did this study in 2012 about immediate extraction cases, where he got 2 groups in which he extracted teeth, placed the implant in the right position, leaving the gap, filling the gap with a bone graft biological material, and taking CT scans, and after 1 year, taking other CT scans after loading. And on a special software, he had marcations from the head of the implant along the long axis of the implant. And what he found that after 1 year of loading, even when you place the implant in the proper position, filling the gap, leaving the distance, all that stuff, you still have around 1.2 to 1.5 of labial bone loss. And where is this area? Again, it's at the head of the implant. Head of the implant where all the problems happens. So again, by default, whatever you try to do, you're still gonna get remodeling and bone resorption. And the pattern of resorption, as you all know, it's more towards from the buccal going towards the lingual or palatal, and then it starts going along the long axis of the implant. You leave this, you continue like that, you get bone resorption and loss of the labial plate. So coming back to the gap, if we're placing the implant like this and we're leaving 1.5 millimeter the gap, filling it with bone, and we have the labial plate less than 1 millimeter, so what's the diameter? and we have labial bone thickness less than 1, labial loss with the graft around 1.2 to 1.5. So your gap that you have to leave in front of your implant should be more than 1.5. So this will dictate you, according to the socket size, what diameter you should use. So the implant diameter, for example, in an upper central, if we have all these factors, we have to use implants less than 4 millimeters. What about the buccolingual dimension? That's the mesiodistal, we know that. The buccolingual dimension. In a central, we have a buccolingual dimension around 7 millimeters, while the mesiodistal dimension is around 9. If I place something like a 5 millimeter here, 5 millimeter because I want to leave like 2 millimeters and 2 millimeters from the adjacent, imagine placing a 5 millimeter in a buccolingual dimension. You're not leaving any gap. So the concept of you have to leave at least 1.5 to 2 millimeters from the adjacent teeth does not apply in this. What applies is you need to leave the gap around 1.5 to 2 millimeters in front of the implant itself. And accordingly, you have to choose the right diameter of implant. Now, one of my friends, Howie Gluckman from South Africa, had this interesting study about how to guide you to place or to initially drill for your implant inclination, angulation, according to the anatomy of the buccolingual dimension and where your root or tooth that will be extracted. We have different configurations, as you can see. When you have different configurations, if you have like this configuration, where you have like 1.5 to 2 millimeters labial plate, and the palatal is like 2 millimeters, where do you start your initial drilling? When you have cases like this, so he categorized it and classified it as a guideline where to start your penetration or initial drilling for implants. Let me show you one of my cases or several cases. These are the cases. The top two are what we want all the time. When you're immediately extracting, immediately placing implants, these are the top two that you need. Because when you look at the palatal triangle of bone, this is the amount of bone that you need to stabilize your implants, to the extent that sometimes you can actually immediately temporize non-functionally these implants. These upper two. Look at this lower right one. Look at the buccolingual dimension. Very thin labial plate, very thin palatal plate, very narrow buccolingual dimension. When you look at this part here, look where the root is. Almost with the labial plate. You can't really see it from the CT, it might be ankylosed. So in these configurations, it dictates you what to do. Like for example, if I'm doing this case, and in this case I did it, I would rather not remove this tooth, because if I extract it, what am I gonna do? I'm gonna remove the labial plate. I'm gonna lose this labial plate. So maybe it dictates me to go to the technique of socket shield. You've all heard about socket shield or root membrane, whatever you want to call it. That you actually dissect or split this root into half, you remove the palatal part, some preparation of the labial, and then you place your implant in the proper position and fill bone in this area, and you've left the labial plate attached with the periodontal ligaments to the labial plate. This is like tricking or deceiving the body that you haven't extracted anything. The root is there. The periodontal ligaments is there. It's attached inwards to the labial plate. And therefore, you're preserving the labial plate. In this case here, when you look at it, look at the buccolingual dimension. Let's first take the one I'm talking about, socket shield. In the aesthetic zone or in implant dentistry, we try to use all the technology available, all the tools available. I'm a prosthodontist. I'm doing guided, I'm doing CAD/CAM, I'm doing freehand, everything. I'm using all tools available in my hands to get the best outcome I can for the patient. So cases like this is the case, exactly what I'm talking about. Instead of removing this, we're going to do a guided socket shield. This was 8 years ago. It was my first guided socket shield that I actually scanned, milled. I know where I'm gonna split this root exactly, removing it, placing my implant, guided, and immediately milling my temporary restoration. After scanning, after placing the implant, defining the emergence profile that I want. And most of the time when I'm doing immediate, non-functional temporization, I don't use acrylic. I don't use PMMA. Most of the time now, I try to use either the zirconium or Emax because it's better for the tissues around it. It heals better, it's better for the tissues. From here to here. Let's take another case. Look at this patient here. She came to me, she's 26 years old. She has her natural tooth. You can see there is resorption, internal resorption, and the root is there. And the root is almost with the labial plate. So again, this dictates you, would you extract this root and take the risk of fracturing or removing part of the labial plate, or will it dictate you to go again to the technique of socket shield, for example? As you can see, this is how she came to me. She had this tooth here, as you can see, have internal resorption, extracted, did my socket shield, placed my implant. Here is my socket shield or root membrane attached to the labial plate, place my implant, place bone, and then placing this same natural tooth, just bonding it, not immediately loading, just to keep the architecture and look at the interdental papilla between it. I don't want to disturb this architecture. I want to keep it for the final restoration. Here's my implant, my root, as you can see. Now CAD-CAM, the same thing. I do scans. In this case, I do a zirconium milled abutment on a tie base, and then another zirconium full anatomical zirconium on this zirconium cemented. So it's screw cement. And with this type, this zirconium milled abutment, I can decide where the margin of the crown is going to be. And when it's zirconium, as I said from the beginning, this area, I design the emergence profile. It influences this area, the shape and the quality of the soft tissue. There is my temporary. This is the temporary on the implant, CAD-CAM, and here is my full anatomical zirconium at the end. Look at the quality of the soft tissue around it. Look at the interdental papilla between the central and the natural central and the implant. Same level of venous. And this is the case after 3 years. So, as I said, all the tools you need to implement in your practice to get the best outcome you can. This is the case I showed you from a while. If you remember this root, we have an infection, very thin labial plate, very thin palatal plate, very narrow. Cases like this, we know from the beginning, from the CT, I cannot extract and immediately place an implant. So now I decide to place bone graft and prepare this site for a future implant. And if I need to do any soft tissue manipulation from the beginning. And since at the end, it's a very narrow buccolingual dimension ridge, maybe here I don't want to do it freehand. I want to place it guided to leave at least 1.5 millimeters in front of the implant. So designing the guide on the software, where I want to place the implant, everything. Here is the extraction. You can see post and core extraction, fractured root. Fractured root, atraumatic extraction. And you would realize in most of my cases that I'm showing, I don't open flaps. I'm minimally invasive whenever possible. Because definitely there are other cases you have to open. Minimally invasive, atraumatically extracting. What am I going to do? I'm just going to do a bone graft inside the socket, and I want to seal this socket. So how to seal it if you don't have an implant to seal it with? So either you can use soft tissue graft from the patient as a free gingiva graft, as a connective tissue graft. Some patients don't want to touch their palates. Or you can use what we call a dermal matrix. This dermal matrix is an allograft from the same species. Okay, so I placed the bone, sutured this, and placed a temporary cantilever CAD-CAM next to the adjacent tooth, which was root canaled. And now you can see the amount of soft tissue. From the beginning, she had very robust amount of soft tissue, good quality soft tissue. Look at the occlusal view here. That's where it healed completely with good height of soft tissue. Now comes the part where I designed the guide, milled the guide in-house. What do? I remove part of the epithelium. As you can see here, I'm just removing part of the epithelium. I'm de-epithelializing. And then the underlying part of height of soft tissue, I do what we call a roll technique. This roll technique. So I can actually, you can see here, this is connective tissue. Instead of throwing it away, I'll just roll it and place it in a small tunnel here. And then I place my guide, I drill. And then I place my implant, tie-base scanning, immediate temporization. This was with PMMA. As I said, nowadays I like to do it zirconium, immediate zirconium or Emax. Look at the quality of the soft tissue around the implant. Doesn't look that nice, the cosmetics of the teeth, but now I'm still developing the soft tissue and the architecture. Now after 3 months of loading non-functional, I remove. Now you can see the soft tissue and the thickness that I have. So now I do 2 other temporaries with Emax and leave them for another 6 weeks. These are temporaries, Emax stained, you can see that. Look at the soft tissue around the implant and the natural tooth. Now after another 6 weeks of healing with these 2 new Emax temporaries, I remove, and now I want to capture this tissues, this part, which we call the subcritical area. This part here, which you see, junctional epithelium to the head of the implant. This is junctional epithelium. This is called a subcritical area. Why? Because it's very critical, this area, the design of your emergence profile, or supracrestal area. Now I want to capture this, and I want to do it digital again. So I scan it to capture all this information digitally, and now I implement microsurgery. Now I'm implementing microprosthetic design on the software, how I want my emergence profile. Another friend of mine from Spain, Ramon Gomez Mida, came out with this study with Marcus Blatz in the States, showing that from the head of the implant, this emergence profile has different zones. And each zone, depending where this emergent profile comes from down upwards, has an influence on the soft tissue around it. As you can see here, we want to capture this. You look at all this, depending where you've placed your implant, depth. And that's why most of the time now we try to place our head of the implant subcrestal. You all know this, at least 1.5 to 2 millimeters. Why? Because you want this height, this emergence profile that you want to design very smoothly, not to impact the soft tissue around the implant itself. So there is a crestal part. This is where the implant is. This green part is the subcrestal part. And then we have the biological part and then the etheric part. The design is always like it's a concave. It's never convex. When you have height of soft tissue above the head of the implant, when you have the head of the implant subcrestal, you give enough height for this emergence prosthetic profile to come smoothly without pushing or stressing the soft tissue. So now after this, again, scanning the implant, capturing, you can see up here, this part for the emergence profile. I start milling. This patient was traveling. I had to do the implant immediately, the crown on the implant immediately, and she wanted to do some crowns and veneers in the upper anteriors, the upper central and laterals. So she stays outside after I prepare, scan, design on my software the emergence profile, how I want it according to each zone, according to the height, and do my milling. These are the Emax try-ins, and then after they're crystallized. Look at the implant. Look at the soft tissue around it. Look at the stippling, how stable it is. Did I do anything in the soft tissue? I didn't do anything. She had this good quality soft tissue from the beginning. All I did is preserve this area, preserve the architecture. I just preserved and prepared the site for the implant. But I prepared it properly, and I took my time. This is how we started. This is after around 8 years. This is after placing the implant, the crown on the implant. This is 8 years post-op. You can see the amount of bone in front of the implant. Can I have done this freehand? Anyone who is experienced can do it. But there is a risk in this buccolingual dimension to do it freehand that you might go more buccally. And you'll end up with very thin bone. You'll get bone resorption and recession.
5 minutes.
Oh, really? Okay, then عندي حالة طب. So anyway, we need to do a lot of things to come from here to here. Let me go to another case. معلش ممكن تديني 10 minutes? Okay. هو في محاضرة بعدية؟ طيب اللي عايز يمشي يمشي. Okay, ما عنديش مشكلة. Just gonna give you 2 more cases, please. Now digital workflow, soft tissue bone grafting. Look at this case here. I take my CTs, look at the soft tissue, CTs showing where the missing are. Very thin labial, buccolabial, buccopalatal, around 3 millimeters, around 3 millimeters. Very thin. Would you place an implant? No. You have to prepare the site. You want to graft the site, not vertically, but horizontally, bone grafting. So decided to 3D print this defective area. That's the ridge itself, incisive foramen. 3D print it. 3D print the lower jaw at the external oblique ridge because I'm going to harvest bone from this area, digitally guided. I'll go fast with the surgery. So I go in the lower using the piezo surgery. I remove a piece of block, what we call, everybody knows it, the cortical shell or Khoury technique. I'm going to go fast. So I'm placing my guide, which I actually know how much of the bone I'm going to take. And now I'm scraping the bone, cortical bone, to get some more autogenous bone. Just go, there is my part. I split this bone into 2 pieces, so I have a buccal and a palatal, and I have to screw them inside for the defect and then place the autogenous bone that I have collected or scraped from this piece of bone, as you can see here. Buccal and palatal. And then the bone particles, I place it in the spaces in between. Okay? So this is how it is. We remove the piece of block. Screws, I'm stabilizing the guide with a screw, and I have the occlusal tables of these teeth to stabilize it using piezo. I remove this piece of block. You can see cortical, some cancellous. I take some scraping for autogenous chips. I split it in 2 pieces, one for the buccal, one for the lingual, screw, fixation, palatal, and buccal. These gaps I fill with this autogenous bone, and I suture. Now after 3-4 months, I know this is autogenous bone, I have bone. Now I want to place the implants. And now it's the full guided workflow. So I do it guided. And remember one thing, guided surgery, it's useful. But remember that we, as dentists, guide the guides to guide us. It's very important. So in other words, what is guided surgery? What does it do? It correlates the anatomy of the ridge to the future teeth. And that's why guided surgery gives you the maximum precise point of entry where the implant should be according to the teeth aesthetically and functionally. So we're really looking inside without seeing it. So now I open a flap, I remove, look at the bone quality. Here's my labial plate, which I placed, and the palatal in between, it's all bone. I remove the screws, now my guided. That's why it's very important when you're planning with whomever is doing your guides, you have to interfere. Because if you leave a dentist in my office to do this guide, you'll see what happens. It has to be properly designed, properly planned, and properly produced, and milled or 3D printed, whatever you're going to use. Now I'm using the system, I place my implants. Look at this. I have enough like 1.5 to 2 millimeters, but look at this one, where it is. And it's guided, although I have a lot of bone in this area. So now I have to overcompensate, closing. After 2 months, I don't open a flap, I just open and I do some roll technique to give some thickness around this implant. Can you see the amount of thickness here now? To compensate for the misplacement in a proper dimension. And that's the temporary and the final. I'm going to go to the last case, if you want to see. Now it's full arch. Immediacy. Cases like this, what would you do? Now everybody now you see on Facebook University and Instagram University, where everybody's learning from this 2 social medias. Everybody's doing what? All on X, full mouse, extract and place. We don't extract. We extract when we need to extract. I'm sure all of you have seen cases which you have the teeth, they might need just some crown and bridge, conventional orthodontic work, and they extract. And then they reduce the bone, they remove the bone to place the implant in a proper platform. And then they do what we call an FP2 and FP3, which you don't use. Look at this. It needs to be extracted. Look at the CT. We have some infections, bone loss, lower bone loss, mobility, but I have some soft tissue. I have bone in the upper. Am I going to remove bone? No, I want to keep and preserve this architecture. So now I start planning. What do I do? Full mouth immediacy. How to do it? In one visit, I'm scanning the patient and taking a CT. And now on the CT and the software, now I want to start placing where exactly I want to place my implants, in which areas. I'm going to extract everywhere. Where exactly when I place the implant, where am I going to place my multi-unit abutments? Because remember one thing, it's one visit, the next visit is a surgery, and immediate temporization, pre-milled. I'm not going to place the implants and then scan. It's already scanned from the beginning. Everything is virtual. So I choose the best options. I don't do these all-on-4 concept. All-on-4, if you lose one implant, you're lost. Minimum 5, 6, 7, wherever I can. So we produce several guides, what we call stackable guides, which go on top of each other to guide us. These stackable guides, we have the base guide, the teeth guide, the temporary guide, the implant guides. 4 guides. And you will see the surgery. What do? I place the base guide with the teeth guide. And the best types of guides are the teeth supported guides, because you all know there are other cases which are soft tissue supported, and it's not that precise. So you can see that's the base guide, and then we fix it with fixation pins, and then we place both together, and we place it and fix it. Now I remove the teeth guide, and I have to, through this base guide, extract properly all these teeth and clean properly. which is challenging to do all these extractions when you have something buccal and palatal like this. Now extracting everything, I don't open flaps, I'm curetting everything. And now with the surgical guide that I'm going to be using for the system itself, I start drilling. Here is just a small video of how to stabilize these guides with fixation pins so it doesn't move. And then we remove this, extract, and then we start our drilling. I'll go fast. Once I've placed my implants in the proper position, I remove all the guides except this base guide. It's always from the beginning till the end there, because this is what guides me in every step. Place my implants. I already from the software know exactly what type of multi-unit abutments I'm going to use, what height of the cuffs I'm going to use, where I've placed the head of the implants exactly. And now I pick up my titanium sleeves, placing a rubber dam, picking up the titanium sleeves. How? I place my temporary full arch in the guide, place it, which is snaps on the base guide, exactly where I am, and then I pick it up with flowable composite. And this is how it is, immediately. Did I take any scans? Nothing. It's just day one. Scan of the natural teeth and a CT, and everything is done virtually. Extraction through the guide and all this takes 1 hour. This prosthetic procedure takes 3 hours. Orthodontists understand this. The most challenging. It's not an easy procedure. Surgery is easy. Prosthetics, 3 hours to do just one full arch. Now going to the lower, the same thing. I'll go fast, the same concept, the same way. In this case, since we had so much bone resorption, this is what we call an FP2, because there is loss of bone. You're restoring not just the teeth, but some tissues, bone and soft tissue. Same thing. Extraction, placement of the implant, removing in between any of the implants. If you have some height of bone just to fit the temporary, you remove it at this stage. Place the implants, the multi-units, the same concept. Picking up everything, and at the end, finishing and polishing and smoothing this fitting surface completely. You fill all the gaps here, you polish it completely for the soft tissue and proper hygiene. As you can see here, I'm finishing. This is the patient after maybe 6 hours. It's not easy cases, not one of my favorite everyday case that I love to do, no. I prefer one to some soft tissue, you know, but these are very challenging at the end. So we start like this and we end up like this. Thank you very much for your kind attention, and I hope I didn't take too much time. Okay. Appreciate it. Thank you very much.
This is a small appreciation for your kind, informative lecture. Thank you so much, Doctor.